Gentlemen, authorities, students, virtual audience, good morning to all. We would like to inform that this ceremony is being recorded and streamed to our channel iea.usp.br. We are going to open the international conference, the second webinar of the series, Brazilian pandemic. It's not only a viral event. We're going to have an international outlook on how we can share the papers of researchers looking at social and human sciences. We seek to deepen the information that has been produced in a multi-stakeholder approach, including scientists, authorities, managers that wish to strengthen our unified health system and the different communities in their social response. In this virtual panel, we have Professor Dr. Vahana Gopian, Dean of the University of São Paulo, Professor Carlos Gilberto Carlotti Jr., Pro-Dean in the postgraduate courses, Professor Rosalie de Deus Lopes, Deputy Director of the Advanced Studies Institute at the University of São Paulo, Professor Marcia Castro, PhD, also member of the consulting committee of the Brazil Studies Program faculty, and also with the David Rockefeller Center for Latin American Studies, Professor Lorena Barberia, Professor of the Department of Political Science of the University of São Paulo since 2015, also Chair of the local committee of IPSA USP, University of São Paulo, Summer School in Concepts and Methods in Political Science and International Relations, and Professor Vera Paiva, full professor of the Department of Social Psychology of the Institute of Psychology of the University of São Paulo, and Lancet Mission Health and Human Rights, founder and coordinator of the AIDS Prevention Center at the University of São Paulo. We will now hear the coordinator of the event, Professor Vera Paiva, for her opening remarks. Professor Vera.
Good morning. I will speak in Portuguese. Bom dia a todos e todas e todes.
Good morning to all, and welcome to the second seminar with the theme, the COVID-19 pandemic is not just a viral event. I would like to begin by thanking Lorena Barberia, a colleague of the Political Science of the University of São Paulo, and Marcia Castro from the Harvard School of Public Health, and the support of David Rockefeller Center from Harvard School in organizing and putting together this event. I should underscore that this conference has been produced primarily by women. I'm very grateful for their efforts during their holidays. They serve governments and international agencies and are researchers in different fields that think and co-produce social responses to the pandemic and who have actually responded to our invitation. And I believe that we are all fully aware, as says Paulo Freire, that there is a need for a global and articulated response to this health and humanitarian crisis. I also believe that we share a great concern with the unexpected control of the Brazilian pandemic, reaching 500,000 lives, with a very high toll that has bereaved thousands of families. We're also concerned about the future for the youth that have been working in the outskirts of our cities, and the recovery, the post-pandemic recovery, and of course the need to tend for millions of orphans from the COVID-19 pandemic who have been feeling its effects in their bodies and souls. As a researcher in social psychology and preventive medicine, I have experienced intensively the first years of AIDS. I was part of the network of researchers, health professionals, and community leaders. Social movements co-produced a Praise Brazilian response much faster than in the experience with HIV. In the outbreak of COVID-19, it became clear this is not a viral event, and we have validated the multi-stakeholder and intersectorial response to the pandemic. COVID and AIDS were similar at the start in the irrational, the denied science, and the first effective response that sought to test and care for the infected people and encourage education for social behavioral prevention in the psychosocial experience of fear that deepens the denial of risk and stigma associated with people, and also with protective inputs such as condoms and masks. Once again, the misuse of the notion of risk groups from the start revealed once again that social inequality is a determinant for individual and collective health. There are relevant differences between both pandemics, one being that we still do not have a vaccine for AIDS. In terms of access, as we discussed in the last seminar last June, well, there are many other differences which cannot be discussed in this conference. Differences and similarities. But since we are in Brazil, I would like to emphasize one of difference which actually makes us have a firm commitment to all of these seminars. When it comes to the audience and participants that will replicate over time, thanks to the simultaneous interpretation, we can bring to the discussion researchers, physicians, and researchers that are aligned with this perspective, looking at the environmental crisis that is also key for this and other pandemics, as will be discussed further. We have produced a high amount of evidence on how the social, cultural, and political context and conservatism and authoritarianism, and these are the differences I'd like to highlight, produce the destruction of public policies and hypopandemic and hamper human rights, and of course aggravate social problems in Brazil. There's much we have learned as to how we can use health programs to mitigate inequity, inequality, and access to prevention, care, and still in context of severe poverty and unemployment, sexism, and racism, of course, produce neglect to health and denial to health and life. I would like to thank all of those who will share their research with us, their papers, in seeking to produce social cohesion and to produce change or sustain public policies to control the pandemic with the collaboration of communities and those who have been mostly affected. Community participation with lower investments than we should be seeing, and more important than ever, especially considering the tragedy we've been facing in Brazil. In the case of Heliópolis, who are joining us today, patient healthcare should belong to all or to none. I wish you all an excellent day and an excellent week. Thank you, Professor. We would like to point out and thank the following authorities: Mike Ryan, Executive Director of the WHO. Dr. Ryan has been managing health risk for over 25 years and is the Executive Director for the Emergency Health Programs at the WHO. Ed Garcia from the Peruvian University of Washington, former Minister of Health in Brazil. Jarbas Barbosa, Director of the Pan-American Organization of Health, PAHO. Carlos Lula, Secretary of Health in Maranhão, and President of the National Council of Health Secretaries. We would now give the floor to Professor Lorena Barberia, Professor of the Department of Political Science at the University of São Paulo, and she's the scientific coordinator of the Solidarity Research Network on COVID-19.
Welcome to everyone joining us. really wonderful pleasure to be joining Vera Paiva and Marcia Castro, with whom I've co-organized this event. And it's an incredibly important event, the second event that we've held, trying to promote the discussion of the pandemic is not only a viral event. Through these events and through the work that we've sought to undertake across the last year and a half of the pandemic, we've tried to encourage a discussion within the university and across Brazil, and now for the first time internationally, that in order to understand the pandemic, we need to embrace and discuss the impact across disciplines, and also academia, dialoguing with those at the front line, those that are in policy positions and in leadership positions in our society, across different sectors and across multiple different areas, but also thinking about engaging the most vulnerable and those whose voices are often not heard during this pandemic. And that's been a strong commitment that we've had in organizing these events. And today it's really important that we're here broadening the discussion to highlight and to bring together international perspectives about many of the common challenges we face across the globe, but also what are specific to different contexts and different countries. And so it's a tremendous honor, and we're very, very excited to welcome all of you. And I just want to thank very much the David Rockefeller Center for Latin American Studies, who has generously provided the simultaneous translation for this event and has been a really wonderful co-organizer of this initiative. Thank you to everyone, and thank you also to Marcia for all of her collaborations with Brazil since the pandemic has started. It's been very important to count on your support and your work.
Thank you, Professor Lorena. Agora ouviremos as palavras da professora doutora Roseli.
We will now turn it over to Professor Roseli, Deputy Director of the University of São Paulo, Institute for Advanced Studies. Good morning to all. It is a pleasure to be here. On behalf of the Institute of Advanced Studies, I would like to greet you all, our special guests, our speakers, and authorities, and our virtual audience, Professor Vahana Gopian, our Dean, Professor Carlotti, our Pro-Rector in postgraduate courses, on behalf of whom I would like to greet all of our colleagues from the University of São Paulo. I would also like to greet the present authorities and speakers of the event, and Mr. Michael Ryan from the World Health Organization. I would like to greet all of you who will be here today and tomorrow with us. Professor Marcia Castro. I'd like to thank the Harvard University, Rockefeller Center, our gratitude for putting this event together, such an important debate at many different levels. I would also like to thank Professor Vera Paiva, Professor Lorena, for all of the events they have been organizing, and especially this event we are opening today, 2-day event, full days. The IEA is once again bringing relevant debates to the table, not only for Brazil, but at a global level, with an interdisciplinary, multi-stakeholder approach and debate that will show us how to move forward and tackle so many challenges. Thank you once again for this opportunity and for attending this session. Thank you, Professor. And now we will give the floor to Professor Carlos Gilberto Carlotti, Pro-Rector of the Postgraduate Courses of the University of São Paulo Fellowship Program.
Thank you, Sylvia. I would congratulate Professor Lorena for the to organize this meeting. and also Professor Guilherme, Professor Varran, to support the event. At the beginning, we thought that COVID-19 was just a disease. So our problem should be only health. But now we see that COVID-19 was only a disease. It showed to us that our society has many problems, much bigger than a health problem. We have social problems, we have ethnic problems, we have so many problems to think about when we see the COVID-19 in our society. So the challenge now is to change our society, not only to talk about COVID-19, but we have to change the way we deal with our social problem. So Lorena, thank you very much for the invitation. I hope you have a very nice meeting with very nice discussions, and we should also change the graduate studies in our university based on what you discuss in this event. So thank you very much, Lorena.
Thank you, Professor Carlotti. Now, agora anunciamos as palavras do professor Dr. Varran.
And now we will give the floor to the Dean of the University of São Paulo, Mr. Varran Agopian. Good morning to all. Good morning, ladies and gentlemen. It's I'm honored to be here. It is a privilege for the University of São Paulo to host this event, this debate about the pandemic on a broader level. I would like to thank our supporters today, Harvard T.H. Chan School of Public Health, David Rockefeller Center for Latin American Studies, and the organizers, Vera Paiva, Lorena Barberia. Thank you for putting together this international event, Marcia, and we will have the opportunity to hear speakers from 14 different countries and to exchange information. Once again, I would like to welcome our speakers and thank all of our speakers, and to say that, well, activities like this are becoming ever more important, because now with the growing number of fake news everywhere and misinformation, universities, the academy have become a reliable source for the society when it comes to sharing and spreading information. Therefore, it is key for universities to actually carry out such discussions and to produce information about the pandemic that is reliable and trustworthy. I wish you all a wonderful event. Thank you. Thank you, Professor Agopian. And we are now going to close the opening ceremony. The University of São Paulo would like to thank you all for attending, and we wish you all an excellent seminar.
Okay, everyone. So good morning, good afternoon, good evening. I'm Marcia Castro from the Harvard T.H. School of Public Health, and I'm really honored to have organized this event with Professor Vera and Professor Lorena. So we're gonna go ahead and get started with our first session, and it's our great honor to have Dr. Michael Ryan, Executive Director of the WHO Health Emergencies Program. Dr. Ryan has really been at the forefront of managing acute risks to global health for nearly 25 years. He served as Assistant Director General for Emergency Preparedness in response to WHO Health Emergencies Program from 2017 to 19. He has worked in conflict-affected countries, led many responses to high-impact epidemics. He's a founding member of the Global Outbreak Alert and Response Network, which has aided the response to hundreds of disease outbreaks around the world. He served as coordinator of epidemic response, operational coordinator of WHO response to SARS, and WHO director of alert and response. He completed his medical training at the National University of Ireland, a master's at the University College of Dublin, and a specialist training in communicable disease control at the Health Protection Agency in London and the European Program for Intervention Epidemiology Training. Above all, Dr. Michael Ryan has been one of the faces of this pandemic, not shy of words of calling people when they're doing the wrong thing, which I honestly truly appreciate. So it's our great pleasure to have him here to have a conversation about many different aspects of the pandemic, aspects that we're going to go in depth during today and tomorrow. Mike, I'm going to start with a topic that I know it's close to your heart and you've been fighting this. So we're going to start with infodemics. So this is one of the most challenging problems, not just for this pandemic, for public health broadly. And I wonder if you could say a few words of how WHO has addressed this issue and how different actors in society, and you know, you can use Brazil as an example, but more broadly, how different actors can contribute to reduce infodemics. And for some countries, this is particularly tricky. If you think of Brazil, the federal government is the first one spreading wrong information and denying science. So I would love to hear a few words from you on this topic.
Great. Well, thank you, first of all, for the invitation. It's great to be with you all today. And my regards to all our colleagues around the world, and particularly to you in Brazil and in the Americas. Yes, you are right. The information overload, and it's both good and bad information. The difficulty is that people find it very hard to sift and separate the good information from the bad information. And really what helps people do that is trust. In the end, at the end of the day, the information itself doesn't change behavior. If you trust the person giving you the information, if you trust that information is in your best interest, then you will act on it. And I think that's really the deficit we're dealing with, not a deficit of information or even good information. We have a trust deficit between people and governments, between governments. And it's at all levels, as you said. It starts very much at the community level and expands and becomes even more difficult as we move up. But this is not a new phenomenon. Speakers have introduced this conference have spoken about HIV. Tuberculosis in my own country was a massive source of stigma, a massive source of misunderstanding, families ostracized and pushed aside from society. In the past, we've seen this. It's not a new phenomenon. People fear contagion. We fear infectious diseases. We're programmed to fear infectious diseases because we want to avoid them. The difficulty is in a situation of charged emotion where information is not perfect, where we don't fully understand what's going on. You have to trust the system to give you the information that you need. We've not been particularly effective in doing that in this pandemic across the board. And what that gap and that vacuum has been filled with misinformation, leaving people very exposed, not just exposed to the virus, but exposed to poor information. And it's something we need to do better at. We're trying at WHO through our infodemics approach, through our EpiWin network, through our collective service for community engagement. But everyone is struggling to do this. But I would just say, Margaret, that for me, we can do better at information management. We can do better at giving good information. But unless we bridge the gap in trust, then it's very difficult. And if people and communities have been left outside the system for decades, and the only time they see the system is when the system is coming to ask them to do things that they don't fully understand, then how do we expect people to react? We leave people outside the health system, we leave people outside the social system, we leave people outside the economic system, and then we expect them to behave perfectly when there's a crisis. And many people in poor communities look at us and say, what crisis? Our crisis has been going on for generations. This is your crisis, not our crisis.
Yeah, I think you raise a really important point. In Brazil, we commonly say that we have an invisible population, and those are the most vulnerable. And unfortunately, this population only becomes visible every 2 years when we have elections, because elections are mandatory in Brazil and the politicians give their vote. And then suddenly they become visible, but the problems are there all the time. And I think there's another aspect regarding trust, Mike, which is, and here I think all academics have to do a mea culpa, which is we don't really do a good job communicating uncertainty. And in a pandemic of a new pathogen, that the knowledge is being built as we go. And I think WHO suffered from that with all the discussion about masks and then the issue of ventilation and aerosols. The knowledge is coming. So the message can change because, one day we know more than the previous day. So can you just say a few words about this? About, sometimes you give a message and then you give a different message just because you know more. And again, I'm doing a mea culpa here because I think we still have to learn how to communicate uncertainty, and that can ruin trust.
Yes, I think that is true. But communicating uncertainty needs to be done with that sort of included in the message itself. So it's very important that scientists, when they are looking at data and looking at their analysis and their public health advice and policy, is to communicate that uncertainty. People aren't stupid. People are smart. They're much more believing of someone communicating uncertainty, but giving the best possible advice that they can. I would say, though, in this case, and certainly over the last year and a half, we've also seen a divide between science and policy. And that's where I think it's been quite difficult for communities, because we've seen quite public battles between the public health of the science community and very often government and government policy. And that has caused difficulties as well, because very often the public health community is trying to communicate uncertainty, but at times that our capacity to influence policy and the capacity for science to drive policy has been compromised by the politics of the situation.
Right. So another issue I would like to raise with you is the whole issue about universal health systems. That's one of the sustainable development targets of the goal for health. And right before COVID, so towards the end of 19, there was this global health security index that was put together, and it ranked countries such as the US, the UK, and Brazil very well positioned to respond to a new epidemic, a new pathogen circulating. In the case of Brazil, one of the factors that really positioned Brazil well was a universal health system that is, recognized internationally as being really good and as being resilient. So this concept of health system resilience didn't really not hold during this pandemic because it was not shielded from a bad leadership. And we have many different examples. Brazil is just one of them. So I wonder if you could share your thoughts on what is the possibility that we can find ways of revisiting this concept of health system resilience and really shield health systems, but also public health institutions from bad leadership?
Well, I think what this pandemic has shown, and it's a bit like the 100-year or the 1,000-year storm, buildings are constructed in earthquake zones to resist a certain magnitude of earthquake. Not every earthquake, but for 100 years or for 200 years. And health systems are constructed in the same way. Health is seen as a cost in the system. Many health systems around the world, while very good, are run at very, very low margins. They're run really on 100% of their capacity most of the time. The engine is running at full capacity all of the time to meet the health needs of populations. But there are huge inequities within that. And when people say we have a great universal health system, you go below the national level, go down to the state level, go to the local level, and you find that breaks down. And I think that's what we found all over the world, that the health system is not the same in all parts of any country. Therefore, there were weaknesses in all systems, and those weaknesses were greatest in areas of poverty, greatest in areas of social exclusion, which is not unexpected. I think the other thing, and you mentioned all these measurements and index and external evaluations and global health security index, I think you mentioned, many of those assessments are counting things. You know, they're looking at the system and they're counting how many doctors, how many nurses, how many beds, how many hospitals, how many laboratories. So it's a very static measure of capacity. It measures the infrastructural and workforce capacity. What they don't and didn't measure, I think, adequately was the decision-making capacity of the system, those dynamic parts, the trust part of the system, the governance part of the system, and how governance will interact with science and policy. And when you look at that, these intangibles, hard to count and hard to measure, the performance of the system. So if you look at an athlete and you can judge the athlete as so many feet tall and they can run a certain distance in 100 meters and they're extremely fit, but will they be okay during a football match where they have to be dynamic and face an opposition where the tactics change and the situation changes? And I think that's the difference here, is that we were looking at the physical attributes of our system, not at its strength and conditioning, not at its adaptability, not on its ability to cope when the system started to collapse. Complex systems fail in very complex ways. No more than when 50 years ago, when your car broke down, well, you had a hammer and a wrench and you got out and you banged a few things and you could get the car going. I'm sure in Brazil, people were used to that in the past, like in my country. Now you open the hood of your car and it's computers and you can't do anything. Once the system fails, you can't fix it in real time. You've got to go and get help. So I think we've built complex systems that require huge amounts of investment in resources. They're not very flexible, and they don't adapt well in failure. And all systems fail at one point. And the real question is, as a system starts to fail, are there fail-safes in there that allow the system to cope? Can you move staff around? Can you change people's post descriptions? Can a nurse become a doctor? Can an anesthetist become an emergency physician? Can a renal physician become an infectious respiratory physician? Are we able to move our resources around? Are we able to manage clinical pathways? One of the big challenges in SARS-CoV-2 and in COVID is that a very small proportion of the population do very badly when they get infected. And most people do okay. And the real trick is getting those people who are likely to do badly into the system quickly and get them in front of a qualified physician and nurse at that very moment when they're likely to desaturate, their oxygen is likely to go off. And can you support that patient through that critical period? Too many patients did not get to that care in time. They couldn't enter the system. The system wasn't able to sort out the very sick from the somewhat sick from the not so sick. And the systems become overwhelmed very quickly. So a lot of this has been about the dynamic capacity of the system to change and cope and move resources around. And I don't think we've measured that adequately, and I don't think we've invested in that. And that's what you call, I think, resilience. It's not just resilience. Resilience is the ability to be hit and absorb the punch, but it's also the ability to dodge the punches and move away from the punches and avoid the hits. And I think that's, for me, resilience is a bigger concept. And we haven't thought enough about the flexibility and the adaptability part of the system.
Yeah, I mean, what you just said is music to my ears, because in full disclosure, I'm very skeptical about any of those indicators, because usually they're constructed based on what is available, not based on what is needed to go in there. They have nothing about quality. So as you said, they can look really great, but can they adapt? Can they respond if one of the components of those indicators fail? So I don't believe in any of those indicators, and I don't believe in any of those beautiful reports that come after a pandemic telling us what to do next to avoid the next one. So we have way too many of those. I hope we're not going to produce like rivers of those reports in the coming months, because I don't think that's necessarily what we need. So I want to follow up what you just said with another question, which is we're probably facing a scenario where the demand for healthcare is just going to increase because of long COVID. And we don't even know exactly the full spectrum of demands that we're going to have because of the conditions associated to long COVID and for how long they are going to last. We have pretty solid evidence from different studies showing the decline in life expectancy at birth. So it's about 1.5 for the US. We did a study showing 1.3 for Brazil with huge inequalities regionally and across race, ethnicity, and levels of education. So do you think that because of long COVID, we are going to take some time to go back to pre-pandemic trajectories of increasing life expectancy? So US is not a good example because they had stalled because of opioids and all of this. But Brazil was gaining about 0.5 years of life expectancy, so a couple months over every year in life expectancy, and many countries are having gains annually. So is it reasonable to think that this trajectory that we're seeing, this trend, is going to slow down a little bit because of many things, but one of those things associated to long COVID, which is still sort of the big question mark in the room in terms of severity, composition, and how long it's going to last?
Yeah, it's a very, very good question. And certainly the long COVID condition, as you said, we don't fully understand. It's an array of different conditions, be they neurologic, be they respiratory, cardiovascular. So there are different impacts on people, as you know. And those studies show, depending on how long people are followed for, and again, the follow-up periods are not standardized, so the percentages change. If you follow people for 6 or 8 weeks, you find up to 30% of people still have significant symptoms. If you follow people for 3 or 4 months, that drops maybe to 10 or 20%. And the range of symptomatology is very varied. It's generally mild, but there are people suffering severe long-term consequences. I think in Brazil, now you're approaching I think about 20 million cases probably in the next week. So that's a lot of the population, and that's underestimating the number of people who are being infected. And we really don't understand those long-term impacts. And, you know, we've seen going back to the polio, we still have polio survivors from polio in the 50s and 60s. And those polio survivors have suffered for a very long time. Their symptoms are, while rare, are very complex and require a huge health system investment to keep people healthy. So there's no question that long COVID is going to have an impact on the health system. It's going to be an extra demand on the health system. But as you said, there are other impacts, the loss in routine immunization, the slowness now in follow-up to cancer care. So the barriers to access to to immunization, to diagnostic services, to therapeutic services is also going to have it's a lag effect, but it's going to be there. The psychological distress, the increases in suicide. We really, this is a major shock to our system. It's also the socioeconomic distress is also going to have a long-term impact because, as we know, the economics of income are going to ultimately affect health. We know you know this, preaching to the converted, but 30 to 50% of our health is not actually dependent on health access. It's not dependent on health intervention. It's dependent on the social determinants, the underpinnings of work, of life, of how you're born, where you live, how you work, where you work, all of those different factors. So there's no question this is adding another stress, major stress to the system. And when we look at events, you said those numbers, 1.5 years, it seems like so little. But when you look back in the last century, there were only 2 or 3 events that did that. I think the pandemic of 1918 was the big mortality event. It shifted the life expectancy in the US and around the world. And I think Second World War did that as well. But very few events in the 20th century actually impacted negatively as a whole around the world on life expectancy. So this is huge. Already to have that sort of signal in the system is very worrying. And we've got a health system now that's on its knees, finding it hard to cope and recover. We're not through the pandemic yet, so we're not even, it'd be one thing if we were looking in the rearview mirror and thinking, how are we going to cope with the aftermath? But we're not in the aftermath. This fire is still burning. So we're dealing with the aftermath and the pandemic at the same time. And that's really hard to do in a system that's very exhausted. And I feel for our health workers across the board, from the primary care system all the way through. They've been heroes to us all, but they're exhausted now. The systems are exhausted. A lot of countries, through their revenue streams that support the health system, have been buying forward against future expenditure in the health system. So there's a lot of countries have been paying for the COVID response from money next year in the health system. And my fear is going to be the fiscal squeeze when countries come out of the pandemic and recognize that they've sort of sold the family jewels because they've paid forward all of the costs. And we're going to potentially see huge cuts in healthcare expenditure after the pandemic. At the very time you'd imagine we'd want to be increasing health expenditure, I'm afraid we may be decreasing it because of the way health is seen as an expenditure in most governments. It's not an investment. It's not a strategic investment. It's an expenditure. So I do have real concerns, but I think it can be avoided because that's the downside. I'm one of life's optimists. I think never before has the health of the health system become more relevant, or people are so aware now of how central health is and how central health protection is and how central the health system is to the well-being and security, economic security and health security of the population. And the question remains, what will people do, as you say, when they go back to those elections in the coming years? Are citizens going to stand up and demand that health and health systems and health access becomes a central pillar of our future? I think if they do, and if governments look to invest in health, then I think not only can we avoid the worst outcomes in terms of long-term health impacts, but we can take the next big step forward in health attainment. Because we're kind of stuck. Before the pandemic, we were stuck on the SDGs. We were stuck on many of the health gains. We were kind of doing all right, but we were treading water. We were not making it. We weren't going to make the SDGs, in my view, in health because we were stalling. And that stalling happened long before the pandemic. So the real question, I think, now for society as a whole is a really important discussion society needs to have with itself, and particularly society needs to have with politicians. Where is health in the priority setting in each country and around the world? And I think if we can have that conversation and understand that health is no longer an expense, it's no longer an expenditure. Health is an investment in the security of society. And if we make that decision, then I think we can not only avoid the worst of the outcomes, but we can actually build better health systems for the future. Now, that's the eternal optimist in me, but we have to be optimists and we have to believe that society, people, I believe in people. I don't believe in anything else. I believe in ghosts and I believe in people. And I think we're seeing an activation of society. And yes, we're seeing the misinformation and we're seeing people who, don't want to be vaccinated. We're seeing all of that. But overall, that's good because a debate has started. And you don't always get in a debate what you want to hear. You're going to have people for and against. You're going to have people who don't like what you say and people who do like what you say. What I'm happy for is that health is now being debated on the streets, in the parliaments, in the living rooms, in the bars, in wherever. And I hope that debate can turn into a new day for health systems.
Yeah, thanks so much for saying those words, Mike, because it's amazing to see in Brazil with our universal health system that it's something that was put together by the people. It didn't come from the government, it came from the people, from society. And over its 30 years, it made so many advances in reducing inequalities and in improving health conditions. And now we see people that always criticize the system talking about SUS and thanking SUS and taking the vaccine, holding signs, thank SUS. And it's a shame that it needed a pandemic for the Brazilian population to really recognize the importance of a universal health system. But I'm glad, as you said, the health system is now in conversations. People see the importance of it. And I do hope that next year, people exercise the most important right that everybody has in a society, which is the right to vote, which in Brazil is also a duty, but it's the most important right we have to really voice their concerns and be able to, change the course of what we are seeing. And just a second thing is, thanks for saying you are an optimist. I always tell my students, if you're not an optimist, go to another field. Don't stay in public health, because if you're not an optimist in public health, you're never going to be able to do your job. So thanks for saying that. So I want to follow up what you said on the socioeconomic issues, and I'm going to invite Dr. Carlos Lula, who coordinates the state health secretariats in Brazil, to ask a question. Carlos, please.
Muito bom dia a todos, muito bom dia a todas.
Good morning to all. First and foremost, I would like to thank the organizers for inviting me. We have two different approaches in this conversation. One from Maranhão, where I'm Secretary of State of Health, in the state of Maranhão, and then you also have to look at Brazil. And of course, there has been a very bad example, a very poor example on how to tackle the pandemic. Anyhow, this is, of course, a place that should be studied and understood. Maranhão is one of the poorest states in Brazil. Among the 27 states in Brazil, unfortunately, we rank last, among the last, when it comes to social, economic ranking in Brazil. And of course, we're all aware that there are many issues to be tackled in Brazil, and Maranhão is the same. However, they are amplified, I should say. And when it comes to, of course, fighting the pandemic and debating the pandemic and the socio-economic consequences of the pandemic in Maranhão, would be, well, early on, we, of course, were full aware of the challenges that would lie ahead, that it would be more challenging than in the other states of Brazil. And just to give you an outlook, the government of Maranhão opposes openly and directly the federal government approach. The government authorities, the administration in Maranhão opposes the federal government. And therefore, we have had a different approach to the pandemic from the start. We actually knew of its severity, of the consequences. And today, in a certain way, we have good indicators. We have produced good indicators when it comes to the pandemic. We could have actually been doing very poorly, but no, actually we have some of the best indicators in Brazil. If you look at the mortality rate, it's the lowest mortality rate in Brazil among the 27 states, 3 times lower almost than the mortality rate in other states. And our indicators are doing better than most countries in the European Union, actually. And therefore, this was actually a result of the approach of the Maranhão government from the start, because we were fully aware that it would be severe with severe consequences. And more than that, half of the workforce in the state of Maranhão is informal, half, 50%, meaning that this part of the population have to leave their homes to work every day, day after day, because they do not have working capital. They depend on whatever they sell day after day. And you have street vendors, beach vendors, and informal workers, artists. And these are the people that are most hardly affected by the pandemic because they cannot work virtually, remotely. They can only work in the physical world. And they have to go to work every single day. If they work as a bus drivers and no one's using the public transport system, they will be out of a job. If there's no one out on the streets and there are street vendors, they won't be able to sell their products and therefore won't be able to eat. As Mr. Michael Ryan just mentioned, yes, we have been facing 4 key issues right now. Yes, you have a health problem, and as we all know, the health system is under pressure. There are patients who cannot have access to treatment because of the pandemic, more so in 2021 than 2020, because the pandemic hit us hardest in 2021, and there are surgeries that patients have not been able to undergo. Only 20% of the surgeries were performed, of those that should have been performed this year, because the hospital system was overburdened. And more, you have the health issue and a cultural issue, communication. You can't have 2 different approaches. If the health secretary tells people to mask up, but the Ministry of Health says otherwise, there's a problem. If the president of Brazil opposes what health secretaries are mandating or claiming, there's a problem. The president claimed that COVID-19 was a mere flu. And so there's a clash, there's a conflict in the messages that are spread. And that has been one of the key issues, because it didn't happen once or twice. It has happened oftentimes. People here in Maranhão saying, but the president won't mask up. Why should I do it? The president didn't get a shot. Why should I get a shot? Is it really safe? So you have this ambiguity, unclear messages from the president, and that is, of course, very negative. And therefore, it's a challenge when it comes to tackling the pandemic and to having one single discourse to the society, one unified source of information to our society. You have also mental issues and the mental health of first responders. There are many doctors, nurses, physical therapists that are on leave because they actually face terrible things, and they were also overburdened and burned out. And this is also having impacts in the society. Our mental health services, for instance, has waiting lines that, are unprecedented. Many people now with mental problems during the pandemic, and it's something that we will have to also address for a long period of time going forward. Because, of course, we tackled the 2 key fears. Men fear 2 things mainly, madness and death. I think these are the 2 things we fear the most as humans, and as we can read in the literature. And these were the things we were mostly fearful of during the pandemic. We were afraid to lose our lives and to lose our minds. And yes, we've been under pressure for 16 months. And we know, we're fully aware that it'll be much longer than another 16 months to get out of the woods. And you have the health problem, the mental health problem, the social problem, and one more key issue in reaching the end of my intervention before I ask the questions to Mr. Ryan. We also have the social issues that we're facing. Of course, when it comes to education, students are studying remotely. Starting next week, we might go back to the physical classroom. Still, we have not measured the impact caused by the pandemic on students and on going back to school. We do not know what the dropout rate is yet and what it'll take to have students go back to the classroom. We do not know what the social impact has been for students, for this generation that was away from school, from the classroom for almost 2 years now. So you have educational and social impacts there. And at the same time, we don't know what the consequences of the economic issues will be. Of course, there's unemployment, and we have the highest unemployment rate ever in Brazil. And we do not know, we have no idea how it's been worsened by the pandemic. By the end of this year, we will have a better idea of this scenario, of how it deepened over the last month. So, Professor, I would like to ask you, Mr. Ryan, 2 questions. What will we be facing going forward now with regards to the pandemic, with the new variants? And that has been, of course, driving the number of new cases and deaths. I would ask you to please give us an outlook of the next 6 months with increasing vaccination. Still, the pandemic is not fully controlled. And second question, what are the strategies governments could adopt or design considering the socio-economic challenges we will be facing going forward? Unemployment, children and adolescents that will not be going back to the classroom, especially in the poorest areas. And speaking particularly about the state of Maranhão. So which strategies could governments adopt to tackle the socio-economic challenges we will be faced with over the next months, and in attempting to go back to normal, a certain normality, quote unquote? Thank you, sir.
Thank you, and very interesting listening to the experience in Maranhão, and congratulations on the work there, and for the lives saved with the comprehensive approach to disease control. Not always easy, and you did mention that specific issue of people who have to work, and day workers, vendors, informal workers, artists. It's been very, very tough on them because the social supports for people who work in that sector, across those sectors, just aren't there in many countries, and it's been a huge problem in so many different countries. You mentioned the social issues, the educational impact. I think that's something we're only coming to terms with now. In terms of the long-term educational impact. In terms of your specific questions going forward, I think there's a decoupling of the pandemic now. We have countries in which we have very high levels of vaccination, and we're starting to see that the death rates and hospitalization rates have fallen in those countries. But what we've also seen, and if you think about it, even in the last week, the United States has had over 500,000 cases reported. The United Kingdom, 250,000 cases in the last 7 days, 2 of the most highly vaccinated countries in the world. They're now back in the top 10, number 1 and number 4 on the top 10 list of countries reporting cases. The difference in that is that the numbers of hospitalizations and deaths remain very low. And this is happening in a lot of countries. So the Delta variant is continuing to spread. It clearly, and other variants are continuing to spread. Vaccines are not proving 100% effective against infection, but they are proving remarkably effective against severe disease, against hospitalization, and against death. So, if we're really, now experiencing, another increase in cases, we've seen, I think the Americas in particular Central and South America, have probably been for the longest period affected. If you look at the number of cases and deaths every week, for the last 6 months. You know, the Americas has figured there. And even when you look at 5 out of the top 10 countries are in the Americas. 5 of the top 10 countries for deaths. 4 of the top 10 countries for cases are in the Americas. So the Americas has really suffered very, very badly, a prolonged impact on the health system, huge stresses on the healthcare system for a very, very long time. And it is very hard to get out of that cycle unless we can increase vaccination. Because what we really need to do is end the emergency. We will not end the pandemic quickly. It's very clear the variants and the emergence of variants is making eliminating this virus very, very difficult. But we can eliminate the public health crisis, the social crisis, and the economic crisis if we can get more people vaccinated. Because I think, as you've probably experienced in Brazil, the difficulty is when the health system starts to fail. The health system comes under pressure, and then governments are left with little option but to shut down society. And you end up in this vicious cycle. Shut down society, take the pressure off the hospitals, then open up society, hospitals fill up again, shut down society. And most governments have had to deal with this vicious cycle. Vaccines will help to break that. But we also need to keep doing the other things. But the difficulty for you as policymakers is how do you continue to suppress transmission? And we can do that in terms of breaking chains of transmission without just continuing to disrupt the social, educational, and economic life of society. And that's a real challenge, especially in your situation where you have so many informal workers. So the question is, how can we support workers and people to reduce their risk of infection? Certainly, we have to avoid the massive crowding situations if we can. We need to continue wearing masks. We need to continue reducing individual risk of being exposed to the disease, while at the same time opening up critical infrastructure like schools. So how do we balance opening up certain parts of society with keeping risk management measures in place? And a lot of that is about investing in those communities themselves to try and reduce risk. And we've seen great examples from around the world, in Brazil, in India, and other places, where communities themselves have taken a lot of action with government support. You don't have to, it's my belief that you don't have to engage in massive lockdowns to keep some pressure on the virus while you increase vaccination rates. But none of this works unless we increase vaccination rates. And I think that's going to be the challenge. I know rates have increased in Brazil, but they're struggling all over the world. We deal with another huge inequity when we look at high-income countries versus low-income countries. You know, we're seeing 60, 70 times more likely to be vaccinated in a high-income country versus a low-income country. Right now, in the least developed countries, in low-income countries, we have maybe 1.3, 1.5 vaccines per 100 people. That's just not acceptable when you see the number in high-income countries is well over 60. So there's a huge inequity in vaccine distribution. But if we're going to get through this and get to some normality, we have to continue to try and suppress infections, but at the same time, increase vaccination hugely. And that's a massive challenge in the current environment. The most important people to vaccinate are older populations with underlying conditions, frontline health workers. And there are still countries in the Americas and around the world in which even frontline health workers are not protected. And this is a tragedy. But identifying those older persons, those persons with underlying medical conditions. Remember, in this, the virus is not what's killing people in itself. What's killing people in general is massive inflammation in the lungs with a rapid reduction of oxygen. And in order for that reduction in mortality to happen, people need access to care. But most of the risk of developing those severe complications come with age and come with having underlying conditions. And ensuring that we vaccinate people with those conditions, people with hypertension, people with diabetes, people who are otherwise immunocompromised, and in vaccinating frontline health workers. If we can get to those high-risk people with good vaccine, vaccinate them the number of times they need to be vaccinated, once or twice, depending on the vaccine, then we will begin to severely limit the potential for this disease to overwhelm our health system and force you as policymakers to shut down your economies. So the vaccine coverage in itself for me is meaningless. I would rather understand, for example, in Brazil, what proportion of high-risk people are vaccinated, what proportion of health workers are vaccinated, what proportion of people over the age of 60 or 65 are vaccinated. So I think we have to have some hope. Vaccines are doing a fantastic job. They're not stopping the virus, but they're stopping the death. And if we can invest more in vaccines, I think we can make progress. Over to you.
So, thanks so much, Mike. This is thanks for sharing those thoughts. So I'm mindful of time. So I would like to ask a final question, which is really a reflection. I don't expect an answer, but a reflection. So you just highlighted the differences across countries. So the so-called global South is really lagging behind on vaccination and lags behind in many other things. We know this. So do you think that we have any chance of starting a real coalition that brings the global North to support the global South and really move towards setting up a global epidemiological and genomic surveillance so we can really stop those things before, as soon as they emerge? We can identify new pathogens as soon as they emerge, regardless of where they emerge. That's going to need really the global North to think beyond their own belly buttons and help the global South. So do you see any chance of this moving forward? And can WHO play any role in pointing fingers at people and try to make this happen?
Yeah, well, I think the first thing we need to do is end this pandemic. And the only way we're going to do that is if we get better at distributing the vaccines we have. We're seeing an improvement. We're seeing more vaccines come into COVAX. We're seeing more donations come from countries. Now we have 12 plus countries donating vaccine. We need the manufacturers to prioritize COVAX so we can get vaccine to the developing world. We have the money to buy the vaccine. It's finding the manufacturers to sell that vaccine to us as a priority. And COVAX is a coalition of many institutions beyond WHO. So we need to get vaccine better distributed. But you're right, in the long run then, we need to readdress issues around global preparedness and global response. And my fear in this, and I think you're probably articulating that, is that we end up with this global solutions approach. So we had a global pandemic, so the solutions are global. So what we need to do is make more machines that go ping and build more laboratories and cut more yellow ribbons and do all of this super technology work, and then we'll fix the problem from satellite level. We will not fix the threat of emergency preparedness and response and health emergencies unless we go to communities. You know that in Brazil with dengue, with yellow fever, with other diseases, with cholera in the past. Epidemics begin and end in communities. That's the front line. That's what we've seen. It's frontline health workers, frontline communities. That's where it begins and that's where it should end. So if we're really truly to have a global system of protection, it's based on connecting communities to their national public health services and then connecting those national systems in an unbreakable global chain. But the global system should exist to support the local intervention, not the other way around. And this is where I hope, when you mentioned it before, we have the pandemic and we have the infodemic, and now we have the recommendation-demic, right? Where, I have telephone books. I mean, literally, I can hold my doors open with the emerging pontifications of various groups around the world who all seem to have the answers. They've all of a sudden, everyone has the answers. But I've been in here 30 years doing this. I've been through SARS, I've been through the Ebolas, I've been through the H1N1 pandemic, been through all of these diseases, been through the yellow fevers, the meningitis and everything. And in the end, what I've seen in the aftermath is people forget. We have a collective amnesia and we don't learn the lessons. We write the lessons and we make the recommendations, but we don't do anything about it. And I hope this time we won't do that, because I think planetary health, I think health justice and social justice and climate justice are linking together. I think people are beginning to see the existential risk we face in a globalized society with such unfairness, with such exploitation of people and our environments, that this is not sustainable. We cannot simply keep living like this. We have to find a better way. But the better way is not to build more technology. It'll be an important part of it, but we have to build from communities up. You talked about resilience. We talk about our most communities that are excluded from the economic and social life. We need to begin there. In the end, if the next pandemic, is more likely to be influenza than anything else, and it's more likely to emerge from an avian strain, what's going to matter is a local worker or farmer who keeps chickens in his backyard and has death in his chickens, that he knows who to tell and is willing to tell that person that he's sick and his animals are sick. And the local health authority knows what sample to take, and there's a lab to test the sample, and somebody's not going to come along and kill all his chickens and not compensate. Because that's the moment the next pandemic will begin. It will begin in a village, it will begin in a small community, and it will explode from there. And if we're going to avoid pandemics in the future, it's about understanding about lives, livelihoods, and understanding that moment, the spark, we need to find the sparks, not the fires. And if we're going to do that, we're only going to find them in communities and by working with communities. And I know for a lot of the people who think in global terms, it's not very easy. I've been using I watched a documentary a number of weeks ago about the building of the Golden Gate Bridge in San Francisco. And I hadn't realized, I should have realized in my life, that you have to build a suspension bridge from both sides and you meet in the middle. You can't build a suspension bridge starting on one side and go to the other. So you have to start on both sides. So I think we need a local to global approach where we recognize that local systems are contributing to this global alert we have. This global watch, this global surveillance is built up of millions of local nodes. And the global system can't function without those local systems. And that global system must invest in building those local systems, and the two meet together. So I think if we have that approach, then we make progress. I hope so, but then again, I'm a life's optimist.
Mike, I think we couldn't end in a better way, because what you just said stresses the importance of the community health agents. Those are the ones every day, door to door. Yes. It involves trust that you mentioned right in the beginning. They are the ones building trust, bringing information, and making sure that if that chicken dies, people are not going to hide the chicken, but tell the community health agent that the chicken died and we can avoid a next pandemic. So thank you so much. Thank you for spending an hour of your precious time with us. And thanks for all the work that you do, Mike. We couldn't be in better hands. We are all inspired by your words. And I hope that the next generation of leaders, the students watching us, they are inspired by your optimism, that they remember they have to go to the community. They need to listen to people. They need to listen to the problems, because we don't have the answers. No matter how big shot you are, we don't have the answers. We have to learn the answers by talking to people in the community. So, Mike, I'm inspired for, a month. Just listen to you. Thank you so much for sharing this time with us, and keep up the good work, Mike. Appreciate it.
Thank you. And thank you for all your work. And I'm sure you'll be with Jarbas. I heard Jarbas's name later. So he's a remarkable product of Brazil. And I'm sure he will also give you the PAHO perspective and other things. Jarbas is a good friend. So I'm glad he'll be with you later too.
Yes. Thanks, Mike. Appreciate it. Cláudio, next to you.
Bom dia a todos, a todas. Saúdo inicialmente.
Good morning, everybody. On behalf of the authorities that we have on this call, our Dean, Pan Ngopian. Greetings to the other authorities that are with us, Mike Ryan, the director, one of the directors of WHO, and Carlos Lula, our Secretary in the State of Maranhão, has shown to us the possibilities of working differently in the midst of the pandemic. And that's what we're going to talk about now. We're going to talk about the response of different governments to this pandemic. Talking about epidemiology and consequences of the disease, one of the things that have been discussed is the official response. And because we can't talk about a response to the pandemic without mentioning specifically the role of the state in healthcare and social policy. There's no control that we have seen of a pandemic without the involvement of the state playing its roles. And in Brazil, I mean, we have had a sad observatory of what happens when the state is absent or sometimes when the state opposes to the response. So we're going to have a round table with guests from different governments. We're going to have Winnie Weeping talk about the Chinese experience, Sachi Balsari with the Indian experience, Sue Goldstein from South Africa, and Patty Garcia from Peru. So we're going to open the discussion with the presentation by Winnie Weep, who's a professor of global health, healthcare policies of the Harvard School of Public Health, and also director of in the Department of Global Health and Population at Harvard T.H. Chan School of Public Health, and also director of the China Health Partnership at Harvard University. She was previously professor of health policy and economics at Blavatnik School of Government, University of Oxford, and senior research fellow at Green Templeton College. So the floor over to our guest, and thank you very much for participating with us.
Thank you very much for inviting me to share the experience of the Chinese government's response to COVID. If my voice starts breaking up, do just shout and let me know, and I will try to slow down. So first of all, I want to say that I don't represent the Chinese government or the Chinese government's view, but I'm just reporting to you from what I understand and have analyzed the Chinese government's response to COVID. And I will try to extract the key lessons and leave the details and nuance during the discussion. I'd like to separate China's response to COVID into two separate periods. The period which earlier I would say what Mike Ryan and Marcia have referred as the crisis period versus the post-crisis period. In fact, I think the one lesson that one can learn from China is try to put that crisis out of the crisis period as soon as possible, so you can have the bandwidth to deal with the complex situation that still follows. So the crisis period will be approximately December 2019 to around March or April 2020. And that's during the major outbreak in Wuhan that most of you know about it already. I mean, the first strategy that all of us know about is, of course, the lockdown of Wuhan. And I think it's still debatable whether China needs to go to that extreme approach. My reflection is that probably by the time the cases were surging in Wuhan, China probably doesn't have much other strategy than to lock down, because it happened at the time of Chinese New Year when everybody is traveling. You just cannot stop people from traveling. So the way to lock down is not just lockdown, in my view, is not just localizing that outbreak, but in retrospect, I also think it was a wise strategy is when China was able to localize the outbreak in Wuhan and even in the province of Hubei, what it was able to do is then to mobilize the resources from the rest of the country to go to Wuhan to help them. And by resources, it is a combination of personnel, equipment. I understand that during that 3 months, over 400,000 of people has been mobilized, health workers from different provinces, and they go in phases, in teams. The second strategy that China used during that time was using the shelter hospitals for isolation and quarantine. In the beginning, actually, China just asked its people to stay at home. And what happened is that the data analysis at the very beginning realized that a lot of the people got infected was because they just flocked to the hospitals. So they got infected in the hospital and they get infected at home. So what China immediately do is that build these shelter hospitals. And I mean, again, this is not new strategy. Going back to history, it has been used in other pandemic. But I think China did go back to what we have learned in history on what might be helpful and immediately put into action. So they turned these stadiums, huge stadiums, into shelter hospitals, and they were able to do it in just 2-3 days' time. And what is the advantage of doing these shelter hospitals is that everybody who are suspects, everybody who has been identified through contact tracing, instead of making them stay at home, stay in the community where you cannot control what is their living condition, as some of the living condition are actually quite poor, quite crowded. It was put into these stadiums. So these stadiums serve several functions. They basically are isolation and quarantine quarters for those who are suspects. But then during the period of observation, for those of people who actually do develop COVID, they were immediately transferred to the hospitals. So it's also playing a role of triage. And finally, in these stadiums, they were also provided sort of daily activities of which people feel that they are actually not isolated. So at the end, when the government, about April last year, when the government was trying to reflect on what were the strategies that went correct and awarded the people who recommended the different strategies, lockdown and shelter hospitals were the two that were prominent. The third strategies that I would like to highlight, and I'm really glad to have listened to the conversation between Mike Ryan and Marcia, was precisely mobilizing the community. This is the one thing that is not mentioned enough in the global discussion about China's strategy. Everybody talks about a lockdown. Everybody talks about these big shelter hospitals. By the way, I also want to mention that China also built 2 huge hospitals for acute care quickly, but they were not actually having much effect at the end. They realized what is effective is really cutting the infection upstream, not waiting for people to get infected and then put them into the hospital. And by community, to use the words that were just used in the last hour, who are the community agents? One group of agents are actually the Center for Disease Control's local agents. Unlike the United States, the Center for Disease Control in China penetrates all the way from national, provincial, city, and all the way down to community and village. So you can mobilize them. They are there. Second are primary healthcare providers, but I would say that actually China's primary healthcare system is not as good as Brazil's system. The third group of community agents are traditionally, China do have what we call neighborhood communities. These neighborhood committees basically know about everybody quite well, and they are very effective. This group of people, what do? They go around and do public health education. They are the people, as the conversation just said, they are the people that the residents trust. So this is the group of people who go around and tell people they need to wear masks, they need to wash their hands, they need to have physical distancing, and they're responsible for making sure every household has enough masks. They are responsible for contact tracing. They are responsible for mobilizing people to go do tests. How did China get people to do tests? Yes, they have tests available, but it is the local community that get people to go and do the tests. And just having the test alone is not enough. And what is also amazing is that they actually provide daily support. What does it mean? If an old person needs to be driven to a hospital for tests, they organize to drive them. The taxi driver who is not working at that time do that job. They mobilize and organize themselves to buy grocery, to deliver food. And that make shelter at home much more practical and feasible and acceptable to people than to have just a government policy saying that you need to stay at home when you do not provide all these help. And finally, I have to say that scientists do an important role. You realize that if you review that period of time, many of the major announcements is actually not made by the government. It's actually made by the CDC director. It's actually made by the scientists who come out and give people the advice. So post-outbreak, and that is starting from about last year's April or so, what is China's strategy? China's strategies has always been early case finding, early contact tracing and isolation, early identification of the origin of any new confirmed cases. And in fact, I think that target is a bit tough. They still want to target at zero local infection. So right now, a lot of the infection that confirmed cases that we are hearing in China are imported cases. But for them to be able to trace the origin and therefore from that origin, trace anyone who had been in close contact has been a priority strategy. In other words, and if you find them, isolate them, quarantine them. So, I mean, even my colleagues, my friends in China, they seem to be spending all their time figuring out each local city's rule on quarantining. It sounds very inconvenient, but this is how they were trying to control the any further outbreak. So what China does now is they classify the entire country into locations of high, medium, and low risk based on outbreak number. Then they use digital technology to track everybody's travel pattern. And so everybody would have a code that identify whether they have been to places that is red, which is high risk, medium, which is yellow, which is medium risk or low risk. And if you travel from any place that is high or medium risk to the destination city, this is all within China, you will be required to satisfy. And whenever there is new outbreak, China would impose population-based testing. In other words, they would try to make sure that no one falls through the crack in making sure that they're not going around, going to the community, infecting other people. The second major strategy is, of course, massive vaccination. But I would say that massive vaccination only appeared recently. For many years, for many months, China did not pay attention to vaccination. And in fact, their vaccination strategy is a little bit different from the US. In fact, they don't vaccinate old people. The argument is that since the infection rate is low, the priority is to vaccinate people who are actually going out and have a lot of activities and potential contact with risk and infection. It is only until recently that they're trying to reach the bulk of the population. I'm going to leave the effectiveness, efficacy of the Chinese vaccine as a separate discussion, a point that we can do that during the discussion. The last strategies that they do is to have very strict international travel restriction, and practically the international border is closed at this moment, unless you're willing to go to China to have a minimum of 14 days of quarantine in a hotel, plus another week or maybe another link to pay these time prices, fine. I do want to cover a little bit about under these stringent strategies, what happened to non-COVID care. Non-COVID care during the first few months practically was brought to a halt. All the hospitals in the whole country practically has closed elective care, practically has no outpatient services, because all of them is being repurposed to identify and treat COVID cases or being sent to Wuhan or Hubei province to help them. It is during this period of time that care is to a certain level being maintained by care delivered over the internet platform. Now, care delivered over the internet platform actually existed before COVID, but they were not very popular. What happened during this period of time, most of these services that are provided by private industry they actually offer these care for free. They attracted a lot of physicians to sign on to their platform and provide free care. And when the government saw that, the government stepped in immediately to get the universal social insurance scheme to actually pay for these care, and also streamline the review and approval process. So I know that I have used almost my time, so let me do a quick summary. I think China's strategies in retrospect is end the crisis phase fast. What they have done is very, very drastic, and some would say draconian, and people are still debating about the cost. But the fact that it is able to end the crisis fast allowed them to buy time and to really smooth out the resource need in order to go into the second phase, which is the current phase of maintaining and prevention. The second lesson is that despite China is a big country, a lot of the decision is actually centralized and coordinated at the central level. There is, in a way, a commander-in-chief. And in fact, if you read the document around that time, the narrative that they use to fight against COVID is a war, it's a battle. It's a battle that's led by some commander-in-chief, and they use it to rally the population to feel that they should be following the government's advice in order to fight this battle. And so centralizing the decision-making, but localizing the outbreak, which is very much different from the United States. If you look at the United States, it's almost like every time you put out a fire here, another fire would start there. And so the way China does it is localize this fire, put that off, and then move from there. The priority given to early detection and isolation, I do think it is something very, very effective, and it's low cost. And that if you organize it enough, especially using the community to help with that, it is feasible. So again, I want to re-highlight the important role played by the community. I think China also quite smartly used technology, digital technology, to do contact tracing. There are issues about privacy and all of that, which should be discussed, but we should not ignore that this has been quite effective for quick decision. And finally, I have to say good governance is essential. And let me just show you this graph. After SARS, China prided itself by building a state-of-the-art information system, of which any infectious disease that happened in a national hospital, provincial hospital, all the way down to the community will be reported in real time through an internet to go to all the different levels of Centers of Disease Control, and then directly going to the Health Ministry and Health Bureau, and also directly going to the government. It broke down during the early period of Wuhan because what China had was an information system. However, who get to use what information and can make what decision was completely fragmented and unclear. So I want to emphasize that because I hear so much about the importance of information system, and I would have to emphasize this is a failure lesson from China. If you build the best management information system without a clear governance system over it, you still would not achieve what you want to achieve. So thank you very much for allowing me to share some of my observations of China's lessons, and I look forward to learning from other countries and also for the conversation afterwards. Thank you.
Muito obrigado, professora Winnie.
Thank you very much, Professor, for your presentation. I would like to point out at this moment, well, if I may, that as mentioned earlier by Professor Yip, it's extremely important to engage the community. And this is without a doubt a key point when it comes to how China responded, and mobilizing the community is not a spontaneous action. In Brazil, we also had the mobilization or engagement of the community in different respects. However, it was produced, it should be produced with reliable information, and of course, by sharing information flows that are science-based and reliable, and you have to, of course, build awareness continuously and educating the population if you are to control the pandemic, to fight the pandemic, which is also very different. It differs drastically from the Brazilian scenario. And now I would like to give the floor immediately to Professor Balshari, the emergency responder in Harvard Business School and Medical Center since 2009, affiliated to also the Health Emergency Center, Harvard University. His research has contributed to advocating for the rights of vulnerable populations affected by disasters and humanitarian crisis. He is the head of the Young Digital Health Network in Lakshmi Mittal Asian Institute, a research group, and their products have also shaped the digital health system in India. Co-director of Crisis Ready IO, an interdisciplinary research network, and that is also of Harvard, and direct relief for lawmakers that respond to emergency disasters. Professor Sachi, the floor is yours, please.
Thank you very much. Am I audible?
Yeah.
Great. All right.
Good.
Thank you kindly for inviting me to this very important discussion. I'm going to build off right where the last two speakers, Dr. Ryan and Professor Yip, left off, and the common themes we've identified. You know, as we think about the responses around the world, it is striking, I'm sure to all of us, as to how simple and yet extremely complex the response to the pandemic was, right? Sort of putting on my clinical hat, just what exactly are we dealing with? By March or April last year, right, 2020, the world already knew, thanks to social media essentially, and very early reports from China, and then from Italy, and especially sort of the WhatsApp videos from the emergency rooms in Europe that went viral, that the majority of people that will get exposed may or may not have COVID, depending on what kind of exposure. Most people won't develop COVID. Of those that will get COVID, the vast majority will be asymptomatic. Of those that develop symptoms, most people will have mild symptoms, and we've heard this recurrent theme over and over again. And there is a small number of people that will get short of breath. And of the people that get short of breath, most people will only need oxygen, maybe pronation. And a few months later, we realized that the correct dose of steroids for a short amount of time may help. It is only an extremely tiny slice of the population that gets exposed and gets COVID and is symptomatic that will need critical care. The vast majority of the world does not have the capacity to take care of these people that are critically ill. And that capacity cannot be built overnight. No matter how big a hospital we build or how many ICUs we put up overnight, the clinical capacity to take care of these patients doesn't exist. So as Mike pointed out, what we really needed to do is to quickly identify those people that would need oxygen, the mild to moderate cases who could be turned around before they got critical. That needed to be the clinical thrust of all we did for COVID-19. In India, as many of us will recollect, there was a major lockdown announced at the end of March. This is 1/6 of humanity being told that they will be under lockdown, given 4 hours notice, right? cases had started coming into India. There were about 1,000 cases that were detected when that decision was taken, mostly in urban India, as you can imagine, as you know, the virus would have arrived on flights into the urban centers. So normally the streets of India that look like this, right? This is Connaught Place in New Delhi, not too far from the parliament, was emptied out, completely emptied out, right? You're talking of one of the most populous nations in the world, very successfully staying at home. But there was this other India, the tens of millions of migrants that come to the cities to often earn daily wages. Many of them live in very close shelters, right? Share rooms, their families are back in the villages in India, and many of them would sleep in the streets. And when the lockdown was announced, there was unfortunately not really a plan for these tens of millions of migrants. And so they flocked, thronged in high density, as we can see, to public transport systems, trying to get back home. The public transport system was also shut down, and so they decided to walk the tens or sometimes hundreds of kilometers it would take to walk home. As you can imagine, that there were several challenges with this kind of draconian lockdown, of course. Even urban middle-class India wasn't prepared, right? So those with the means were suddenly asked to stay at home, and essential services were open, but it was entirely unclear how folks were supposed to navigate these services. The elderly were locked in at home. As you can imagine, the middle class in India is highly dependent on domestic help that comes home. And without that help, you suddenly took people that even had the means and made them very vulnerable. This was a tiny part of the population. The vast majority of the population that does not usually have means essentially were on the streets trying to figure out what happened and where they could get not food, but wages, because they were dependent on daily wages for survival, money that needed to be sent back home. India has one of the largest midday meal programs in the world, which came to a grinding halt overnight. So now we have tens of millions of children who are dependent on this food, sometimes their only substantial meal. When they go to school, being denied that meal. The impact on education, of course, will have long-term consequences, and it's too early to see what that is around the world, as all our students have missed class, right? From Harvard to the primary care center in the rural global South. But telemedicine or teleeducation was not a solution for the vast majority of these kids. What the early response was marked by was also questionable science. You saw sort of these large hospitals and Professor Yip's presentation as well, where the Indian government's response initially was to centralize the response. So they activated the Disaster Management Act. They took full responsibility, saying, look, this is a national emergency. The state needs to be involved. This is not just any public health problem that can be locally solved. And part of that draconian response and responsibility was to say, we are going to identify, contact trace every new case. And as soon as a household is suspected to have COVID-19, the household will be sealed. People will be taken out and supported in these isolation care centers. While that is laudable for isolation, in hindsight, and not a year later, but I think around the summer of 2020, many scientists began to question the wisdom of this isolation. If you're living in a dense household and one member has symptoms, it is highly unlikely that everyone else has not already gotten infected. There was no treatment to offer in COVID. I think the signaling that governments did was somehow that one took, if one was taken to these isolation centers, that you were safe. But if you think about the first slide, there was nothing to do. There is to date, 18 months into the pandemic, very little we can do about COVID-19. Most people need supportive management at home with a little paracetamol. only those that will have increasing oxygen requirements need to be quickly identified and be provided oxygen. There is no oxygen at this isolation center. There is no oxygen at most isolation centers around the world. And so the question is, to what avail are these centers being built if what it does is actually terrorize families? What this ends up doing is people are afraid to report their symptoms because no one, rich or poor, wants to leave their home. And this is different in different country contexts, of course, right? So as Professor Yip said, in China, this might have been socially acceptable and people may feel comfortable at these centers. In India, not so, because you have the juxtaposition of various socioeconomic strata living very close together. And most people were too afraid, if they could, to report their symptoms. The way this backfires is then by the time you actually report your symptoms, you are so sick that you'll end up in the hospital critically ill. India also has a mixed medical response system. There is Ayurveda, there is homeopathy, all formally recognized by the state, and there are medical schools for various disciplines of medicine. Various state governments in India, health is a state subject in India, were actually sponsoring the mass distribution of these concoctions that have no evidence base. Right? And what that does is two things. One is perpetuates the false notion that, oh, it's not really harmful. It could be anything, and we will see how the allopaths follow it as well. And so if it's not really harmful, it's okay to give it. And the other is a false sense of security. I'm drinking this potion every morning, I'm protected. India's contact tracing app was downloaded by 100 million people in weeks. It was the fastest downloaded app in the history of apps. For contact tracing, digital contact tracing to work, you need about 60 to 70% of the population to be participating actively in the contact tracing app. 60 to 70% of the population does not even own smartphones, much less smartphones that are BLE enabled. So regardless of whether the Bluetooth technology and the way the analog world of sort of 6 feet and 15 minutes of exposure was translated to the digital world of contact tracing apps, regardless of that, the arithmetic doesn't work. However, these data and testing data were used to create these hotspots, as they have been around the world, because that was sort of the wisdom of the moment. But what these hotspots do is affect individual and group freedoms, right? You are asked to stay at home or not leave your home or travel or not travel based on data that are questionable, data from the contact tracing app and data from testing. In April 2020, at one of the Harvard hospitals that I work at, when we initially started testing, there were no tests. We all remember tests had to be made because COVID was novel. So there were very few tests, and we had set up triage tents across these hospitals. As people started coming in, they were being tested. Then the wealthiest nation in the world, the United States, ran out of Q-tips. Essentially, we had no nasopharyngeal swabs to do the testing. So we stopped testing and we said, reserve the tests only for those that are very sick. If people come with symptoms in a pandemic, tell them they have the disease, go home, only test the very sick. Then tests were available and we started expanding testing. Then rapid tests were available and Harvard University bought these tests for everyone who was on campus and you were testing daily. What the epidemiologists and the demographers here would be horrified by listening to this is what happens to the denominator. Every time you test, every time you change the testing criteria, the denominator shifts. And yet, barely was there a country in the world that was reporting what those tests represented. And yet these tests were made to color these maps that determined what the public health response to these districts should be. Anyone who could code was making SCIR models. I'm sure Professor Castro wanted to tear her hair out when the next new model arrived at her desk on a Monday morning. In India, the models were predicting that the epidemic would be over by October 2020. And the problem with this is that the scientists were not at the decision-making table. Around the world, including in Massachusetts, you had consulting companies sitting with governors' boards. The biggest names in consultancy were telling the governments what triage criteria should be, what the model should look like, and what the responses should be, and often apropos of nothing. As Mike pointed out, when we look at aggregates in countries, we miss the nuances of actually what is happening at the individual level. India is a large country, it has 1/6 of the world's population. There is wide variation from city to city, village to village, in what state capacity looks like. In the state of Kerala, the abandoned isolations, at home isolation, and provided, as was seen in the Chinese response, the necessary care to keep people at home. Can we help them with transport? Can we help them with food? Can we bring medicines to them? And society sort of also rises to the occasion. My parents were elderly. They were in lockdown in India in their mid-70s to late 70s. And the neighbors ensured that they did not leave home, right? Society, the community spirit that exists in these societies and cultures, which is very different from urban United States, allowed this kind of home isolation to be possible. My parents did not leave their home for 3 months because neighbors brought groceries, neighbors brought medicines to them at home, and they managed to sort of ride the first wave of COVID without even risking being infected. And I think we need to remember how we tap into what society can do. Keeping an eye on time, I'm going to just quickly mention the vaccine response in India was very unfortunate. While India had one of the largest vaccine manufacturer at home, in India, largest vaccine manufacturers in the world, in India, India did not actually invest in purchasing and guaranteeing these vaccines till January 2021. And so our vaccine rates fell low. There was, of course, Indian exceptionalism, as there has been American exceptionalism and sort of disbelief in science. One of the world's largest religious mass gathering was allowed and sanctioned by the state in early 2021, and election rallies were held throughout the country. It was kind of inadvertent that you would then see this massive second wave. The second wave, as all of you know, and I'm not going to harp on this, has been marked by excess mortality. We have seen these visuals of funeral pyres around India. It was also marked by this desperation in India by the billionaires, by the technology companies, by the corporations and the Indian diaspora to do something. And the something, because the visuals show people gasping for oxygen, has been to donate lots of oxygen concentrators to India and to build ICU beds overnight. Except oxygen cannot be in isolation of the entire continuum of care. The national guidelines continue to peddle ivermectin, hydroxychloroquine, CT scans, remdesivir, and inappropriate uses of steroids for months and months and months into the pandemic, leading to one of the largest outbreaks of mucormycosis or black fungus anywhere in the world. We still don't know what this may have caused. Hypothesis is that it might be the zinc prescriptions, because patients with COVID would get vitamin C, vitamin zinc, dexamethasone, whole slew of antibiotics, and remdesivir. What we were panicking about, and I will end with this, is what all of this would do to rural India. The third wave photographs and videos and stories that we have heard are from urban India. The latest estimates from a couple of days ago is that there might have been 4 to 5 million excess deaths because of the COVID pandemic. It was limited state capacity on top of weak underlying health system and a deep politicization of science that we have seen around the world. As the pandemic spread to rural India, civil society and scientists banded together. And they said, we cannot depend only on the state response. Let us augment the state response. A wonderful study done by Professor Mushfiq Mubarak at Yale University, a randomized control trial of over 350,000 people, determined how do you actually normalize mask wearing. It's one thing to ask people to wear masks. It's another thing to get people to wear masks that cover their nose and their mouth and decrease the transmission rate in the community. And what does it take to actually do that? Clubbed with that, several of us said, look, all we need to do is identify that small slice of people that need oxygen, make sure they get oxygen at the right time. Can we break this down? Can we protocolize this? Can we make this a checklist for the manager, for the healthcare worker, for the patient, translate into multiple languages, and work with a slew of community organizations across South Asia, across India, Nepal, Bangladesh, to say, can we take science to the people? Can these countries, with political differences, but with a shared society, speak the common language of science? So community-based organizations that together serve hundreds of millions of people across this region basically took the latest scientific protocols vetted by scientists from around the world and converted them into these very usable metrics. Very usable implementation steps for community health workers to go door to door, support people to do home isolation, and quickly identify those that needed oxygen, take them to oxygen centers, not isolation centers, centers where you were actually given oxygen, but heavily protocolized, so that you could decrease the demand on the ICUs. Here's what vaccination in India looks like. We're still far behind. Absolute numbers are very impressive, of course. 435 million doses have been given. India, unfortunately, is a very large country, and we have a long time to go. So until then, I think what India falls back upon is now the people of India who have to fall back on basic, one-on-one principles of public health, masking, isolation, and the correct kind of treatment when possible. Thank you kindly for inviting me.
Thank you very much, Professor Sachit. We see in many aspects there are similarities between India and Brazil, especially when we look at the lack of political leadership, telling people what to do in relation to isolation and the lockdowns politics, and also when we regard to the scientific knowledge as the basis of the response. I think, there's no other example like Brazil that denied science so much, but we see also in India, this has been a problem with a good example with the medicines recommended for treating the disease. Well, we go to our next presentation from the experience of South Africa, Susan Goldstein. I'll read it in Portuguese. Susan Goldstein é especialista em medicina e saúde pública, diretora do
Is an expert in public health medicine and department director of the SAMRC Center for Health, Economics and Decision Science. She has a special interest in 30 years of experience in communication for social change, health promotion, socioeconomic determinants, and health in children. So over to you.
Thank you. Can you see my screen?
Yes. It's
okay,
not full screen yet.
Yeah. How's that?
Yeah. Very good.
Okay. Thank you very much. First of all, a couple of disclaimers, and thank you for inviting me. I'm really honored to be amongst such esteemed presenters. Listening to Mike Ryan, I'm glad I'm not in your booth, sir. I am not representing government, and this is a personal view of what the government response in South Africa was. And I'm speaking as a health promotion academic. So this is the other day in South Africa. We had what some people called economic insurrection. People looted, and there was a lot of rioting happening in the streets of 2 of our provinces. Context, South Africa, just for people who are not aware, we were colonized. We right on the southern tip of Africa, first colonized by the Dutch, then by the British. They managed to keep their power by land grabs and, of course, brought slavery to the country. This was followed by apartheid in 1961, which became famous for institutionalized racism and keeping Black people basically away from the wealth of the country and separating people physically and through education, through lack of services and so on. And of course, this has resulted in huge inequities. So even since our liberation in 1994, you can see on the left-hand side are the informal dwellings where people live, hundreds of people living on top of each other. And on the right, the middle class with reasonable, nice housing. This inequity, of course, is in the health sector. So at the top, you see a hospital with a helicopter, absolutely up to state-of-the-art services. And at the bottom, you see what the vast majority of people have is overcrowded clinics, mainly for women and children, but for everybody. Health expenditure, most of the money is spent on only on 16% of the population. The quality, as you can see, I mean, when you're overcrowded like that and you don't have resources, the quality deteriorates. So the population is 58 million. We've got huge inequality, as I've said. So this epidemic jumped in on a really struggling health system. We have 31% of people have AIDS, 36 NCDs, injuries. We have perinatal and nutritional problems, as well as infectious and other parasitic diseases. And even our maternal mortality rate is very high compared to other countries. So if you even look at India, Russia, Brazil, we're almost the same as India. And in fact, ours rose after 2005 due to the AIDS epidemic. 55% of South Africans live in absolute poverty. And then there's the other context. We've had 10 years of looting of the state by a whole cohort. People blame President Zuma, but he was just one of looters at all levels of the state. So here's the COVID timeline. And if you start at the left, on the 5th of March, we had the first case in South Africa. And our state, we had a state of disaster declared on the 15th of March. And then we had total level 5 lockdown on the 26th of March. So that was, if you look at the numbers of cases, it was before we had many cases at all. So our government was really commended to start really trying to do something early on. And then they developed a 5-level system where they would have level 5, and then it went down to level 4 on the 9th of May when people could no longer tolerate it. And you see it's not really related at all to the numbers of cases. And then you look at level 3, level 2, level 1. And then we went back up to level 3 for our second wave. And we went to level 3 in our third wave. And in fact, we went up to level 4 recently and are now back down to level 3. So all these are very confusing and disturbing. But I think the point that the previous speaker made about who's being tested is absolutely critical when we look at these numbers, because there are so many people who are just not tested and we just don't know the denominators. You'll notice at the bottom that in our level 4s, And in some what they call adjusted level 3, alcohol was banned completely for sale or distribution. And the idea behind this was to free up emergency wards, particularly, and to give space in the hospitals for COVID cases rather than for trauma and violence, which is where a lot of cases, especially on weekends, came from. And it did really help. The stats have been shown that trauma cases drastically decreased during the alcohol ban. However, there was, of course, huge backlash by the alcohol industry, and a start of some bootlegging and illicit trade. So, yeah, that was something that was an interesting, different thing that South Africa did. So the good. What was the good of South Africa? Sorry, can you hear me? Okay, I'll carry on. The good was that there was a very rapid response to the pandemic. And the second point, I think, is really critical. There was a whole of government response. Usually when it comes to some sort of some illness, and certainly with HIV and AIDS, it took years and years and years before there would be a whole government response. There was a massive mobilization of business. There was a solidarity fund, which was lots of people contributed to try and support small businesses, to try and support destitute people. They had the lockdowns, and I mentioned the alcohol bans before to free up the health services. There was a mobilization of health services to prepare. So they were scaling up of testing, trying to get the health services prepared for the coming wave of infections. And so I think that was something that was relatively successful. And they recognized that people could not just stop working without some form of social assistance. So I think that was important. And then I think the other thing that South Africa was lucky at, as compared to perhaps the rest of the continent, is that we have a very good scientific community, and we had a lot of excellence in monitoring the epidemic and the sequencing of the virus. Didn't, however, help when the government didn't listen to the scientists, of course. What's happening? The not so good part was the vaccines. We had a very slow rollout. Only began rolling out our vaccines in March. Also, there was an issue of only no weekend vaccination, so that stopped the rollout. We had two very unfortunate events. The one was that we had bought the AstraZeneca vaccine, and then it was found to not be effective against the beta variant, which was very disturbing. So the government actually gave away all our AstraZeneca vaccines. Then we had the problem with J&J in the States, where the factory was closed, and all the J&J that we had bought couldn't arrive. So we had a really terrible delay in the rollout of vaccines. And in fact, our initial rollout, I think until April, beginning of May, was a study that was done using J&J vaccines run by our Medical Research Council. So that was only for health workers. So we're really far behind, slowly creeping up. I think the numbers, again, 6 million vaccines, but it comes to about 6% of the population. What was good is that vaccine acceptance is rising from studies that we've had. In February 21, it was 71%, and then in May it was 76%. South Africans are not particularly vaccine hesitant. They really just aren't getting the vaccines yet. So that's the not so good. The bad. So the bad, and people have emphasized this before, but I think for me, what's important is that there was a lack of public participation. And although the government tried to bring together groups, so they had an advisory group, they had a national committee of all the ministers, the government ministers, And then after a couple of months, about 3 or 4 months, they decided to have what they called a behavior change advisory committee. But I think the problem was that they didn't consult ordinary people and they didn't listen to ordinary people. So I'll come back to what the consequence of that was. Our second point was the lack of transparency. So nobody knew what was going on. Poor communication. We found out many months later that part of the poor communication was a tender that had gone to somebody's relatives and had made money out of it. The lockdown regulations sometimes had no logic. So people started getting tired of them. For example, one of the things that when you went into a shop, you were not allowed to buy summer clothes. It was winter, so you were allowed to buy winter clothes. But if you wanted to buy summer clothes, you were not allowed to. You were not allowed to buy tobacco. And a lot of people argued that tobacco had very little bearing on COVID-19 infection or severity of illness. So that was a huge debate, and people got quite angry about it. The other thing was that they brought in the army to try and help keep the lockdown, because as you realize, people were very poor, living in miserable situation, cannot possibly adhere to lockdown. It's impossible for a family of 4 to live in one room for any length of time. But the big thing was the disruption of the food systems. It created a massive increase in hunger. And there was a lot of relief, a lot of community people came together. They really collected money, made food parcels, but there was terribly poor coordination of this relief, and it often didn't get to people who needed it. And I think you'll see, I don't know if you can see this clearly, but this is a 2-kilometer line of people to get food parcels in the height of the epidemic. So first of all, it's getting people all crowded together. But second of all, can you imagine the hunger if you have to stand in a line for 24 hours probably? I think that just to carry on with the hunger issue, because it was very, very serious, about approximately 10 million people and 3 million children were in households affected by hunger. And of course, hunger changed how people, somebody was talking earlier about mental health issues. I mean, in a family where children lived in households with hunger, 51% reported depressed mood. And then we get to the ugly. The ugly is really about corruption. And sadly, and I think to many of our horror, even during this terrible pandemic, people were lining their pockets. So there were all sorts of corruption around PPE equipment, around giving money to other friends and families. We were supposed to have field hospitals. It breaks my heart to have heard how China built their hospitals in a week, and our field hospitals just never got built because it was fraudulent. It went into people's pockets. And our Minister of Health was actually suspended in the middle of this terrible epidemic because of what was seen as fraud around the communications, a group called Digital Vibes. So what are the lessons? For me, the big lessons were that communication for social change should be central to any strategy. And a big part of that is engaging with people, not only telling them about and educating them, but listening to them and understanding what the issues are. For an example around that I didn't mention earlier was the informal food traders. A huge amount of food is distributed in informal ways. And what happened was that these people were not seen as essential workers, and so they were locked off the streets and kept off the streets by the army. So not only they didn't have a means of earning a living, but also the people that they were feeding. And so people just could not get hold of food. This was a major problem. I think preparedness for any kind of pandemic, and I think this is something that our government needs to take terribly seriously. The reason why China could involve communities so well is because they were already organized. They already have networks of people that they can listen through to the populace and communicate with. Transparency, of course, we know, and as somebody else mentioned earlier, good governance. I think what's also important is understanding trade-offs and opportunity costs. These decisions that government has to make, and I think everybody has mentioned it, these are not easy decisions. How do you choose between staying home and starving or going out and getting COVID and possibly dying? These are hard choices for individuals, but they're just as hard for governments to make. You're really caught between a rock and a hard stone. So how do you make these choices? And one of the things that we suggest as a lesson is that if you hear as many other people's voices as possible to make the right decisions, because those trade-offs are going to be huge. And what we're suggesting, and what I would suggest, is that there needs to be some sort of priority setting body that helps with looking at advice from communities and affected people, so that all comes from the bottom up to the top, so that people can hear the advice that they're giving and try and make decisions in a positive way. And I will stop there. Thank you.
Thank you very much, Dr. Susan. I'll take a comment that our colleague Sachit brought to our chat, that how striking is the universality of these images all around. And that's true. When we see what we saw from India, from South Africa, in Brazil, we will not see the images here, but everybody in Brazil who's participating is very familiar with that. It's really amazing how the similar lack of response, the lack of government planning, it brings highlight to the dimension of our preparedness and how much our preparedness for epidemics is only focused on the health services and healthcare system, and there's no preparedness of the government in general. So we see hunger, we see a lack of communication, lack of transparency, corruption, everything that we know will happen every day shows up and now almost blasts us when we live in a crisis like this. Well, we go now to the presentation of Patricia Janet Garcia Funegra from Peru. Patrícia é professora da Escola de Saúde Pública da Universidade Peruana Caetano.
Patrícia is professor of University Caetano Heredia of Public Health, former Minister of Health in Peru, Dean of the Public Health School in PCH, and former head of the National Institute of Health in Peru. She is acknowledged as a leader in global health and an associated professor in the health department at the University of Michigan and the School of Public Health at Tulane University. She's actively involved in research and global health training and STD, HIV, and has recently been appointed member of the National Academy of Medicine in the United States. She has become the first Peruvian professional to be appointed to this position. Professor Patricia, you have the floor, please.
Thank you so much. I just want to be sure that you can hear me well, the translators can hear me well. Yeah? Thank you. Okay, so let me share my presentation. First of all, I would like to thank you for the invitation to participate in this discussion about what is happening with COVID. I want to say also that I do not represent the Peruvian government. And although I have been, I was called as part of a group advisors for scientific issues and innovation, I think this has been the hardest job in my life, because although we were there, actually the government was not really listening to the recommendations of the group of experts that they called, and eventually we decided to resign. So I will try to go through these different topics in the agenda and try to share my own view, my personal view of what has happened in Peru during COVID. Peru is a very diverse country with 33 million inhabitants. And it's a very centralized country because 1/3 of the population is in the capital city of Lima, which is a mega city. We were having a fast-growing economy. The problem is that it has been based on a informal or unregulated work. So we have more than 40% of people that are self-employed, which is the highest rates in the region. We also have a very weak social protection system, poor housing, and overcrowding. But one of the things that probably it's a little, I mean, I have seen so many things in common with the previous presentations, but one thing that has been also a big problem during these past 5 years in Peru has been the political crisis and the instability, which included the change of 11 ministers of health, about 5 or 6 during the pandemic. I already lost the count, and 4 presidents in just a matter of 5 years. So we have the opposition of the Congress to the president policies. The president was replaced. The Congress was dissolved in 2019. And just when the pandemic was started, we were having a new Congress coming out. So I don't want to make it complicated, but I mean, there have been so many changes of presidents and so many protests in the country. Then eventually we have a president that was the president of the Congress, really, Sagasti. And now in July 28th, we will have another change of government. So it has been a very difficult time in the middle of this sanitary emergency. Over that, the Peruvian health system is a fragmented health system that is under budget, with about 92% of the population served by the public sector, with unfortunately poor quality public services and with a very weak primary health care system. And according to the Global Health Security Index, that was a self-report, it was self-report in 2019, we already knew that we have deficiencies in terms of biosafety, laboratory systems, epidemiology workforce, and about emergency response plans. So one of the things that the country had to do was to start preparing early. And actually by February the 2nd, we had a COVID national plan for preparation and response. However, by that time, probably it was too late. When we were trying, although we were having the money, when we were trying to get or purchase protection equipment and supplies for the laboratory, it was impossible. By March 6th, we have the first confirmed case. And by March 15th, the president declared a state of national emergency and lockdown with very strict controls of citizens' movement, except to purchase food or pick up medicines and use. And also very early, there was this rule to use masks. You can see the military was in the streets, and remote work was introduced, and only workers from critical sectors were allowed to commute. Then the national borders were closed the following day, and the schools were also closed. And actually, we have and I'm not going to go into everything, but very early we have every single measure that other countries have done. We even started a quarantine hospital. However, I have to say that because it was called isolation hospital, nobody wanted to go. And when people was forced to go to these hospitals, they were just leaving. So one of the things that happened that was really critical at the very beginning of the pandemic was that, number one, we didn't have the laboratory capacities. Only the National Institute of Health was able to do, from the public sector, was able to do molecular testing. Unfortunately, the government didn't respond the way we were asking them, because although this was the only laboratory, we had, at least in most of the regions in Peru, we have 24 regions, we had academic laboratories that had the capacity to do molecular testing, but they were not included in the network for testing for the country. But the other problem was that there were no enough supplies. And so at that point, and I think we were one of the very few countries, very early in April, we decided to buy serologic tests, these rapid serologic tests. There were like 1.5 million just in April that arrived. After validating the test, because we have a study to validate it, it was implemented for the detection of cases. The idea was that to use this type of test, and if it was positive, we considered the person to have COVID. And if it was negative, people should be having a PCR. I mean, that was the algorithm that was supposed to be used, but the fact that the test was so easy, as you will see later on, make it so popular that we even started having like a black market of rapid tests. And unfortunately, the rapid test became the way of making the diagnosis, but also people started to feel that having a test meant that they were not sick and there was no risk of infection. So they had this false sense of security, which was really terrible. And every single policy of the country was based on the rapid serologic test. And finally, this is another thing that is interesting, is that we started to have a definition of confirmed infection, which is completely different from other countries. Any patient will be considered a confirmed case if they have a test that is positive to PCR or a serologic test with or without symptoms. And actually, most of our cases had been diagnosed with a serologic test. So this is what happened, okay? We had the first case, we started very early with the mandatory use of masks, and the cases started racing, and this was our first wave. There were some closures and some openings that they call the different economic stages of activities, okay? But eventually, we had our wave and kind of survived, but it was really critical. People were coming to the hospital at the last time. We didn't have enough oxygen, and our hospitals were completely overwhelmed. All the primary care centers were closed, and everything was done at hospitals, which was one of the biggest failures from my point of view. So this was the daily confirmed deaths in the first wave. And actually, everybody was talking about how high they were, and actually they were very high. But there were also, and this is an interesting thing, we started in 2016 a new system for online death certificates registration. And we started to improve it. I mean, I started this when I was a minister in 2016, and we continue following it. And in 2020, we proposed the government to use it, and it was used. And there were incentives also for physicians and for people to report deaths. People will receive money for the funeral if the death happening at hospitals or at home was registered in the system. So I think we have had a very good system for recording deaths almost at real time. So what happened after? Well, since we have all these rapid tests, we decided to do some serologic studies that were done in November 2020. And we found that about 40% of the population in Lima had detectable antibodies against SARS. And in areas like the jungle in Iquitos, almost 80%. So people started feeling that nothing was going to happen, that we were almost having herd immunity. And plus, we had all these changes of presidents and protests, etc. And a second wave started in December 2020. After these economic openings, the preparation for the holidays, the festivities, and because people were starting, and people never thought that because summer was coming, we were going to have this second wave. In June 2021, the National Institute, for the very first time, because as I said, our laboratory capacities were very limited, released the first data from a study of 1,700 samples, where they showed that we had a new variant, the variant Lambda, that represented about 71% of the cases. We had 14% of gamma. And for the very first time, the Delta variant was found in the country. Actually, it was found in the southern part of Peru. And later on, we have found few cases of the Delta variant in Lima. But this has been just recently. This is what has happened, the first wave in 2020 and the second wave in 2021. And now we're using even antigenic tests to find patients. And right now, we are seeing, although we have found the Delta variant recently, we have seen that the cases have been coming out. We have been able to do testing in about 15 million people. And these are the curves of the confirmed deaths. And unfortunately, this second wave has been even more terrible. People were dying inside the hospitals because of the lack of oxygen, on ventilators with no oxygen. And there have been all kinds of things associated with corruption, as you have heard before, been corruption with oxygen, ICU beds, medications. And one thing that was also terrible is that we have the same issue as in Brazil, that the government decided to recommend packages of treatment with no scientific evidence, with hydroxychloroquine, azithromycin, ivermectin. And we have had also cases associated with this black fungus. And unfortunately, when you look not only at the numbers of deaths, but the excess mortality, you can see the red lines there. We are the champions of the world, which is one thing that is terrible. There have been other impacts. Although we have all these lockdowns, and I love what I heard from our colleagues from South Africa. Yeah, we also have this economic insurrection. I mean, people could not stay at home during the lockdowns, and they started coming out, and because they had to get the money in the streets in order to survive, because 72% of the population has this informal, unregulated economy. And that has probably increased at least 10 points. Employment fell 20%, the poverty rate has increased. And although the government tried launching a program of economic compensation to protect the vulnerable population and to support the businesses, they started some cash transfers, but everything was so delayed and we were not prepared. Our banking system was not prepared and people were not used to do electronic transfers or electronic processes. Education has been also affected due to complete closure of schools and universities. We're still closed. Teleeducation strategies were developed a little before the pandemic, but however, the problem is that, and they were using internet, television, radio, etc. However, we have parts of the country, it's a country with lots of inequities, where it has been very difficult to reach students, and there has no formal evaluation of what has happened yet. So Peru's coronavirus response was right on time. I mean, we have done everything that was said. I mean, we even had hospitals for quarantine and we tried to do things. But why we were hit so hard? Based on the comparison of deaths in 151 countries relative to the population, unfortunately, Peru is in the first position with 6,005 deaths per million, okay? So I try to summarize here some of what I think are the most important things. Number one, the contextual factors, the poor housing, the overcrowding, the social norms, because people, I mean, in Latin America, we're used to live together. We have these extended families. I mean, we are close. It was so difficult for social distancing. And it was so difficult for people also to use the masks, informality, the politicized environment, the distrust of the government, and the slow governmental responses to support the population. And the result was that people were not following the lockdown. At some point during the pandemic, we have more people that were taken to the police station than the people that were infected, because people didn't care. Social distancing, the strategies were very difficult. Mask use was difficult. And there were so many difficulties isolating people isolating cases at home. We had families in one room with 15 people living there. We had a limited laboratory capacity and lack of supplies and PPEs. And that undermined the implementation of inadequate case identification tracing strategies. Just in this second wave, the government started creating these teams that were going door by door and were distributing the pulse oximeters. The problem is that people were not very well explained about the pulse oximeters, and people started thinking that pulse oximeters were for diagnosis. So there had been so many things that were not very clear in the communication too. The massive purchase and the use of serologic rapid tests was initially very helpful, but it was not good for early identification and isolation of cases. It induced also a delayed deployment of capacities for molecular testing because everybody was feeling so comfortable with it. It was overused. People felt that it was like a health certificate to have a serologic test that was negative, and it gave a false sense of security. Some people were taking serologic tests to have parties or to go to work and be all together without masks. Another factor is the weak health system. We unfortunately have a hospital-centered pandemic response. Primary care centers were closed. The government said that it was because of the lack of PPE and the risk for providers, but actually this lack of primary health approach or pre-hospital, pre-ICU approach caused the hospitals to overwhelm. We had no ICU beds, no oxygen, and other health problems were ignored. Although telemedicine started and has been used, but it hasn't been evaluated. The use of medications without evidence had been a big problem. There were treatment guidelines and scientists and experts, we were completely against it, but the government didn't listen. And they started distributing treatment packages door by door with hydroxychloroquine, azithromycin, and ivermectin. And that caused adverse events, toxicity, antimicrobial resistance, complications, and self-medication because people, if the government is doing it and they are not bringing it to my home, I will buy it. And at some point we ran out of lots of medication. There were no antibiotics because people were taking it. And they were taking it as if it was preventive. And it caused a false sense of security. There had been also a lack of communication campaign, inadequate information about public health measures, and unfortunately, there was no community involvement. And the government, instead of bringing everybody to the table, they were trying to do everything themselves. So the population was not following the lockdowns, the social distancing. The population was confused, and the community didn't feel that they were part of the response. So what about the COVID vaccine? Well, because of this political instability, because we're a small market, because of the bureaucracy, and probably because of the abusive conditions set by the companies also, and our poor experience of negotiation, we were very far behind on trying to access vaccines. We were able to sign a contract with COVAX, but COVAX had a very slow distribution. Although we have a national plan for prioritization in October 2020 with different phases, which means starting vaccinating the health providers, then some critical workers, and then people with more comorbidities and by ages, there were several adjustments that were done. The initial negotiations allowed us to buy the Sinopharm vaccine. Initially, we were told that we were going to buy 40 million doses, but eventually only 1.5 million doses arrived the country. The vaccination started in February, but it was very slow until June. That is when we have started catching up. Now we are at the level of vaccinating people that are 40 years and older, and we're using the Pfizer vaccine. The public are very receptive, and right now we have at least 3 million people that have received one dose. That means 9% of the population, about 4.38 million people that have received 2 doses. And that is because the transition government was able to sign some contracts with Pfizer and recently also with AstraZeneca. And apparently with the vaccines that COVAX is bringing, we are having right now more vaccines available. So you can see here, United Kingdom, United States, South America, Brazil there, and Peru, and you can see how we are catching up starting in June, and we hope it will go up. Even these weekends, we are having what we call the vacunathon, which is kind of like a campaign. So they are like 24 hours Saturday and Sunday, the vaccinations areas are open to anybody who is lacking, for example, their second dose. So everybody can go and or are that they are on the right age. So anybody who is less than 40 can go at any time, even at midnight or any time. And we have seen, and this is things that we are showing, is that, for example, COVID mortality in physicians compared to general population really started to go down once the vaccines were given. And I guess we are used to trust vaccines, but with this type of data, people want to have vaccines and they are making queues from one day to the other in order to get vaccinated. So what are the conclusions and the lessons learned? Peru was having a very good economic situation. We had the money, we have the cushion money to have a good response. And actually we started early with the restriction and prevention measures, and several are still ongoing, but we have been hit very hard by the pandemic. And one of the things that I think has been critical are the contextual factors. As a country, we will need to redesign social protection strategies, address inequities, and work with vulnerable populations. But one thing that is very, very critical is political stability and clear leadership. I think that has been one of the things that had not allowed us to have a real good response in the country. We need to invest in strengthening health systems capacity. Our primary care system is really very weak. We lack ICU beds, and we knew that when we started. We have less than 500 beds for the country. Right now, we have almost 3,000 or 3,500. So we were able to increase them, but it was not enough. Oxygen, human resources, health information systems, and laboratory capacities are things that need to be addressed. Rapid tests were initially a useful alternative to the shortages of molecular testing in Peru, but contact tracing and isolation were not effective. So it's not just a matter of testing, but testing and having a good response. And to have a good response, we need to have the social protection strategies that will allow people to follow the rules. Decisions should be made on the best evidence available. We need science, we need implementation science, we need behavioral science, and we need the government to really understand that. For the lack of supplies, I think as a region, not only as a country, we need investments in technology, and we need to have some technological independence in the region. Effective communication and transparency is something else, and community engagement for public understanding, preparedness, and responses are critical. As a country, we have been a model for community health agents, but they were not included in the response, and I think that was a failure. And that's it. I'm looking forward for the questions, and thank you very much.
Thank you very much, Patricia. I think we again sadly see this universality of images that Sachit told us. I bring another similarity with Brazil, is the political crisis. Both Peru and Brazil had just lived a coup of state in similar ways just before epidemics hit the countries. I think this part of the explanations of what we live today. I'd like to address all our participants, all our professors, the same question of how each of you see, one, the role of primary health care in vaccination in the next few months, and two, how do you see the behavior of epidemics in this next year? I would say year of some months ahead, that we can just feel the impact of vaccination and the possibility of getting to the threat of collective immune response. So I'll ask each of you in the same order we began. So beginning with Winnie about these questions. And while that, we also wait for questions from anyone by YouTube, by the chat.
So thank you very much. In the case of China, in terms of vaccination, China is not really relying on primary healthcare centers to do vaccination. It's a mass mobilization effort and using the community to mobilize. And there are these huge vaccination centers, or I mean, it's almost like what we see in Boston doing it in Fenway Park, that kind of approach to get people to get mass vaccinated. And some of them are primary healthcare providers. Some of them are not even that. They're just trained to do vaccination, and that's why they're doing it rather quickly. The problem with China is that many people have been vaccinated with Sinovac because they are producing two types. The first type, Sinopharm, has been exported. Sinovac is the one that is used to vaccinate its local people. And increasingly, there is evidence that it is actually not very protective against Delta. So to what extent China actually need to get people to do a third booster? And someone who is at the Center for Disease Control a few days ago was having dinner with my colleague. He even said maybe we need another 2 booster. So I think that's where science and implementation and government policy is not aligning. I think that's where China is a little bit falling short in terms of, yes, they're able to get a lot of people vaccinated, but are they vaccinating with the most effective vaccine? That's a slightly different question. In terms of behavior, I think that, I understand from other conversation and presentation that it is very hard to get people to wear masks, wearing it the right way. It is very hard to get people to go to test if they need to. It is very hard for people to do a lot of things, which is behavioral, right? If they need to be isolated, they actually do stay in isolation. I do not have a good scientific response. I do not think it is simply because Chinese are more obedient. I think, again, it is, if you would ask me, is 2 things. One is the way these information are communicated to people. It is not completely through the government. It is through the communities, the people that they already have been working with. And I tend to agree with Sue that yes, China was able to do it is because they already have that infrastructure. That community actually started in the 1960s, right? It's sort of part of that barefoot doctor system. That system doesn't work, but that sense of a community is still there. So they are the one who is doing most of the things that have an effect on behavior response, because behavioral response is just so hard to get the government to make change. It has to be the people around you whom you interact on a daily basis to do it. So what are those that are in Brazil or in other countries that you can mobilize would have to be really locally adapted.
Thank you, Professor Winnie. Sachit, would you please?
Yeah, thank you. India in particular has a very robust public health system that can deliver when it works. Vaccination campaigns in India, as also election ballots, have historically reached the farthest corners of India. The mechanism to get the vaccines to everyone in India exists. Vaccine procurement is the biggest challenge. Of course, in India, we're lagging behind. There are days when folks are trying to get the vaccines, but vaccines are not available and they have to wait. Vaccine hesitancy, the numbers are unclear. There is more vaccine hesitancy than there has been in the past, but globally this, is unfortunately a manufactured problem. And what we I think have to worry about is the impact that this vaccine hesitancy is going to have on childhood vaccines, where you typically did not have great amounts of vaccine hesitancy around the world, and whether there's going to be a spillover effect. In terms of behavior of the epidemic, I think vaccination is going to be our Achilles heel. If you look at these numbers, only 1% of people in low-income countries have received at least one dose, right? 70% of the world has not received a single dose. This is the opposite of where we need to be. This is sort of beyond science that I feel legitimately qualified to speak about. But, if there are variants that weaken the efficacy of existing vaccines, we'll always be playing catch up. And as we have seen repeatedly, right, what we need to do is have community solidarity and a little bit of self-discipline. But the politicization of the public health response to the pandemic is, I think, the greatest barrier that all our societies are facing.
Thank you, Professor Sachit. So, Professor Susan, please.
Yeah, thank you. So I completely agree with my colleagues. I think in South Africa, what's been interesting is one of our provinces, which is the poorest and has very limited health services, not great health services, Limpopo, but they did the best when it came to vaccination, and that was a total mobilization process. So they basically went door to door, talked to people, got the local leaders vaccinated first, and so on. So I think that bringing in the primary healthcare sector is critical, but remembering one of the issues about primary healthcare, and I think one of my colleagues mentioned it, that during lockdown, people couldn't access. So all the childhood immunizations, we don't know what's happened to chronic illnesses. One of the benefits in South Africa around chronic illnesses is that we started this auto dispensing, well, it had been started for HIV patients, but now people with chronic illnesses went on. So you can get your 3-month supply from a ATM type machine. So I think that's been good, but we don't want to overload the primary healthcare services so that women can't deliver happily and children won't get their vaccinations. I think the second question about the behavior of the epidemic and people's behavior in the epidemic is difficult. It's going to have to be, as people say, of course, vaccination is the answer, but it's going to have to get to a point where people, I think, will be wearing masks fairly permanently for quite a long time. It's going to become the norm. We're going to all feel comfortable wearing masks because that's how it is. And we're going to have to treat this epidemic like flu. And flu is not harmless by any means. People don't realize. I know in South Africa we have 11,000 deaths a year from flu. So I guess at some point it's going to normalize and become another flu.
Thank you very much. Professor Patricia, please.
Yeah, thank you so much. So I think there are so many similarities, right? Because the primary care centers have been closed, right now what they are trying to do is they are trying to rebuild their capacities to try to catch up on all the diseases and the vaccination that is around. Having said that, what happened in Peru is that what has been created, well, actually not created, it's like we're using the experience that we have with massive vaccination campaigns in this COVID one and making it even bigger. So we not only have the people that have been working in primary care, because we need some people staying at the centers, right? But we are also involving even military that had been trained on how to put the vaccines, okay? So when we have like a mixture, we have primary health centers that you can go to get vaccinated. And actually every Peruvian has a DNI, which is your national identification number, which is unique. So using the same system for voting, so people had been arranged depending on where you live, where you are supposed to go. But if for some reason you miss it, that's what we have now, these campaigns called vacunatones, which is like Saturday and Sunday open for you. And if you are in the right place, you can go. So we have a mass campaign plus some centers that are already working there. But I don't think we can overwhelm the primary care system because it needs to start working again. One interesting thing that probably, we were looking at numbers right now. We were calculating the numbers of how many people had been vaccinated. We have reached about 80% of all the people that are 80 years and older so far, and about 70% of all the people that are 60 years and older. But what happened is that also, that population is, we're a younger population, so we still have to vaccinate all the rest. But what I'm trying to say is, we have about 30 to 40% of the people that are 40 years and older, but people are queuing, waiting for their vaccines. The problems have not been how to vaccinate or hesitancy, but the availability of vaccines, which I really hope, because supposedly we have signed all the contracts, etc. With the change of the government, this is not going to stop. Regarding the behavior of the epidemic, I completely agree. I think this is, and WHO has already said, this is going to become endemic. But the desperation of countries like mine, like South Africa, probably India, is that unless, and it should be the desperation of high-income countries too, unless everybody is vaccinated, maybe, because this is the risk, another variant will come out and we will need to start again doing all the vaccinations. Right now it looks like the vaccines are covering for the worst things like the severe disease, but this may change, okay? And talking about the behavior of people, I think this is the moment in which people has to understand that vaccines are great, but they are not impenetrable, okay? And because of that, we still need to use masks. And I had a question for our Chinese colleague, because one of the things that I remember, and don't take me wrong, but every time when we were receiving Chinese tourists, they were using masks, okay, several times. So they were used to use masks. And people were, even in my country, seeing Chinese people with masks walking around, they were like, what do these people have? They are crazy, right? And that was before the pandemic. So I think another thing that has been important for you, probably, don't you think, has been for China, the experience of having SARS before and MERS and all those things that we never thought were real in this part of the world, at least. And that has helped also to a better response. I guess you have good memory, or Chinese had good memory also, because that's what I fear. I fear that after this terrible event, people will forget, and with the next pandemic, we will not do things the way we are supposed to.
Let me respond.
Just a minute, Winnie, just a minute, because I have a similar question from Marcia Castro that is with us. So I ask Marcia to bring her question.
Winnie, you can answer first and then I'll ask the question.
My sense is that my question to you is yes and no, in the sense that, yes, I think their resistance to wearing masks might be smaller. But if you see how in China, even today, they are willing to put on a mask, they're not in crisis mode. I do think that without education, persuasion, they will be doing it. And I think part of the education and persuasion, which I think is very important, is the sense of what you are doing have an effect on your neighbors. I think that sense of the self and the community, it is essential because people are not wearing it for just themselves. And same as the message that goes out to vaccination, it is not just about protecting yourself. There's also that sense of, as long as you do not get to this much percentage of herd immunity, basically the country will still need to be closed and all of that. So there is also that sense of you and the community. There's a sense of what you're doing has an effect on others as well. And I'm afraid that actually its effectiveness would vary by country. Social value, the value of whether everything is just about oneself or whether people care about your actions' impact on the larger society. So,
okay, so let me follow with a question now, which has to do with you are all discussing. So communicating things, right? So you would imagine that in the middle of a pandemic, countries would organize a mass communication campaign to bring the right information to the population, right? Seems reasonable. And in the case of Brazil, we have a history of doing that. But of course, during this pandemic, that wasn't done alongside many different things were not done. So my question is sort of two-part. One is, was anything like a mass communication to sensitize the population, bring the information, get adherence to strategies, was it done in the countries you talked about? And the second thing is, I think we got a good mix of trying to use community health agents or whatever name is, but somebody there at the local level. And then the examples in Patty were very direct. They didn't involve community health agents. Brazil didn't involve either. So I don't know if there is some kind of role like this in South Africa or India. So why do you think that didn't happen? And I can give you one example in Brazil. Right in the beginning of the pandemic, there was a protocol issued that if you start reading the protocol, it says, well, this is what the community health agents should do. They shouldn't go to the houses. They should work in healthy units. And then if you keep reading it, it says the opposite. So it was so confusing. Nobody knew what to do. And because Brazil is big, we had some community health agents working with the support of different actors in the community and others that just went in an office and tried to reinvent their work. It was a mix, but basically they were not part of the response. So if you could talk a little bit about those two things, the mass communication and the role or the complete lack of a role of a local person in responding, but also bringing the information. Thank you. Any order, you can just...
Okay, can I start? Then I'm happy to start. So in terms of mass communication, there was some mass communication, but because communication is my kind of field, I was horrified at the lack of depth of it and also the lack of listening and testing. So people, if you don't test your communications, you don't know how you're coming across. And for me, that was the biggest problem. They just sent out messages randomly. I think that it also was very erratic. And even now, there's very little happening. You need constant reinforcement, communication, getting to people and listening to people. So for me, that has been a huge gap in South Africa. I think in terms of the community, we've got what you call community health workers. So the base on which we're starting is that we have, I think there's 600 and, no, I don't know how many, let me not say, but they are very poorly paid. They're not properly included in the health system. And when the government decided who were essential health workers who needed to be vaccinated, they were not included. So their use as vaccination agents was so limited. They weren't included. They were encouraged to go from house to house to reach people. But of course, it was dangerous. They didn't always have PPE. Yeah, it was a disaster.
maybe.
Sorry.
No, go ahead.
Please go ahead. No,
Go ahead.
Okay, so regarding mass communication, so this is something that, I mean, in general, not only mass communication, communication about the pandemic. In the country, the president, the second, I think, he decided to be himself who was giving the numbers and telling things, okay? And there was no campaign really at all. And actually, it was so interesting because without thinking about it, I ended up being in the TV, in the radio, explaining the journalists, trying to make things much more clear and trying to give messages. But it was not only me, it was like several experts trying to fill the gap of communication that was not there, okay? I mean, I have to tell you that I was invited. I even had a TV show, okay, a real show, 1 hour a day in the national TV channel, responding questions and social media, etc., about the pandemic, because there was nobody from the government doing that, okay? And that was in the first wave. In the second wave, I mean, even the private sector was offering the government to sit down and create a campaign. But I don't have any idea why this was not really thought about. I mean, we have very good experts about this. And eventually what happened is that they created messages that were also, as you said, erratic. They never tested them. And some of them were so crude that people could, I mean, you could see that people were saying like, I'd rather not see it, okay? This is terrible. And so they were so scary, some of them, or so complex that, and they were never really steady, okay? So basically, I think the communication, except for the media, I think the media in general, the TV, the press, etc., were trying to fill the gap that the government was not able to fill. And actually the experts, we were doing kind of the same thing, although we are not trained for this, okay? And so I think that has been a real big problem. And on the other hand, we have all these social media bringing all these fake news, myths, and other things. So it was very hard. Regarding the second thing, why the community health workers were not involved, okay? So one of the things is that community health workers here are not properly recognized by the government and they are not paid, okay? Although we were able to release a law, at least to have them recognized, and we have a database of all of them. But basically, they were completely ignored. Actually, all primary care was completely ignored. When I talked with the government, why primary care was closed and why we were not including community health workers, the answer was we don't have enough PPEs. And we think that there is going to be more harm and we can handle everything through the hospitals, okay? And that proved completely wrong. So some of the municipalities, we have some examples of municipalities in certain places that organized themselves and started working and helping some communities, etc. But the problem is that that ended up just as little examples of something that didn't work. The policies didn't include at all community health workers. Everything was the hospital. So the policies were closing anything that had to do with primary care or things that were closer to the community. And I think it had to do also with fear, okay? So fear, maybe the lack of protection, and the fear had two things, okay? So one was the fear of the disease, and the other was the fear of the government from the unions, because the unions were really, so the unions of professionals, I mean, they were really also scared about the high rates of health professionals that were dying. And so it became a very complex situation too.
Thank you, Professor Sathi.
Thank you. I have to acknowledge again, just the universality of these problems. Just if I had walked into you speaking not knowing what you were talking about, it could have been so many countries that we're representing here. I have 3 points to make about communication. Communication was very effective was effectively used in India for messages that the government wanted to communicate. And unfortunately, it ends up being the pandemic theater, right? So large brushstrokes that sort of look like sweeping interventions from the government are given more stage. The head of state has been on television a few times and enjoys, or at least in 2020, enjoyed vast popularity across India. People would do what the head of the government would ask them to do, including a one-day trial lockdown that he went on national television and asked people to do, and people voluntarily stayed at home. This was just a few days before the actual lockdown. Including peddling the digital contact tracing app, which had not been piloted, which had not been tested, which had not been validated. You have a head of state going on television, various arms of government, senior government representatives, right, encouraging people to use the digital contact tracing app. That same zeal has not been seen by heads of state asking people to mask. The masking experience, especially through Mushfiq's work, has shown that it is really important to get the local community representatives, people that individuals respect in their own microcosm, in their own society, to ask them to mask. After the erosion of trust in government in so many communities, it wasn't, the Bollywood actor masking that was going to have as much of an impact as the local imam in the mosque or the local village leader, both demonstrating masking by use and by example, but also encouraging people to mask. I want to acknowledge what the scientists have been through. I think we're learning the importance of translational science. Many of us who felt comfortable and thought it was appropriate for us to stick to the science and then leave advocacy to others. I think 2020 has shown that space gets filled up by folks that don't know or don't know much. And each of us, I think, has examples, as Patricia shared, of having spent so much of time on podcasts and op-eds. I've written more op-eds in 6 months last year than I have ever had in my professional career. And whether that is the most effective means of communication. And in India, it certainly is not, because we're a little, English-speaking bubble. We're still failing to communicate with a vast majority that are then consuming information through social media. I think this also raises questions about accountability. In many of our countries, people are jailed for saying things that may be inconvenient truths, right? For littler things. And yet there is no accountability for the misinformation that directly results in foisting such misery upon populations, right? And I think these are questions that the scientific community is going to have to engage with policymakers in terms of understanding what freedom of speech means in our various contexts and where what amounts to screaming fire in the theater. Community health workers have finally been used in India, and quite successfully. India has 1 million ASHA workers. They're India's community health workers, and several hundreds of thousands of others. Civil society organizations have mobilized to use ASHA workers. The Community Science Alliance that I talked about has really protocolized what the ASHA worker needs to do. And as all of us have acknowledged, distributing pulse oximeters doesn't cut it. We have to support these community health workers to walk, not that last mile, they're in the last mile, but those last 10 feet, right? Understand how to use that pulse oximeter, call someone every day, 2 or 3 times a day, understand what their oxygen saturations are, and then intervene upon it. And just those last few steps are not done because, again, that's the unsexy component, right? It's your grand sweeping distribution of pulse oximeters gets you the headlines. ASHA workers, calling 3 times a day to make sure that someone's actually paying attention to the oxygen saturation doesn't. And I think the cure is in the details. And I think we need to do a better job of that universally. Thank you again.
I'll just be very quick since there's limited time. China definitely, for things that they want to communicate, they definitely have a very effective communication strategy. And I think that's partly the Communist Party's strength. The propaganda engine, if they want to use it, it is just very powerful. Every state, every lesson, every advice is all cast in these 3-character sentences that rhymes, and it is on the wall, it is in the television, it's through radio, it's on your app, and children, they would have video which is produced specifically for children in cartoons. There are other videos which is for different kind of population. You don't need to read, you just need to understand that 4-character. So that's done really well. However, do remember in the beginning stage when the government was trying to deny the situation and therefore do not have the right information sent to the people, and yet there is this doctor whose communication with his own colleagues were leaked. That was the period of a month that the whole government and the party was actually seriously threatened in terms of its legitimacy. So yes, communication is important, but do it right, because if you don't do it right, you can be in serious trouble too.
Thank you. I'll get to Vera, who asked for the word.
Can you hear me?
Yeah.
Okay. So thank you, all of you, for the wonderful panel we had. And again, for the quick and recent invitation that you accepted in this moment of the pandemic and summer and winter here, right? Break. I got many comments that we don't have time to discuss right now about the consultancy firms giving more advice than the scientists everywhere, and how much did it impacted on the hospitals, on the curves, the models and curves that doesn't say anything, people who does not understand anything about public health and community health and social and collective health, right? And the hospital-centered response that we got without using our knowledge on the importance of community health, primary health care, and et cetera, from other times, right? Also, just to stress and invite you already to indicate good people for the third conference that we are getting, that will focus more directly or more we'll have the focus on behavior, individual responses and individual vulnerability, sex in the pandemic, and the synergy of the pandemics, right? So if you have any suggestion for us from the people you know from the BRICS, right? and as we used to call it years ago, from your countries, please let us know. And ventilation, yes, it's been a problem. Nobody is including ventilation. Sue is totally right? And I just wanted to, after that, invite all the audience that we have in YouTube to come back at 2:00 to see the next sessions of today, which is the long-term impact of the pandemic with Professor Noreen Goldman from Princeton University, Cássio Turra from UFMG, Professor Aloysio Segurado, who is with us in this room, and the moderator will be Adriano Massoud, who was in Cambridge and Harvard for a long time and now is at FGV. and finishing with a wonderful keynote speak by David Williams from the Harvard School of Public Health on race and COVID mortality in the US and UK, moderated again by dear Marcia Castro, who I thank again for your support and presence today. So thank you very much. I hope to get input from you for the next one, and see you.
Bye. Thank you very much, Vera, Lorena, Marcia, everyone that has coordinated the seminar. I think it is a good opportunity to learn about the experience and unhappily see that there are similarities we wouldn't want to have, especially when you see denialing science and the abandon of such important dimensions like primary healthcare systems and communications. So unhappily, we have to cry about our similarities, and we now put our hope that it can get a vaccination faster and take us to another situation. Thank you very much for all, and see you in the afternoon.
Bye-bye.
Bye-bye. Thank you.
Bye-bye. Thank you very much.
Thank you.
Som. Pronto, professor.
Okay. So, hello, everybody. My name is Adriano Massuda. I'm a professor at Fundação Getúlio Vargas. I'm studying health system and management, and I'm very happy to join this event that started this morning discussing the pandemic. The COVID pandemic is not only a virus problem, but is a issue of how we could organize our health systems. And today we're gonna doing the continuity of the event. This event organized by the Institute of Advanced Studies of USP, with in cooperation with the Dave Rockefeller Center for the Harvard University for Latin American Studies at Harvard University. So I'm very happy to join this event, and we're gonna discuss now the long-term impact of the pandemic with three very special guests. Professor Noreen Goldman. She is a professor of demography at the Princeton University. Professor Aloysio Segurado. He is a professor of infectious disease, a full professor at the University of São Paulo. And Cássio Maldonado Turra. He is professor of demography at the Federal University of Minas Gerais. So we're gonna have 20 minutes of presentation for each one of our special guests, and then we're gonna have 1 hour for discussion. So I think to start, I would like to invite Professor Noreen Goldman to open our work for today. Thank you, Noreen, for your participation.
Okay, thank you. Thank you for inviting me. And let me share my screen. Okay, can everyone see that okay? I'll take that as a yes. So what I'm going to present today is the impact of COVID on life expectancy in the US and by race and ethnicity. And this is work that is largely joint with Teresa Andresfay from the University of Southern California. Okay. So to give it a little background, we started this relatively early in the pandemic when there were many news reports talking about the unequal burden of COVID infection and mortality borne by minority groups, particularly the Black and Latino populations in the US. The data were basically counts of deaths and counts relative to these groups' proportion in the population. And much of the very early news reports centered about New York City, which was the epicenter, as many of you probably read about during the very early stages of the pandemic in the United States. Okay, and many of us are demographers, we know that counts of deaths or counts relative to population is not a great way of measuring mortality impact, largely because these populations have very different age distributions. Latinos and Blacks, on average, being younger than the white population. So we made a set of estimates. We made the first set, as I've noted in the slide, that in October 2020, the first set revisited a few times, and it was published in the Proceedings of the National Academy of Sciences in February 2021. Those early estimates used partially projected numbers of COVID deaths since 2020 was not yet a completed year. Okay, we then updated those estimates in April 2021, and that appeared last month in JAMA Network Open. So I'll summarize mostly the updates. And then I'd like to go on and say something about how these estimates compare to those released just several days ago by the US Vital Statistics Office, what I'll call the Centers for Disease Control, the division that released this. And I'll focus, I should say, on life expectancy at birth, although we also looked, for example, at life expectancy at age 65. I won't mention that right here. Okay, so here are just the two papers easily available that I'll summarize in the beginning of this talk. And I'll try to pause every now and then because I know I speak very rapidly and I don't envy anybody trying to do simultaneous translation. Okay, so some of us are very familiar with the concept of getting life expectancy for a year. What it really is, it's a very hypothetical notion. It's how many years people could expect to live if they experience the mortality conditions, that is, the death rates of a given year throughout their lifetime. Another way of saying that is, with the example of 2020, if those rates stayed the same for the foreseeable future, right? And nobody is subject throughout their life to the death rates of a given year. So no cohort will experience the kinds of numbers we'll be talking about, but it's a very good summary measure of what mortality impact there was in a given period. It's independent of the age distribution, and it allows us to make historical and international comparisons. Okay, so this slide shows the data that we use to make estimates of life expectancy in 2020. I'll focus here on the right column, the updated estimates, which didn't use any projections, used the actual deaths reported, although they are provisional because not enough time has elapsed for the Center for Disease Control to check all the deaths. They get reported at different times, to different levels of accuracy by the different states. In total, our estimates are based on 381,000 deaths that occurred during the year 2020. Okay, again, they're called provisional. We compared that with what mortality was in 2018 because that was the most recent year that was available at the time that we made these estimates. 2019 were not yet available, but we now have enough information to know the estimates would be almost the same. So by comparing 2018 to 2020, we're basically saying what is the impact of the pandemic compared to just before the pandemic. Okay, so I won't bore you with details of how we did the calculation, but let me just make a couple of rather critical points. Okay, so basically what we did is we took that 2018 life table and assumed that's what people would have been exposed to had we not had COVID-19 come into our lives. Okay, then we assumed that people who did not die of these other causes were also subject to COVID-19. So we essentially added COVID-19 mortality to what the life table told us before the pandemic, okay? So it makes a rather strong assumption that is that were there no COVID deaths in 2020, life would have gone on in the same way from all these other causes as it had done prior to the pandemic. We kind of call that an assumption of independence of causes, COVID versus the rest of the causes from which people die. Okay, so here are the results. Okay, the red is what the life table told us prior to the pandemic. It's labeled absent COVID-19. The blue tells us our estimates for 2020, adding COVID deaths to that pre-pandemic experience. The length of the bar tells you how much life expectancy at birth declined. You can see the estimates for the overall US population, Latinos, whites, and Blacks. Okay, and what should be immediately obvious just by looking at the lines is the longest line is for Latinos, a decline of just over 3 years in life expectancy based on our estimates. For the Black population, a decline of about 2 years and a little under 1 year for the white population. And I'll update these estimates a little bit later from the CDC. If we put these on graphs, which actually go back to about 40 years, it can show you that the single year decline shown in the dotted lines for each of these ethnic and racial groups is mammoth. I mean, it's a huge decline to be experiencing in 1 year, and no single year during this period has had such a decline. In fact, we either have to go back to World War II. There's some disputed numbers about deaths in 1942 in the US, or we have to go back to the 1918 flu pandemic to get a decline in 1 year as large as what we estimate for the year 2020. And let me make one more point on this graph, which is if you look at life expectancy at birth, it's probably going to jump out at you that the highest numbers are for Latinos. The lowest numbers are for the Black population. So that is to say, prior to the pandemic, Latinos had higher life expectancy than whites and much higher than Blacks. Something many of you are probably familiar with, something called the Latino paradox, a paradox in the sense that social and economic characteristics of the Latino population are far worse than the white population. Yet prior to the pandemic, they lived about 3 years longer on average than whites. Okay. So why these huge disparities? This is what has made the press for many months in the US. Okay, the persistent social inequalities, structural racism, these are the kinds of headlines that have appeared in the US to point to the much higher mortality burden among both the Black and the Latino population in the US. Okay, so there's higher exposure to COVID-19, there's higher mortality for those infected. Some of this breakdown into these two types of risk factors is a little bit arbitrary. But by and large, both Black and Latino Americans were more likely to be employed in what we call frontline occupations, jobs that could not be done at home, jobs that were often in informal work, jobs of relatively low socioeconomic standing in which workers were pretty unlikely to be able to protect themselves, and employers also were less likely to protect their workers. These are groups that were more reliant on public transport, that lived in crowded, multi-generational households. And there's an asterisk on some of these because these factors were especially true for Latinos, in addition to also being true for the Black population. And for Latinos especially, there were language barriers in terms of information about how the virus spread and how to protect themselves from that spread. And then both groups, but particularly the Black population, had higher rates of chronic diseases that might have made them more likely to get COVID, but was especially more likely to lead to severe disease, hospitalization, and potentially death. Things like hypertension, heart disease, cancer. For the Latino population, it was particularly diabetes and obesity. Okay, lower access to healthcare for both groups, and especially for undocumented immigrants, no eligibility for health insurance, but also for benefits during the pandemic, like unemployment, stimulus checks, and lower quality of healthcare for both groups. Okay, so what are the takeaways? The takeaways are clearly there was a huge impact on mortality decline for 2020, especially for Black and Latinos, but there will be an impact in 2021 in the US as well. So we made an estimate of what the impact was just through early April of 2021, and that implied a 0.6-year reduction in 2021 life expectancy compared to prior to the pandemic. So the decline will probably be less than we estimated for 2020. We estimated 1.3 years, but as many of you know, deaths are continuing to occur at lower levels because of vaccination, but yet very uneven vaccination uptake in the US. Okay. Through early April, there were 159,000 deaths that led to that projection of 0.6 year. As of today, it's about 225,000 in 2021. So these disparities will persist. These data indicate Blacks and Latinos continue to die at higher rates. And these are also the groups who are less likely to be vaccinated. So those differentials will persist and potentially increase. So I ask now about the accuracy of our estimates, okay? The death information is provisional. It continues to be provisional. It takes the CDC a long time to get all the data in and do their final checks. But the issue that concerns me, that concerned Teresa and myself as we were doing this, was that assumption about independence of causes of death, right? If there had not been COVID, death rates would have looked just like they did prior to the pandemic. And the only thing that changed in our assumption was that COVID deaths got added. There was no allowance for other causes of death to potentially have increased or decreased because of the pandemic. Why do we make that assumption? Because we only had mortality data for COVID deaths. We didn't have all deaths in 2020 at the time. In fact, they've just come out in the last few weeks. But there's reason to think, that other death rates may have increased in 2020, not just COVID. Other causes may have led to higher rates because care was delayed. People just didn't get treated because of fear of contracting COVID, of going into healthcare settings. The quality of care in many places was lower. Hospitals were overburdened, ICUs were overburdened, equipment was lacking. People had symptoms of COVID for many, many months, some still do, which may have increased risks of dying from other causes. There may have been, and there was, higher crime, higher external deaths, causes of death from external causes like drug use and alcohol use, brought in part, although not entirely, from the social and economic consequences of the pandemic. At the same time, death rates from other causes may have gone down. There is a phenomenon with a very unfortunate word called harvesting. That is, people who are already very sick in 2020, late stage cancer, severe heart disease, now exposed to COVID, may have died, I say first, from COVID, in the sense that if COVID had not come around, they may have died soon after from cancer and heart disease. And so we're not seeing deaths from cancer or heart disease at the rates we might have otherwise. And there's miscoding of cause of death, which could have led to under or over reporting of COVID deaths, especially in the absence of tests for infection. Okay, so in the past week, the National Center for Health Statistics, the CDC, which is part of that, provided their estimates. Their estimates are now based on all deaths in 2020, not just COVID deaths. So they no longer have to make this assumption of independence of causes as we had. And the question is, are their estimates consistent with what we got? And as you can see from the slide, there was a lot of press in the last few days. Even though much of this information had already been released from work that Teresa and I had done, from some papers others had done, this was the official US take on what the impact was in all of 2020 compared to what happened in their case from 2019. How much did mortality decline? How much did mortality go up? How much did life expectancy decline? Okay, so what did they estimate? Okay, first they estimated an overall decline of 1.5 years in life expectancy in 2020, which is slightly higher than our estimate of 1.3 years. Not surprising, since, as I said, we expected other causes to have increased, not just COVID. Okay. Their estimate for Latinos is a 3-year decline in life expectancy, the same as our estimate. Their estimate for Blacks is larger than our estimate. We estimated around 2-year decline. They estimated just below 3. What this means is the Black-white disparity, which had been about 4 years, Blacks lived about 4 years less than whites prior to the pandemic, increased to almost 6 years in 1 year. It had been 7 years in the early 1990s. That was a disparity that was gradually getting smaller, not small enough, but it was on a steady decline, and it now increased enormously in 1 year. The setback for life expectancy in the Black population was about 20 years, just based on 2020 deaths. Latinos experienced the largest decline of the groups they looked at. It was 3.7 years for men, a little over 3 years, men and women combined. 90% of that decline in Latinos was just due to COVID, more than for other groups. Other groups had excess mortality from other causes. For Latinos, it was primarily COVID. Male was higher than female mortality from COVID. The male-female gap increased, as has occurred in all countries for which we have reasonable data. Some causes did go up for 2019 to 2020. accidents, injuries, particularly drug use, homicides, diabetes, liver, while other causes of death decreased over this year, particularly cancer. And that may reflect this issue of harvesting that I mentioned, that people who had been in very late stages of cancer, also other severe lower respiratory diseases and heart disease, may have succumbed first to COVID. And interestingly, suicide went down contrary to maybe many people's expectations of what would happen in 2020. They did not produce estimates for other racial and ethnic groups because of high rates of racial misclassification, but I'm going to give you a 1-minute look at what happened to Native Americans, a group that got tremendous attention early on in the pandemic in the US, because they also, as with the Black and Latino populations, appeared to have very high rates. And I don't have life expectancy measures for them. So these are done on something that did standardize for age, indirect standardization. And this just shows you a little bit of the media attention that the Native American population received. So here is the graph. It shows you, if you simply looked at crude death rates, deaths per people, relative to whites, this is all relative to whites. These groups would not look so high. Latinos would not look high at all. If you standardize for age and county, you can see Blacks and Latinos have much higher rates than whites, but it's the Native American population that has by far the highest COVID death rate in 2020, almost 3 times that of whites. And my final slide, this is based on a paper that's in the medical archive site under review now, that says the rate in the Native American population is highly correlated with the proportion of Native Americans who live on reservations. These are largely American Indian reservations. And it points to the fact that these reservations, this is aggregate data. We don't have individual data that would link COVID mortality to these characteristics, but people living on reservations have higher exposure to many of the risk factors that we assume are important in COVID: crowding, multi-generational households, poverty, high rates of chronic diseases that make them susceptible to COVID, like diabetes and obesity, high rates of smoking, high rates of being frontline workers, and low quality of healthcare. And I thank you. And I thank you again for inviting me to this conference.
Thank you, Professor Noreen. Very interesting presentation showing the impact of the COVID pandemic, but how the impact of the whole disease in the American population and how unequal it was in different groups of population. Let's go to discuss the consequences of COVID pandemic in life expectancy in Brazil. And I would like to invite Professor Cássio Turra. As I said, he is professor at the Federal University of Minas Gerais. Cássio.
Thank you so much, Adriano. Thank you, Marcia, for the invitation. Thank you, the University of São Paulo as well. Let me share my screen. Is it okay?
No.
No? Sorry. Okay?
Good. Good.
Yep. All right. So, as Adriano mentioned, I'm going to talk about a recent paper led by Marcia Castro, a paper that I had the privilege to co-author on the life expectancy reduction in Brazil after COVID-19. So most of my presentation will be based on this paper, but I will try first to give some context in terms of mortality trends in the world and in Brazil, in Latin America, and also at the end, I will give more food for us to think in terms of long-term consequences for life expectancy in Brazil. So I would like to start by sharing one tweet I wrote on early March this year, when death toll in Brazil was increasing very fast. I guess I was really frustrated at that point. So my sentence here, these two sentences, they reflect my frustrations with the fact that we were. There have been at least 300 years, 250 years since the mortality transition started in the world. And at that point in March, we were kind of living at the mercy of the virus in Brazil with this increasing death toll. So I said the demographic transition represented the victory of order in a world marked by frequent mortality crisis. Had we not drastically increased control over death, nothing that we know today, economic, social, and political systems would exist. So these transformations in the last 300 years were really important. And we are facing this mortality crisis in a completely different scenario that mortality crisis used to happen in the past. So at least since the late 18th century or the 19th century, the world has witnessed increases in sustained fall in mortality, especially starting in Europe, Japan, and the US, and then later on in Latin America, Asia, and now in Africa. Increases in best practice life expectancy, so the countries with the highest life expectancy in each year, as we can see in the graph on the left, have been almost linearly since the late 19th century. The story is a bit more complex or complicated when we look at individual countries, of course, as we can see on the right side. Some countries have witnessed faster improvements in mortality. Others have shown some reductions. But when we look at the best practice life expectancy, what we see is this linear pattern over the years. On the right side, we can see, for example, that we can see mortality crisis happen during this time. For example, in the case of the US, we can see the Spanish flu in the 1918, the Second World War here for Japan, but they were then recovering and catching up. So there's a lot of discussion about what's going to happen in the future. Of course, we're going to stay on this line. Countries that are going to converge, diverge over time, but questions about the limits of human life. But this is important to have in mind in terms of secular trends for our discussions for Brazil and for the current scenario. In the case of Latin America, the mortality transition in Brazil started around 80 years ago. It started in São Paulo, Rio, in the south of Brazil, and then it reached other regions of the country. It was in the 1940s that life expectancy exceeded 40 years at birth, initiating what we call a sustained fall. But we were behind at least 4 or 5 countries: Costa Rica, Cuba, Chile, Uruguay, Argentina. All these countries started the mortality transition before Brazil. So Brazil started late, and as we can see here from 1970, that we were lagging behind these countries, but we have been catching up these pioneer countries over time. Although there is still room for improvements, mortality improvements in Brazil, if we take the Latin American levels as our best practice for the next years. So it was in this context of survival gains over decades that the COVID-19 hit Brazil and hit the world. There have been many calculations of the excess or mortality during 2020 and 2021. As we can see here from the Financial Times, these calculations that show the excess of mortality, measuring both the direct and the indirect effects of COVID-19, taking as a reference the trend, the historical trends. Right? But in case of Brazil, as we can see, and there are many reasons for that, the excess of mortality was somewhat high in 2020, about 22% of the expected deaths. And in 2021, it was really hard. At this point here, there was 67% excess mortality. And now I was just checking today, 65 now with the recent decline. But it's a very large increase in the number of deaths compared to previous years. Some demographers, in the first months of the pandemic, some demographers had written that age structure would explain all this difference across the world, but as we can see, this age structure is not the only explanation for the difference, for this large variation. Inequality is important. The supply of healthcare, of hospitals, the types of policies that governments put in place, labor market and types of residence, demographic concentration, and so on. So there are a lot of things that we need to take into account to explain this difference. In Brazil, the story has been really hard. So one very strong, powerful way of showing the excess of mortality in Brazil was by calculating the reduction in life expectancy. And that's what's the main motivation of this paper, as I said, led by Marcia Castro and co-authored by Suzy Guzenda, myself, Sun King, Teresa Andres Fay, and Noreen Goldman, who's in this section together, in this table together with us. So our main question was how strong was the effect of the excess of mortality of the COVID-19 pandemic on the 2020 life expectancy in Brazil at birth, at age 65, by sex, by state, and also in 2021, given that, as I showed, the excess of mortality was, the death toll was really much harder than in 2020. So for that, we calculate three different measures. The first one was the difference in life expectancy in 2020 and 2019. So we calculate life tables for both years and simply measure the difference in the life expectancy. The second one was what we call the cause-deleted life table for 2020. So we took the 2020 life table and we deleted the COVID-19 cause of death. Noreen already mentioned a lot about this, so I don't think I have to talk a lot about these methods, but they are different. One thing, the first method measures all the direct and indirect effects of COVID. We're getting everything, not only the direct effect of COVID on mortality, but also increases and declines in mortality of other causes. The second one, we are deleting only COVID-19 cause of death from the 2020 life table. And the third one, we added COVID-19 deaths to 2019 life table. We also measured the 2021, as I said, impact. And for that was a little bit more complicated because we didn't have data source data at that point. So what we did was to get to estimate what would be the expected number of deaths in 2020 if the life table for 2019 was working in 2021. So we estimate the number of deaths based on that. And then we added the COVID-19 deaths using alternative data source. And then we assume that, we did this for the first 4 months of the year, and then we assumed that after that, Brazilians would experience mortality based on the 2019 life table in 2021. We also estimate the percentage loss in life expectancy in 2020 relative to the gains that occurred 20 years before, and the setbacks in life expectancy for both 2020 and 2021. looking at how many years we went back in terms of life expectancy with this effect of COVID-19. So as I said, we used the same data, 2019 and 2020 same data. 2020 is provisional, right? We didn't correct for underreporting of deaths, maybe some underreporting of deaths for 2020, maybe larger than in the other years. But since we are measuring differences, counterfactual measures and difference between years, the effects of underreporting of deaths should be minor, unless there's some special underreporting levels in 2020, but we don't think this is going to be that different from the other years. So we use IBGE population life table projections, and as I said, for 2021, we had to use alternative data sources to estimate the number of deaths from COVID-19. So these are a summary of some of the results. As we can see, the effects are larger for men than women. As we know, there's have been a lot of news about this, but it's larger for men than women, regardless of the method that we use for both years, 2020, 2021. Another thing is that the effect for older age has been relatively larger in 2020 than 2021, which is probably caused by the fact that the disease or the mortality pattern of the disease has been rejuvenating since 2020 to 2021. And also you can see there are differences between the methods. So when we calculate the effect based on the difference between the 2 years using the whole all cause of death, we estimate the effect of 1.31 years in life expectancy at birth. It increased 1.92 if we use the cause deleted method for 2020. And the reason Noreen already mentioned the fact that for these two methods, we have to assume that COVID-19 is an independent cause of death. And that's probably the reason why we are getting higher impacts with these two methods. In the case of the difference, we are getting effects in both directions. So the increasing mortality due to COVID, but also declines in other causes of death. For example, because of competing risks, since people who are more fragile may be dying from COVID instead of dying from these other causes. But in 2021, the impact is larger, but again, it's a different method, so we cannot compare directly with the other three, but we know from the excess of mortality that the impact has been really large. And also, I must remember everybody that this captures only the 4 initial months of the year. And we assume that for the other 18 months, Brazilians would experience the 2019 levels of mortality. So probably this is, may get worse once we have the data for the whole year, unfortunately. The impact has not been uniform across the Brazilian territory. We have been following also the news about that. So when you look at 2020 only on the left side here in the map, these colors represent the impact at birth and age 65. Of course, they are correlated, especially in 2020. So the largest impact has been in the north region, Amazonas, Pará, and Amapá. In the south of Brazil, the center south of Brazil, which was the region that was the last one to be hit by the virus, has experienced the lowest decline in life expectancy, the smallest decline in life expectancy. In Northeast and Rio and Espírito Santo, they experienced like an intermediate scenario. This was 2020. In 2021, when you compare the decline at birth for both 2021 and 2020, we can see that Amazonas, Roraima, and Rondônia, Mato Grosso, these states were the ones that were most hit both in 2020 and 2021. So they have been suffering from the death toll in both years. And then we can see a change in the patterns as the disease hits the southern and central states. There have been like a larger impact in 2021 in this region compared to what had been in 2020. And while in the Northeast, at least in these three states, Bahia, Piauí, Maranhão, the effects were harder in 2020 than in 2021. So this regional parts are really interesting to examine in more detail, and they show how the disease is spread through the territory over the 2 years. This huge impact represented important setbacks in the 2020 life expectancy in Brazil. In this table, I will not go into the details, but these tables show the states, the life expectancy at birth, life expectancy at 65 in 2020, and what the life expectancy in 2020 represented in terms of the mortality levels in 2020 represented in terms of life expectancy back 10 years ago. So we calculated what would be the level of life expectancy in 2020 that corresponds to the life expectancy levels in the past. And dark red shows where the setbacks were harder. So of course, this includes males, the North region, Northeast as well, and showing that in 2020, this reduction in 2020 corresponds to returning to early 2000 mortality levels for those regions. It's a really important fact. So what can we expect for the future? In this paper, we concluded that life expectancy will not rebound in 2021. So this is something really particular in the case of Brazil, is the fact that we're going to have 2 years, consecutive years of mortality decline, of life expectancy decline. Life expectancy decline in 2020, and it will be at least stay the same, we stay reduced in 2021. Probably will decline even more in 2021, as we showed. We also conclude that the pre-pandemic trajectory of annual gains in life expectancy, the ones that I showed in those first graphs, will likely slow down in the future. And we presented a few reasons for that. The first one is the transmission and the death toll in 2021 that remains high. So I already talked about this. The second reason is the disrupted primary care services in Brazil because of the pandemic. So screening for cancer, the reduction in new diagnoses, the reduction in child immunization, the postponement of medical treatments, the worst health conditions in the population, all these things together can impact life expectancy in Brazil, at least in the medium term. That's what we argued in the paper. There are also the long-term consequences of COVID among the survivors. I talked that I guess we're gonna hear more about it in a second. But here we're talking in terms of the neurological, the cardiovascular, the pulmonary complications of COVID that may increase the risk of death of those who are now considered recovered from the disease. And this may happen in the next years as well, so affecting life expectancy in the next years. Economic crisis, considering that it may have worsening unemployment rates in Brazil, increasing and reducing family income, it may have an impact as well, even if indirectly, on life expectancy in the next years. It will depend a lot on our social safety net or income programs that we can offer to those that are poor. in next year and in the next months. And related to the reductions in public health budget. We don't know how this will, if the economic crisis stays longer, of course, this is going to affect our ability to fund public health in Brazil. And this may have also consequence for medium-term long consequence, not just the short-term consequence that we are talking here in terms of the life expectancy impact. Well, this is my own view. So this is what we discussed in the paper. So I would like to end with giving more factors for us, more points for us to discuss and think in terms of the medium long term. So I've added here a few reasons for seeing the glass as a half full. More cash, maybe more optimistic, but cautiously optimistic. I'm sure that maybe this is not the view from Marcia, Noreen, and other co-authors, I don't know. But I wanted to add these other points so we, in a way that we can have more discussion at the end of the table. So in terms of short term, I guess maybe we can get more optimistic if we think in terms of the high vaccination coverage that we can get by the end of 2021. If this is the case, and if mortality keeps declining, the number of deaths keeps declining like in the US, Israel, I guess we can get in 2022 a rebound in life expectancy and maybe coming back to 2019 levels. I think it's possible if we accelerate the vaccination coverage in the next months of the second semester of 2021. In terms of medium term, we have to think that some other factors. One is mortality selectivity. So as we've seen, there has been like a really huge death toll from COVID. And it may, one of the consequences of this excess of mortality was taking lives of people who are more frail, more fragile, that would have died in the next years from other causes, but unfortunately, very sadly, had to die or died in 2020, in 2021 because of the COVID-19. So this may have a positive effect in terms of life expectancy in the next years. Again, this adds to the discussion of the long-term consequences of COVID-19. I think these things go in different directions. That's why I'm adding these things here for us to discuss. The SUS, the public health system in Brazil, and I guess it gained support from the public opinion in Brazil. This is one thing that I was in a seminar the other day with a colleague from the UFMG, and we were discussing from the medical school, and we were discussing about that, how the university, the public health, gained support from the public opinion. People understood the importance of SUS, the importance of university, the importance. Of course, there are people that are denying science and so on, but a lot of people start to be aware about the importance of the university and the science and the scientific work and the public health. So I think this may help SUS to get funding for the next years, political support to improve funding. Economic recovery is a possibility. We don't know, economists don't know how much we're going to get in the next 2 or 3 years. The potential economic growth in Brazil is low now. We need to have productivity gains. So it's difficult to have like a huge increase, it seems, in the next years, but it can be, we can do better depending on how governments deals with the economy. In terms of long term, as I show in the first slides, there have been secular trends in survival. So we need to keep looking at the pioneers of this process because we are laggards. Brazil is lagging behind. So if other countries can reach higher levels of life expectancy over the years, it means that we can at least follow their trajectories, even if with some delay. So one thing that we have to look at is for the aging-related disease. So how Japan, other Asian countries, South Korea, France, Italy are going to deal with this aging-related disease, and how innovation, medical technology will help to reduce deaths from this disease and keep life expectancy increasing for these countries. In Brazil, as we saw, we are lagging behind. So I guess the expansion of education. Education is really important for mortality levels. There are huge inequality in terms of the distribution of schooling years in the Brazilian population. So if the education expands faster and we provide timely and effective healthcare in the next years, so that we can fight better disease, man-made disease that still kill Brazilians, that could be avoided, including infection disease, cardiovascular disease, and external cause. I guess we could expect mortality gains, survival gains in the next years, regardless of what we had experienced in the last 2 years because of the pandemic. So it's really important that we keep change our structures in terms of inequality, in terms of healthcare access, in terms of education, in terms of public health messages and policies, so that we can keep following this secular trends and keep on track for better and longer lives for our population. So that's my last slide. That was the second part of my tweet. And I said exactly that COVID-19 virus hit Brazil like several other countries. However, so I was really frustrated to be at the mercy of the virus in 21st century. After science, and at that point, vaccination was already a reality. After science has already given many answers, is unacceptable. It's going back centuries. It's jeopardizing our future. That was my feeling. Unfortunately, we haven't changed much since then, but I hope that we can manage this situation by the end of the year and revert this terrible impact that we experienced these 2 years. Thank you so much.
Thanks a lot, Cássio. Great presentation of the huge impact of the pandemic in Brazil and also the consequences for our future. So I would like to invite Professor Aloysio to let us know more about what we can expect in terms of the long-term COVID in Brazil. So Professor Aloysio.
Okay, so thank you. Good afternoon. Thank you very much, Adriano, for moderating this session. I'd like to greet my fellow speakers and also thank the organizers and in particularly my good friends, Marcia Castro, Vera Paiva, and Lorena Barberia for the opportunity. Let me share the screen. I'll change gears a little bit from what has been discussed by the previous speakers in order to bring a perspective of where I come from as a healthcare worker. So as I was introduced as a professor of infectious diseases, it is important to point out that currently, apart from my clinical job, I'm also managing the Central Institute of Hospital das Clínicas, which is the largest academic health center in Latin America. And we have been really involved and actively involved in coping with the COVID-19 pandemic in Sao Paulo. So that's my point of view, and I'll try to share with you my expectations and concerns about the long-term impact of this pandemic in the healthcare perspective. So let's start by saying that from a healthcare perspective, we should think about healthcare provision as a clock mechanism in which different components are interrelated So we cannot think about the impact of COVID alone in providing acute COVID care for severely ill patients who need hospitalization, but we also have to think of COVID-19 survivors who persist having clinical conditions that require sustainable health care, and the impact of our attention being drawn to COVID care, both to acute and long COVID care, in terms of the impact this may have in other healthcare demands we continue to have. And in particular, in our setting, which is an academic health center, this has to do with high complexity healthcare. So let's start by understanding what acute COVID-19 brought to us. As you all know, COVID-19 is an acute viral disease that can have a variety of manifestations in its clinical spectrum, ranging from asymptomatic infection to very severe disease. And for those on the top of the iceberg who really develop severe COVID, the disease progresses in 3 different stages. The first stage of early infection with let's say, non-specific signs and symptoms that are shared with other viral diseases. A second stage when the pulmonary involvement reaches its peak and patients who progress through this phase need to be hospitalized, and a third stage to which only few patients progress, but which demands intensive care because it leads to a hyper-inflammatory milieu that leads to severe pulmonary damage and respiratory failure that requires mechanical ventilation in intensive care. What happens if patients complete the 3 phases? What happens next?
Can you put in full screen, please?
Oh, sure. Sure. Do you have it now in full screen?
No, you have to check the mode up there because it has the big one and the small one. So you go exibir, configurações, no meio. And then, No, the first one,
Okay. So what happens to these guys that develop the 3 stages of disease? They usually recover or die in a time frame of 28 days. This is what happens to most of them. But apart from those who recover or die, a significant number of patients overcome this critical phase but continue evolving with persistent symptoms, which is called long COVID. Let's think a little bit more in detail what this really means. So first of all, it's very important to have a clear notion that so far we don't have an internationally defined case definition for this clinical condition, long COVID. We have a list of signs and symptoms which are usually associated with this condition, but we don't have pathological correlates to most of those signs and symptoms. The long-term clinical consequences of COVID are described as comprising a wide range of persistent symptoms that may lead to substantial disability and impaired quality of life. According to British estimates, about 1/5 of patients persist with symptoms 5 weeks after disease onset, and 10% may still have those symptoms for more than 4 months. Reports have also tried to point out that persistence of symptoms in a long COVID syndrome more often occur in patients with the history of severe COVID-19. But it's important to highlight that this is not always the case. So we have clearly seen patients who have not been so severely ill at the acute phase, who may still persist with symptoms for a long time. And what has been already become a consensus is that this is an urgent public health priority. We should really take our time to investigate this in more depth. And for that, we need a multidisciplinary research effort to try to come up with a consensual clinical definition, to try to understand the pathogenetic mechanisms that may explain those persistent symptoms, to try to disclose predictors of development of this chronic condition. And finally, after we do that, to test effective prevention and management interventions that may lead to a lower proportion of patients with long-term disease. There is also the need to invest in epidemiological studies to try to understand the scope of this chronic clinical condition, its magnitude in terms of attributable risk, and the impact this may have in health systems. A number of signs and symptoms have already been associated with the so-called long COVID condition, but these are related to different organs in the body, clearly showing that this is a result of a multiple system involvement. There are general health and systemic symptoms such as fatigue, which are among the most common complaints of these patients. There are pulmonary symptoms such as cough, breathlessness, chest pain, and in some cases, impaired respiratory function. There are complications in the circulatory system that have to do with arrhythmia, myocarditis, the development of a hypercoagulation state, and in some cases, severe cardiac impairment. Many neurological symptoms that cover a wide range of different syndromes, the most common of them being the reports of prolonged headache, the loss of smell and of taste, peripheral neuropathic syndromes, encephalopathic syndromes, the so-called brain fog, a difficulty in keeping concentrated, and particularly an impaired visual selective attention, which may impair performance at school or in work. The muscular system is commonly involved with generalized muscle pain. Kidneys can have their function impaired. There are gastrointestinal symptoms such as diarrhea, nausea, and vomiting, and in some cases, impaired liver function, metabolic consequences such as hyperglycemia. And I would like to highlight the psychiatric symptoms that have to do most commonly with anxiety, depression, or even mood swings. How do we clear up the situation? How can we disentangle this large number of symptoms to have a clearer picture of what is going on and what we should expect? I would say we first have to have a critical eye on those cohort studies in terms of their methodological discrepancies. Many of the studies that have been published in the last 1.5 years have had different approaches. In terms of the study participants, some studies were restricted to laboratory confirmed COVID cases, while others included lab confirmed cases and suspected cases as well. The choice of outcomes has varied considerably in this diversity of signs and symptoms that were looked after. The assessment of outcomes has been different in many studies, most of the studies have been telephone surveys with patients at home. In other studies, these have been developed in face-to-face interviews and clinical assessments, which are more objective in a way. The existence of controls is not always there. So we have cohorts that only include COVID-19 patients. So it's hard to distinguish whether these symptoms are really related to the COVID-19 acute phase or whether they might be due to other conditions. And duration of follow-up in those cohorts have varied also a lot. There is a basic question underneath, and that is if long COVID is indeed a novel distinct syndrome, because it could also have, in fact, it does have a lot of overlap with other previously described syndromes. And I would like to mention here the post-intensive care syndrome, which is a condition that affects patients who have been in prolonged intensive care and most often under mechanical ventilation for a long period of time using strong painkillers and muscle relaxants. Another syndrome, which is known as post-viral fatigue syndrome, which has been described as associated with a large number of acute viral infections that is mainly characterized by a chronic fatigue and an impaired performance when trying to return to routine activities after acute disease. And there is a lot of overlap as well in terms of psychiatric complaints with the so-called post-traumatic stress disorder. So what I really mean here is that we still don't have a clear understanding whether we are talking of a specific clinical syndrome or if we are talking of a combination of effects that overlap among each other and that have still to be disentangled from one another if we want to have a clear view of what to expect for the near future. What about the impact of COVID-19 in other healthcare demands? We have heard from Professor Goldman and Professor Turra that excess death studies have clearly shown, and these are data I collected from the CDC website, that show that if we collect data concerning mortality associated with respiratory diseases, circulatory diseases, malignancies, dementia, and some other causes, as mentioned here, we clearly see excess mortality in the second half of 2020 and throughout the year of 2021 in the United States. This can be due to two different aspects. These could be misclassified deaths where their COVID-19 association was missed at a point because of the lack of appropriate diagnosis and testing, or this could be a consequence of people dying of other causes because of the reasons that have already been pointed out for the lack of healthcare and more difficult access to routine emergency and routine care. In fact, there has been a number of publications so far that clearly point out for an impact of COVID-19 on both prevention and care of chronic conditions. There has been a reduced adherence to healthy lifestyles for many reasons that were explored in the panel this morning and also in this current panel regarding undernutrition or poor quality of food during the peak of the pandemic, the inability to perform physical activity, different patterns of smoking and alcohol use under the pandemic conditions, barriers to healthcare utilization, which have led to both reduced access to preventive care and to acute and chronic disease management. In fact, there are some estimates in the United States that the lack of appropriate cancer screening during the pandemic period may lead to 10,000 preventable deaths due to breast and colorectal cancer in the United States alone. There have been consistent reports of an unfavorable impact in pediatric immunization programs, even in countries where these have reached a successful condition, meaning that immunization coverage in these 2 years will drop in many countries, leading to, of course, unfavorable health outcomes. And apart from that, we can clearly point out that having less access to acute and chronic disease management, both in routine care and emergency care, may also lead to preventable deaths. Let me take an example I'm very familiar with, and this is HIV prevention and care. If we consider this theoretically, COVID-19 impact could reach each one of the steps of the HIV care cascade. It could bring difficulties to prevention in terms of increasing populational vulnerability to HIV acquisition, reduced access to combined prevention measures, condom use, STI diagnosis and care, pre-exposure and post-exposure prophylaxis. It could reduce access to testing and lead to delayed HIV diagnosis. It could lead to reduced linkage to care due to lockdown and urban mobility restrictions, or even to reduced access to services that were shut down for some time under very strict lockdown conditions. It could lead to impairment in sustainable treatment due to risk of medication shortage, reduced antiretroviral prescription and dispensation, to retention in care because of, again, the lockdown and urban mobility restrictions, reduced working hours of services, lack of personnel, and also that may lead to increased losses to follow up. And finally, ultimately, leading to an impaired viral suppression. So again, as was said in terms of life expectancy, bringing down gains that were that were obtained with a lot of effort of healthcare teams for the last 2 or 3 decades, with reduced access to ART, loss of social support, worsening of living conditions, and maybe increased loss to follow up. In fact, the impact of COVID-19 on HIV prevention and care is appearing in a number of publications that have been recently summarized in Current Opinion HIV/AIDS, and they include all the different aspects of this continuum of care of the prevention and care cascade I was just talking about. So what is the message we can take from here? We can take a very clear message that action is needed. It is very important to raise awareness of the need to persist in health promotion and adherence to healthcare. Once again, I would like to echo the previous speakers about the importance of reinforcing the importance of the health system, particularly here in Brazil. We have heard that the pandemic raised, let's say, public attention about the importance of our unified health system, but nevertheless, we are still under an underfinanced system. And if we think about possible budget cuts in the next future, it's not very clear for me, Cássio, I'm sorry, that we can be that optimistic that just by raising the importance of the health system in the general public opinion, this will effectively lead to a better funding of the system. It's very important to help people return to healthcare, to refer them to healthcare settings where they can have their long COVID conditions taken care of or other conditions they still need care for. We have to ensure our healthcare settings are safe, using communication and adhering to sanitary measures to prevent transmission of the coronavirus in those settings. And we cannot disregard the need to emphasize the disproportionate impact COVID-19 has had on more vulnerable populations. So our interventions have to bear in mind the need to provide equitable interventions to different populations according to their particular vulnerability, with special attention being given to those more in need. And finally, I think we should go for more creative solutions. We have to make better profit of existing resources, our primary care system, the action of the community, very highly committed community health agents we have in the family health strategy, and try to involve them in identifying patients with long COVID or with other conditions that need care and bring them back to services. We have to take profit of something we used during the peak of the pandemic, the use of technology, telemedicine, which has, I think there is no way back. It was introduced in routine care and it's here to stay, and we should make the better profit of it. And finally, we have to make sure this is a collaborative effort that involves not only public health officers, but also healthcare providers with the participation of the affected communities and their inputs. I would like to now finalize with the case study of what we are doing in our institution in terms of long COVID. So let me start by saying that this is the Hospital das Clínicas Academic Health Center, affiliated to the School of Medicine of the University of Sao Paulo. In 2020, starting from late March, this largest academic health center in Latin America converted its central institute, where I am talking to you from, into a fully dedicated COVID-19 in-hospital facility, providing 800 beds for the public health system in the city of Sao Paulo. And it is important to say that out of these 800 beds, 300 beds were for intensive care. This was an unprecedented effort of healthcare teams and of the institution itself. It represented a really effective, fast response to the public health emergency in Sao Paulo. It's hard to believe that other institutions would have had the capacity we did to mobilize the community in such a short notice to cope with the pandemic and with the overburden. It was also thought about to have this fully dedicated hospital to maximize favorable health outcomes for patients with severe COVID-19, alongside with trying to reduce cross-contamination to healthcare workers and to patients with other diseases. During this period, so starting from March last year, we have been conducting observational studies using data from inpatients that were admitted to our institution due to moderate or severe COVID-19. 3 very important institutional initiatives were launched. The first of them was to organize an institutional cohort of patients who were admitted to the institution with laboratory confirmed COVID-19 that added up to over 3,000 patients. And we tried to collect standardized data concerning their demographics, their comorbidities, disease aspects, symptoms, lab and imaging results, hospitalization details, mortality, and other incomes. So extracting data from the electronic medical records, this integrated data lake was made available to provide research data for this cohort in different studies. The other initiative that was very important, I would like to emphasize, is the setup of this protocol for multidisciplinary reassessments 6 and 11 months after hospital discharge, and in parallel, the establishment of a BIOS repository with clinical specimens of different kinds that were collected during hospitalization or during follow-up. And all this structure that was put together last year was overseen by a steering committee that was appointed by the School of Medicine Dean and the hospital board. The main differences between our infrastructure and some studies that have been conducted elsewhere with hospitalized patient cohorts is the fact that we have had these in-depth assessments carried out by several specialized teams, in addition to a just yes or no symptom questioning we see in other studies, that we had all eligible subjects invited for in-person visits, so we did not rely only on telemedicine or on telephone interviews, but we had in-person objective assessments, and that we had the possibility of using 2 facilities for this assessment, follow-up assessment. One at the main hospital and the other one at the Heart Institute, which took care of evaluating a large cohort of patients who had been in ICU care. So this is just the study flow chart of this cohort that added up to 3,500 patients. I won't go through every detail, but these are published and I will then share the reference. One important point about our first follow-up visit is that we had about over 800 attendees, and this is their demographic characteristics. I would like to emphasize that about half of them are Black or brown. So this is a special feature of this cohort that has to do with the population we usually take care of. They are frequently also have other clinical conditions, comorbidities, that may have led to a more severe COVID presentation that required hospitalization. And 65% of this cohort had been under intensive care units, for a duration of 14 days of hospitalization. And 43% of them had been intubated and underwent mechanical ventilation. The main persistent symptoms at first follow-up visit, with a mean of 7 months after hospital discharge, as you can see here, is very widespread in different organs and systems, with the importance, predominance of body pain and fatigue as well as breathlessness. But it's important to say that about 90% of the cohort referred at least one symptom 7 months after hospital discharge. In terms of emotional and cognitive complaints, I would like to emphasize they were very, very common. 60% of patients had one referred symptom in that domain, and these had to do more often to memory loss or sleep disorder and impaired concentration. Neurologic complaints more often were related to headaches, weakness, speech and walk impairment. We are planning to proceed with this study, trying to identify predictors of long-term outcomes. Here are some of the factors we are exploring: demographics, comorbidities, severeness of COVID during hospitalization, other hospital interventions, and prior frailty to COVID-19 acquisition. And of course, a better understanding of the scope, magnitude, and risk factors of long COVID will help us establish intervention protocols for these patients at the institution. I would like to finalize by thanking this large number of colleagues that involved a large number of medical specialties who were, I would say, for the very first time brought together in an institutional effort to cover a public health priority that will have a significant impact in our healthcare provision in the coming years. Thank you very much.
Thank you, Professor Aloysio. Very interesting presentation showing the complexity of the consequences of the long-term COVID for treating the people who survived the disease, but also the other consequences of the pandemic, and how the teaching hospital of USP did a very important job in terms of reorganizing rapidly the capacity to treat the people and following the people, showing how we will need to reorganize healthcare to treat the disease. So actually we have more 30 minutes for discussion. And I would like to invite the people who are watching our panel to make questions. I like to do a very general comment and show some questions for our colleagues, but also I would like to invite for other questions. So it's very interesting to see this in our three presentations. The similarities between Brazil and the US in terms of they are the countries that are the most affected in terms of number of deaths and reduction of life expectancy. But as very unequal countries, we had large differences between the population groups. So these similarities tell us about the complexity of our countries and make some implications for our public policies and for our health systems. And I would like to have some comments of the presenters about that. But also we have differences in the two countries. So it's interesting to see that in 2020, US was more affected than 2021. And in Brazil, we had the country, 2020 was much worse than 2021 was much worse than 2020. So I would like to have also some comments about that. We have the change in the government in the US, but also we have the immunization increasing faster in US than in Brazil. And so interesting to see if there are other consequences on that. I don't know if we have some questions for our colleagues, and then I would like to pass the, I don't know, Marcia, Vera.
I have a question. So, first of all, thank you all so much. This was terrific. And my question is to Aloysio to link with the other talk. So, very specific. Do you have reports in your cohorts that you put together? Do you have reports of long-term disability? For example, people that are now receiving disability pensions because of COVID. And do you have any numbers on mortality, which is what the first two papers discussed? I think there's at least one paper from the UK that reports higher mortality among COVID survivors that had long COVID compared to people from the same age. So those two questions have a direct effect on human capital, right? Which, I mean, the economists should pay more attention when they, try to prioritize economy over health, but also have an impact on what we discussed in the first two papers, which is life expectancy. So do you have any numbers on that from the cohort?
So thank you, Marcia, for the question. This is very important. And when I was listening to Professor Goldman, Professor Tuha, this was something that came to my mind as well. Yes, we do have mortality data in this cohort. I don't have them right now here, but we are collecting data. So patients are scheduled to come for the follow-up visits, and there is active search for those who miss their appointments for a rescheduling of appointments. And from that, we have data of some of them who might have died. And there is a number of patients who are under continuous rehabilitation medicine intervention. I'm not sure if you are familiar with that, but in our Hospital das Clínicas complex, we have one institute. You have already visited it, the Rehabilitation Medicine Institute, which is a very sophisticated institute in terms of rehabilitation medicine interventions they are equipped to provide. And so they are being followed there. And many of these are patients who have not been able to return to work. And we can also collect data about that, because this is really something that shows the socioeconomic impact, because we are talking about family providers who are under sick leave, and I'm not sure if our US colleagues know that, but here in Brazil, if you go under sick leave, your income will be dramatically reduced. So we are already talking about people who sometimes are involved in informal labor market, and out of those who are under formal labor market, if they go for prolonged sick leaves, they will have a significant reduction in their income that will affect not just the provider, but also his or her family. So we do have data on that, Marcia.
Yeah, so I'll follow up with you on that. Full disclosure, I already sent a message on private to Aloysio. We need to talk because I have 1,000 questions. But one thing that I think it's important is really to measure the impact on human capital. And I haven't done this yet, but I already sent a few messages. I'm exchanging a few messages with friends in the Social Security Ministry to see if we see an increase in pensions from disability. And I don't know, Noreen, if this kind of data is available for the US in terms of people going into disability because of the pandemic. And I think we need to pay attention to that, because those are things that may not be immediate, but those are sort of mid and maybe even long-term effects. And, just this morning, Mike Ryan said, we have prolonged impacts in the health system, but it's beyond the health system. It's prolonged effects for society that I haven't seen any, measurements yet. It's not easy to do, but I think we should pay attention to that.
So, any other questions? Or I think Marcia addressed the questions for Lorene, if you want to say some comments.
You're mute, Lorene.
You're mute.
Yeah, so we can at some point get disability claims information. I don't know if we can tie it directly to COVID, and we can tie it to time, right? And we can see what's happened over time, and make inferences about the pandemic. So you raised the interesting question, Adriano, about 2020 versus 2021, and similarities and differences between the US and Brazil. I think what's quite interesting is what the countries had in common, which were anti-science leaders who put the economy above public health, and huge diversity, racial, ethnic, socioeconomic diversity in the populations, which was clearly going to hit some people much more severely than others, even in the absence of vaccine or treatment. It was going to lead to very different exposures to infection and mitigation behaviors. It was also a case where, as you say, vaccination came to the forefront under a change of regime. And that's helped the US much earlier than Brazil. Hopefully there'll be a catch-up effect, and the catch-up effect becomes more likely as vaccination stagnates in the US. But the other thing the countries have in common, which I think has been very destructive and not true of all populations, was even under our change of president, we don't quite have a national control to enforce mitigation behaviors, to enforce lockdown, to enforce vaccination nationally before one goes to school or various industries. We have a lot of power in our governors, and that power in our governors, combined with huge political diversity in the two societies, has led to very uneven geographic distributions of infection and mortality and vaccination, and ultimately impacts in life expectancy. And we'll see health, and we'll see disability, and we'll see those long-term social and economic impacts being very heterogeneous across both societies.
I think you should do a study like we did, Noreen, by state. Just saying.
Okay, you brought me into Brazil, and I'll bring you into the US. Start with Louisiana, 30% vaccinated. It's a sad story.
Yeah. Lorena.
So in the morning, and I think all of us, I'm trying to bring a little bit of the perspective, thinking of the communities that are listening to us. And we spent a lot of time this morning talking about the messaging and the implications when we're talking about the pandemic, and how groups read those findings and how groups assimilate those findings. And I'm really struck in the three presentations, and I kind of want to provoke all of you to think a little, interested in thinking about how do we outreach correctly to communities with these findings? Because on the one hand, we can think about there's a very frightening and reinforcing in a very difficult situation that's already very painful, where we've lost many of our people who we know, or we have people who we know are not really feeling well and have long-term symptoms that are undiagnosed, probably because we're still muddling through what is long-term COVID. how do we do effective outreach about these types of findings to engage communities about how to empower them with this? So how do we use this better in our communications? Because I worry sometimes, especially when we talk about, and I listen to these panels, there's a little bit of a feeling of fear, right? I'm at home, I'm trying to stay at home to do the right thing. And at the same time, these findings are saying that the situation is very bad and that I could have something worse because I'm not going to the doctor. And in my community now, I feel devastated, but the findings on life expectancy makes it seem unsurmountable to keep fighting the fight. So I'm wondering if we can talk a little bit about communities and thinking about how do we messaging and what are some of the takeaways if we want to think about NGOs and community organizations that might be listening, and even policy workers that work on social assistance programs. What is the right takeaway for them? I don't know if and it's a hard question. So that's why I spend a lot of time talking, because I know I'm throwing something out there that's a little bit hard.
This pandemic make us a lot of very complex questions. I would like to add a question to Lorraine, to Cassio and Aloysio. First, Cassio, I'd like to know if it's possible to see with the data what are the states in Brazil that had better response to COVID, if observing the excess of deaths. Because we have a very different response in the country, as we have a very decentralized system to municipal level. We have 5,500 different responses, but it's possible to see the states that are under a more vulnerable condition, but had capacity to have a better response with observing the data. And for Aloysio, if it's possible with the experiences that you are developing in just without the clinical hospital of USP, in terms of what are the lessons that we can learn for developing a network of care, including primary care, to long-term impacts of COVID.
Okay, if I may start, I'll try to bring the two perspectives, the one that was raised by Lorena, adding a comment on what Adriano has just said. I think I don't have a final answer for that, but I think a good approach would be the family health strategy program. They are closely linked with communities. At the municipal level, at least here in Sao Paulo, we have a community council that is involved in the establishment and monitoring and assessment of public health policies. So we should bring there the idea that we are talking about comprehensive care. We should not try to disseminate a frightening narrative that people are under threat of becoming severely ill. But I would rather use another approach to say that we have something we can offer these people who have very bravely survived COVID-19, but who are still struggling to come back to their normal lives. Of course, in a health perspective, of course, because the economics has to become better, the labor market has to give them other opportunities. But as far as our sector is concerned, I think we could approach them using NGOs and the population councils at the municipal level and try to build what Adriano has just alluded to, which is this continuum of care. What we see from our cohort, Lorena, is that even though we have a large variety of symptoms that are at least associated potentially with long COVID, most of these patients, they don't require very sophisticated care. They can be dealt with at a primary care level, since we have physiotherapists and psychologists at that in that particular dimension. So we could prepare those multidisciplinary teams with protocol and train them to conduct simple interventions in physical exercise, physical therapy, mental health support that could be I think, help the health patients cope with most situations. And this would be also the opportunity of let's say, selecting those who need more sophisticated care and having them referred to more sophisticated, more highly technological interventions that are available in fewer institutions or healthcare settings. So I'm not sure if I made myself understood, but I would start approaching them under a family health strategy, trying to identify, first of all, people are afraid of speaking up. I'm still not feeling very well. Yeah, so they have to be encouraged to come up and say they need some support, and then have these multidisciplinary teams that include community health workers that visit their households every now and then to identify those who would be invited to participate.
Should I add some points? Yes. So with respect to Lorena's question, the one that Aloysio just addressed, I think Aloysio is a researcher and is a doctor, so the points he raised are very important because it goes to individuals as well. I'm a demographer, so if thinking with a demographer head, I would say that what's more important, I mean, my presentation at the end, I try to add some hope, right, for the situation. But I guess vaccination would be the answer for, would be our best hope, let's say. So thinking in terms of the population as a whole, of course, that would reduce mortality significantly and would allow people to work in sectors that have been really have been hit hard, like the service sector, improving the economy, improving jobs, and so on. So that would affect people's lives more directly. So I guess the first answer is to take the vaccine. That would be a demographer saying to people, take the vaccine and ask for the vaccine, and then things will get better. Of course, things will get better. That's what I hope so. And I think there are elements for us to be positive in some sense. If we look at the United States situation now, there's the Delta variant of the virus, but I mean, it's hospitalizing, killing people who did not take the vaccine mostly. So I understand, Noreen can say more about that. I understand that the United States is thinking in terms of maybe taking additional measures, but most of the people who have been hospitalized and who are dying now are those who didn't take the vaccine. So I think there is hope in that sense. Also, Adriano asked about differences in, if you can see any associations between mortality impact and different policies taken by local governments. We didn't look at local governments to states, as you know. We in the paper, we mention, it's hard to, I mean, that's one thing that Marcia and I will also talk a lot, discuss a lot. I mean, in terms of how to establish causal links and associations, correlations. But we mentioned in the paper, if we look at in 2020, the impact was harder for the North than the Northeast states. And both regions have the worst inequality indicators in Brazil, economic, social and economic indicators. So why the Northeast had a better, did better than the North. And one of the hypotheses we raised in the paper was the fact that the governors in the Northeast states, they were they were able to impose physical distancing and other measures better than the northern state governors, because they were more in opposition to the federal government. But of course, this is just speculation. We didn't have any casual test to say that did work. I think there's so many. I mean, again, when as I mentioned during my presentation, this also has to do with the question you raised to Noreen. There was like a kind of a reductionist view when the pandemic started, from some demographers saying that age structure would explain everything. And I guess, unfortunately, the US and Brazil share many difficulties in terms of social and economic conditions that helped the situation to get out of control in our countries, right? The job market, the informal market, the household conditions, and things like that. So, I guess it's pretty clear the fact that the vaccination, as Noreen said, the fact that it started earlier in the US in 2021 than in Brazil, it has had an impact. So that's why Lorena, I would say to people, get vaccinated and things will get better.
Great, thank you. I think we have time for more 1 or 2 questions. I think Marcia has a question, Vera also. So
I think Noreen was going to say something.
Yes.
Am I right? Yeah.
Oh, yeah, so I was just going to respond. It's interesting. I'm also a demographer, and I was going to give the response to vaccination. So we share that because I think it directly will impact people's willingness to make greater use of the healthcare system, and it'll reduce the stress and anxiety on the part of health providers to see that. And one short anecdote, I ended very quickly my presentation with this little story of the Native American population with, high morbidity, high mortality, huge distrust of the government for good reasons. I mean, they have been the victim of really inadequate healthcare provision and high rates of disease throughout their history in the United States. Yet they had some of the highest uptake of vaccination rates. I tell the story of one of my closest friends in Canada, where I am now, actually got vaccinations from the Blackfoot Reservation in Montana by crossing the border and not getting out of the car because they had vaccinated 99%, and they were offering Southern Canadians the vaccine. An amazing story. And so what a student looked into, what makes that work? How do they succeed in doing that? And part of the story was the community elders. Right. So people who were very trustworthy in the community, had lots of respect, not coming from national TV or something of the sort, but, the importance of local trust and communication to get people, despite, huge concerns about something the nation was touting that they take, were willing to get that. And that tells me that, that's going to be hard, right? And we don't have the community healthcare structure to the degree you have it in Brazil. But I think that's where our hope lies in getting people to get vaccinated and to hear the messages about mental health. One of my greatest worries of the pandemic, which is vastly underprovided in the US, and I imagine also in Brazil, and has had a huge negative impact through COVID.
Yeah, and it's interesting because this morning, Mike Ryan said, we have plenty of information. What we lack is trust. So, in talking about infodemic. So, so I had asked the question before. So why don't we let Vera ask a question, because she hasn't spoken yet.
No,
You pass. Okay. Hello? So here's a question. So the U.S. made the census in the middle of a pandemic. Brazil has not made the census. We don't even know when we're going to have a census. So forget about getting right denominators for anything. The data Aloysio presented just made me ask a question if in the future we're going to need a special cash transfer for people with long COVID, like we had a special cash transfer for mothers that had babies with congenital Zika syndrome, another epidemic, not a pandemic, that we had. But to be able to even figure out if we have this demand, we need data. So what I would love to hear Noreen's reflection on the census we had in the US and all the debates that happened, ask the question about migration status, don't ask the question, change the census, but then the president changed. I don't even know what's happening now. And I would love to hear Cassio's reaction on the fact that we are completely in the dark about denominator. So how do we even move forward in making any decisions in the dark? So I'll start with Noreen.
Okay, so that's a good question. I don't quite know what's the status of our census. I mean, numbers aren't released, but what scares me, two things scared me. One is the pandemic that occurred during it. The other is, in the end, there wasn't a citizenship requirement, but there was tremendous talk during the Trump era, about that, right? And, whether a question, not a requirement, a question on the census form regarding citizenship that probably had huge numbers of undocumented, very frightened about taking the census. Again, that ultimately didn't go through, but last minute changes, communication is bad, communication's worse during the pandemic. And I fear it will have led to the undercounts of the most vulnerable, which will have all sorts of political ramifications, both in terms of Congress and in terms of funding.
Cass.
Well, I think the issues of the Brazilian census, the roots of the issues come back to when polarization in Brazil started to get tougher. So back in 2018, 2019, and so on. Now, when the census, we were just 1 year before the census to happen, and then were all the fights because of the questionnaire and so on. And these things started in the academic community, and then they spread out. Journalists were following the discussion, things went out of control and so on. And then came the pandemic. And then I guess in 2020, everybody agreed that it would be hard for Brazil to collect the data. In a way, I didn't see too much fight on that. But then 2021, there's a lot of fight. And then the polarization came again and people were discussing and so on. I guess the census, I'm part of the 2020 census committee in BGE. I'm very confident that the census is going to get collected next year. But it's too bad that we didn't have the counts, for example, to help us define the target populations for the vaccination. So there's one study I've been working where we show that the health authorities needed to use population projections and population projections based on the 2010 census. And so it's two-way in the past. There are all the problems related to how to project mortality, and all the uncertainty related to projecting population at the local levels, because the IBGE does not provide projections at the municipal levels, only at state level. So each state has to deal with this estimates for small cities and so on. There's a lot of uncertainty, particularly for the elderly. So I guess we are paying the consequence of not having the census. But now it's too late. Yeah. We have to wait for next year. And I really hope the next year we're gonna get the data.
Yeah, I think this is an important discussion because information is power. Right? I mean, in the US, we still have some states that we don't have data on COVID mortality by race and ethnicity, right, Noreen? I don't think all of them release, at least in the beginning, they didn't. We have estimates, but not sure.
Yeah, I think we now have more complete information, although it's always suspect. Right? I mean,
yeah. And in the case of Brazil, it's interesting because on the history of our census, it was during the military regime, the only time we didn't have the question on race and ethnicity. That's not by chance. There is a reason that the question was suppressed in the middle of the military regime. And again, France still does a census without a question on race and ethnicity. So if you don't measure, you can say you don't have an issue. But that's for our next keynote. David Williams is already here. So we're going to talk about racial issues and on the COVID. So Cassio,
Marcia, I know the time is up, but just to say
go ahead.
That on the other hand, we had problems with the denominators and the population counts. But on the other hand, it's incredible to see how much Brazil was able to gather data. The effort that the universities and the local governments and everyone made to build this new database, including the vaccination registration system. I even said to the current president of the IBGE, who's a demographer, our friend Eduardo Neto, a former student of Norin Gold, that I mentioned to him that he should use the vaccination system record to help the census next year, with all the problems that the records have, it's new data being produced as the pandemic goes on. So this is incredible.
No, in terms of data, Brazil is like 10, US is 0. I mean, there's no question about it. I mean, I'm sorry, Noreen and David, but it's really 10-0. And I talk about soccer all the time, but it's 10-0.
Last comment. I think almost no country collects data on race and ethnicity in the census. I think the US and Brazil are among the rare exceptions that collect those kinds of data.
Yeah.
Okay.
So
thank you so much in the name of the Institute of Advanced Studies and USP for your contribution, exciting discussion, right? I was hoping to see Professor David Williams. There's a lot of people. We're very excited to hear you in Brazil right now, right? And so welcome to our panel. And Marcia is going to lead.
Yeah,
Thank you, Marcia.
All right, so thanks again, Noreen, Cassio, Adriano, and Aloisio.
Yes,
this was exciting to be continued, folks, because I think we raised so many questions. So thank you so much.
Thank you.
So now we move to our keynote in the afternoon, and I am really glad to introduce Professor David Williams, my colleague in the School of Public Health. He's the Norman Professor of Public Health and Chair of the Department of Social and Behavior Sciences. He's also Professor of African American Studies at Harvard, and he has written so many. I'm not going to read everything from his bio, but he's widely published. He's a member of the National Academy of Medicine, the American Academy of Arts and Sciences, and the National Academy of Sciences. He has been ranked as the most cited Black scholar in social sciences worldwide and as one of the world's most influential scientific minds. David, the moment we had this topic, I knew I needed to have you in this panel. Thank you so much for dedicating some of your busy schedule to talk to us about racial issues and COVID. So the Zoom is yours, David. Thanks so much.
Thank you so much, Professor Castro, my dear colleague and friend Marcia. It's truly a privilege to be here with you. Brazil is one of my favorite spots on the planet. I've visited Brazil about 5 times, and sorry that I'm not there in person, although COVID is not maybe the best time with what's happening here and there to travel. But it's an honor and privilege to join you today and to talk about some of the research of racial inequities in health and the way COVID illustrated that. And I also want to put the US data in the context and show some patterns where I have data in the United Kingdom as well. One of the things that sometimes happens even to people who study race and health in the United States, we think the patterns are distinctive, but as you look across countries in societies that what I would call are racialized, where there's a ranking on some basis of physical external appearance, we see similar patterns, and I hope we will see that in my talk today, looking at the UK and the US. I'm going to share my screen so that you can see my slides. 1 second, I need to pull my slides back up because I don't see them at the moment. Let me, okay. I'm going to go back now. I should have them. Yes, here we are. All right. All right, so race and COVID mortality is the general topic that I have today, and I want to begin with data. So this is the best data. It's not perfect, but it's the best data we have, and it's deaths through March 2 of 2021, and it shows the age-adjusted odds ratios. And it looks, compared to the white population as one, what are the death rates for other groups? And you could see the Pacific Islander population, the Black population, the Latino population, and the Indigenous or Native American or American Indian population, all those terms would be used interchangeably. All of them have death rates that are much higher than that of the whites, more than twice as high, with the Native Americans, although a relatively small number, having the most elevated risk. The pattern for the Asian population is similar to that of the white population, although there's heterogeneity within the Asian population, and there are some groups that did more poorly than others. The other point is that sometimes when we talk about death rates that differ by race ethnicity, there are people who confuse that with the number of people who have died. So here I am showing you the number of persons who died from COVID through March 2, 2021. And at that time, this is about 520,000 deaths. It's much more than that now. And you could see the vast majority of deaths, is almost 300,000, is the white population, and 18,000 for the Asian population, about 73,000 for the Black population, almost 90,000 for the Latino or Hispanic population, and 5,477 for the Native American or Indigenous population. So it's just important. I know I've encountered white people who thought that white people are not at risk of dying for COVID because it's just the minorities who were dying, and not realizing that there are differences in the risk of death, but this pandemic had a negative impact on all populations. Here is data on COVID-19 mortality in the United Kingdom compared for the disadvantaged racial populations compared to the white population. And here are the age-adjusted odds ratios. And you could see for Black males in the UK, the death rate was 4.2 times higher, so even larger than the US. For Bangladeshi, Pakistani, that's a disadvantaged group in the UK, 3.6 times higher. For Indians, 2.4 times higher. And for females, you see a very similar pattern, 4 times bigger for the Black females, 3.4 times for Bangladeshi, Pakistani, 2.7 times for Indian. That is a striking pattern. What is particularly striking to it from observers from the US and even for the UK, this was a shock to, I was called to speak to a number of meetings in England about trying to make sense of the data. And the difference is, in the United Kingdom, everyone has access to medical care. In the United States, that is not true. And disadvantaged racial populations do not have good access to medical care. So here is in a context where, in theory, everyone has good access to medical care, we still see striking racial differences. In fact, these initial racial differences in the United Kingdom were even larger than those in the US. I'll come back to what might be the drivers of these differences. But let me go back to the US context. This was a report that came out about 6 months ago. There are other reports more recently that confirm these findings. The racial disparities in health in the US from COVID has had a large impact on life expectancy at birth. Life expectancy at birth in the United States for 2020 compared to 2019 declined by more than a year overall. And then when we look within subpopulations, you could see a 3-year decline for Black males, 2.4 years for Hispanic males, 2.3 years for Black females, 1.1 year for Hispanic females, 0.8 of a year for white males, and 0.7 of a year for white females. One recent report talking about this gap, decline in life expectancy, the gap from 2019 to 2020, the decline in 2020, we have not seen such a large decline in life expectancy in the US for 70 years. So this is a huge negative impact on the population overall, but you can see disproportionately it affected the economically disadvantaged populations. So the big question that we need to struggle with today is why? What drives these large racial inequities in health? My first thought would be there are large inequities in health by socioeconomic status, SES. That's in the US and elsewhere. And when I use the term socioeconomic status, I'm talking about income or education or occupational status or wealth. Around the world, these factors, income and education, for example, are large predictors of variations in health. And in the US and the UK, there are large racial ethnic differences in socioeconomic status. So here is national data for the US for 2018. And I am presenting them in a way where I'm standardizing on the household income of whites as $1. So for every dollar of household income white households receive, Asian households receive $1.23. Several caveats. The Asian category has more persons in multi-generational households. So there are more persons contributing to household income in the Asian category. So if the data was presented as a per capita or a per person measure of income, whites would have the highest income. But it's also important to remember that almost 70% of Asians in the United States are immigrants. They are a population that have come to the US with high levels of education. They have markedly higher levels of education than the white population. So a higher level of income is not surprising given the high levels of education. But let's look at the historically disadvantaged groups. For every dollar of household income white households receive, Hispanic or Latino households receive 73 cents, and American Indian or Black households receive 59 cents. What is really surprising, I would say even stunning, about the 59 cents figure for Blacks is, and this is 2018, that is identical to the Black-white gap in income in 1978. I did not misspeak, you heard me correctly. I said 1978. And why did I pick 78? 1978 was the peak year of the narrowing of the Black-white gap in income in the United States as a result of the anti-poverty policies of the 60s and 70s and the civil rights policies of the 60s and 70s. The gap had been narrowed in 78 to 59 cents. And in 2018, the gap is still 59 cents to the dollar. Has the gap been unchanged over time? Oh no, it got a lot worse from 1978. It fell throughout the decade of the 1980s. That was a decade of Ronald Reagan, was not good to the Black community. It fell as low as 54 cents to the dollar in the 1980s. And it wasn't until the mid-1990s during the President Clinton era that it came back up to 59 cents. And it's been a penny up and down from that. Sometimes it's 58, sometimes it's 59, sometimes it gets to 60. But the point is, surprising to where most Americans think that America had a race problem, and Martin Luther King and the civil rights movement, the race problem was solved and there are no racial inequities. And I'm showing you for one group where we have good data going back decades, the racial gap in income in 2018 is exactly where it was in 1978. So there are much larger racial inequities in income than most Americans think. If we look at data for the UK, and I've tried to present data similarly, for every pound, the currency of weekly income the white majority earns, other whites, that's mainly Eastern European, whites from Eastern Europe, earn 79 pence, Indians earn 86 pence, Pakistanis 57p, Bangladeshis 52p, Chinese 76p, blacks from the Caribbean 77, blacks from Africa 60 pence. So the groups that I focused on earlier, blacks, the two black groups, as well as the Pakistani, Bangladeshis, and Indians, also have lower levels of income than the white population in England. Now, as striking as the data on income show, I would argue that they dramatically understate the racial gap in economic status. What do I mean by that? Well, income captures the flow of resources into the household, wages and salary, but they tell us nothing about wealth, about the economic reserves, of the financial assets, of the home equity, of the money in the bank, of the investments that individuals have. And wealth gives us something about the economic reserves that individuals have to cushion shortfalls of income. And here is national data on wealth from the Federal Reserve Board in the United States. And it shows for every dollar of wealth that white households have, black households have only 10 cents, and Latino households have 12 cents. So there are very, very large gaps in wealth in the US. In the United Kingdom, we see a similar pattern. Here is median wealth by ethnic group. And again, for every pound of wealth the white British have, Indians are close, 95 pence, but Pakistanis 50 pence, blacks from the Caribbean 20 pence, blacks from Africa, and the difference is the blacks from the Caribbean on average arrived earlier and are more likely to own their homes in England than blacks from Africa, who are more recent immigrants, and housing prices in England makes it difficult for them to own homes. Only 10 pence, and black Bangladeshis 10 pence. So what I've shown you across two societies, there are large racial gaps in health, but there are also large racial gaps in income and in wealth. What low economic status means is that although we are in the storm of the pandemic, we are in different boats. When a household does not have wealth, does not have any savings, does not have any economic reserves, they are less able to feed the family, to pay their rent. So in the context of the pandemic, some boats are better able to weather the storm than others when you have economic reserves. When my career started, most researchers thought that racial differences in health were simply a function of racial differences in income and education. And if, for example, in the United States, we looked at blacks and whites at the same level of income and education, the expectation was there would not be any differences by race. We now know life is more complicated. And I want to illustrate that with life expectancy at age 25 data. This is national data for the United States. Life expectancy at age 25. So at age 25, how long will the average person live? The average white person will live 5 years longer than the average black person at age 25. Now, let's see what happens when we look at the difference by education. We can see that whites with a college degree or more education in the United States live 6.4 years longer than a white person who has not finished high school. So by education within whites, we see an even bigger gap than the racial gap. And within blacks, by education, the best of blacks live 5.3 years longer than the blacks with the lowest level of education. So this is really an important point. And this is true for most health outcomes in the United States, although we tend to report data in America simply by race and not by race and economic status at the same time, which is what I and others have recommended should be done for decades. Because it's not either or. I want to illustrate the power of looking at data by income and race, or education and race at the same time. In the interest of time, I'm showing you just the data by education and race, but by income, you see the same pattern. What you find, although there's a large gap by education within whites and within blacks, at every level of education, race still matters. So whites who have not finished high school live 3.1 years longer than blacks who have not finished high school. And the gap actually widens, which surprises people. Most people would expect the gap to narrow as education increases, but as education increases, it widens. And this is national data for the United States. And you see this stunning example. The best of blacks in America, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who have finished high school. So what are these data telling us? There's something about income and education that matters for your health regardless of your race. But there's something else about race that matters even after we take income and education into account. And just to show you the pattern is similar for the UK, here is data I showed you before. Here for men is the age-adjusted data. And in the UK, the data is adjusted for even a broader range of variables here, adjusted for income, for education, for household type, for health status. And even after adjusted for all of these factors, multiple indicators of economic status, Black men still have an odds ratio almost twice as high as those of whites. And you can see for Bangladeshi 1.8 times, for Indians 1.3 times. And if we look among females in the UK, here was the age-adjusted data, and it's still almost twice as high for Black females after we've taken multiple indicators of demographic status and socioeconomic status into account, and 1.6 times for Bangladeshi females, 1.4 times. So in both societies, we are saying, even after we've taken the standard measures of economic status into account, we are still finding a residual effect of race. And so researchers have been asking, why does race still matter so much? And specifically, could racism be a critical missing piece of the puzzle to understand the patterning of racial disparities in health? When I use the term racism, what do I mean? I think of racism as a social system, not so much the beliefs and behavior of individuals, but a social system. You can see the arrow goes both ways. It has shaped, and it is shaped by larger political, legal, economic, religious, cultural forces, and historical events. So I define racism as an organized system. It categorizes and ranks populations. It devalues some and disempowers some. And it differentially allocates opportunities and resources to populations. Central to racism is an ideology of inferiority, that some groups are inherently better off than others. That is the justification for the devaluing and disempowering of some groups. Yes, racism can lead to the development of negative attitudes and beliefs, prejudice and stereotypes, and differential treatment, discrimination that can take place by individuals and social institutions. But fundamentally, we need to understand, I think of racism as a system, and the system has ripple effects at multiple levels of society. I want to talk about the ways in which racism affects health and some of the empirical evidence we have for a role of racism. So first, I want to talk about one mechanism of racism that is the term structural or institutional racism is widely used to capture that. And I want to illustrate that with US data using residential segregation as the example. Residential segregation was a policy that emerged in the US in the late 19th century. It was strengthened in the early 20th century, was very well locked in place by the 1940s, and has been illegal in the mid-1960s, but the structure put in place still persists. And basically, where you could live was linked to your race. Your race determined where you were allowed to live. John Sell was a historian at Duke University in America. He wrote a book about the origins of segregation in the US South and South Africa. He showed that the framers of apartheid in South Africa looked across the Atlantic and saw residential segregation in America and how well it was working in the late 19th and early 20th century and said, brilliant, we can implement that in our country. Importantly, Sell argues that residential segregation was one of the most successful domestic policies of the 20th century in America. And you would say, well, why would place matter so much? Well, this is how I think of segregation. I think of segregation as a burglar that enters a community at midnight. It slips into the community, doesn't wake up anyone, but once it shows up, valuables disappear. So in highly segregated, disadvantaged communities, valuables that disappear is quality schools and safe playgrounds and good jobs and a healthy environment and safe housing and good quality transportation and even access to high quality medical care. All of these are factors that research shows in the US vary by race. I want to give you some empirical studies. These are two sociologists at Harvard University, William Julius Wilson and Robert Sampson. They did an analysis of the 171 largest cities in the US. And they said there's not even one city where whites live in equal conditions to those of blacks. And they concluded that the worst urban context in which whites reside is considerably better than the average context of black communities. So segregation has really produced neighborhood conditions that vary dramatically by race. That now you might note that's a 1995 study, so you say, Professor Williams, how have things changed? So here's another wonderful colleague of mine, Professor Dolores Acevedo Garcia. She's a professor at Brandeis University. She created an amazing database. It's called the Neighborhood Opportunity Index. She's ranked every county in the United States and most census tracts on 28 different indicators of access to opportunity. Her focus is on children, but access to opportunity for children reflects access to opportunity for the entire community. I want to give you examples of the indicators. I don't have all 28 listed here, but the quality of schools and the quality of early childhood centers and the high school graduation rate and the percent of individuals in high school jobs and the income level and the home ownership rate in the community and the quality of the air and the water and soil pollution and access to resources for health like green space and access to fresh fruits and vegetables and safe places to walk. So it's 28 different indicators of access to opportunity. And this is what she found. And this is a 2020 publication. If you look at the 100 largest metropolitan areas in the United States, 67%, 2/3 of all Black children are living in very low and low opportunity neighborhoods. That's true of 58% of Hispanic kids and 53% of American Indian kids. In contrast, only 1 in 5 white and Asian kids live in very low and low opportunity neighborhoods. If we look at the opposite end of the spectrum, who is residing in high and very high opportunity neighborhoods, you see almost 2/3 of all white children and almost 2/3 of all Asian children live in high and very high opportunity neighborhoods. So what does this tell us? is that access to opportunity at the neighborhood level varies dramatically by place and by race in the United States. More data. I'll show you two more studies by Harvard economists that shows that segregation, access to opportunity at the neighborhood level, is actually the driver of why racial differences in income and education exist in the first place. So first, I'll look at the work of David Cutler. He's an economist at Harvard University. He did a national study of Blacks and whites in the United States. And statistically, he shows if you could eliminate residential segregation, you would actually completely eliminate or erase Black-white differences in income, in education, and in unemployment, and reduce racial differences in single motherhood by 2/3. In other words, if you step back to ask, why are there large racial differences in income, in education, and unemployment? Why have they persisted over time? Well, it's linked to opportunity at a neighborhood level. And if those opportunities haven't changed over time, you see the persistence of those racial inequalities. One last example of economic data that points to the power of segregation. Another Harvard economist by the name of Raj Chetty, he has done an amazing analysis. Using census data from 1989 to 2015, he asked an intergenerational question. Let's look at Black and white children who start out life at the same place. Their households are similar in terms of their parental income. How are the children doing in the next generation? And he finds that in 99% of census tracts in America, census tracts is a geographic unit with, several thousand, a few thousand people. In 99% of census tracts in America, Black boys have lower earnings than white boys, even after taking parental income into account. Why? They live in neighborhoods that differ in access to opportunity. Do we have a similar pattern in the UK? Not quite. There are some similarities, but the histories are a little different. Scholars who study segregation, like Doug Massey, shows that levels of segregation in Europe are increasing while they are declining in the United States. They also show something intriguing, that in Europe, Western Europe, segregation is stronger, slightly greater by religion. So Muslims are more segregated than non-Muslims. And secondly, by skin color. So religion trumps skin color in the UK context. So here is the levels of segregation. This is the index of dissimilarity. Generally speaking, a score of 60 or higher is regarded as a high level of segregation. And a score of 61 for Bangladeshis would mean that 61% of Bangladeshis in Britain would have to move to have an even kind of distribution of Bangladeshis and whites in the UK. And you can see segregation levels also high for Pakistanis, a little lower for Indians, and even lower for Caribbean Blacks, confirming the point that Massey shows. It's religion is a major basis for segregation in addition to race. At the same time, other data from the UK, although the mechanisms may not only be segregation, other data for England suggests that the disadvantaged racial populations are overrepresented in the most deprived neighborhoods. So here's national data on who is living in the most deprived 10% of all neighborhoods. So this is the worst of 10%. If the levels were equivalent across populations, you'd find whites, 10% would live in those areas. Instead, you see Pakistanis, 31% of Pakistanis live in the worst 10% of neighborhoods, 28% of Bangladeshis, 20% of Blacks from Africa, 18% of Blacks from the Caribbean, 19% of Arabs. So we are also seeing in the UK an overrepresentation of disadvantaged populations in the most deprived residential areas. An important take-home message is that the racial inequities in socioeconomic status that matter for life and health, sometimes people talk about the fact we have a broken system. And my argument is, no, we do not have a broken system. We actually are looking at the implementation of social policy, a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism. So the racial inequities we see are not accidents or acts of God. They reflect the successful implementation of social policy and what I'm calling a truly rigged system that it has produced in the United States. Segregation has another impact on health, and that another pathway, in addition to what I talked about at the neighborhood level and access to opportunity and income and education. Research, mine and that of others in the US, shows that when an individual lives in a disadvantaged, segregated neighborhood, and they are also lower in economic status, they are exposed to higher levels of economic stressors, that is, like facing unemployment or being unable to make ends meet at the end of the month. Psychosocial stressors like unemployment or the death of a loved one. Physical and chemical stressors like exposure to air pollution. So that segregation, another mechanism by which it affects health, is by shaping exposure to both psychosocial and physical chemical stressors. So I've talked about structural institutional racism, segregation. I want to touch base briefly on individual discrimination and its consequences for health. And I would argue, I just talked about stress. One source of stressful life experience that historically we haven't studied, but there's been a lot of study, I would say, in the last 25 years, is the stress of discrimination. And here is one measure. I developed a number of measures to capture discrimination. One of them is called the Everyday Discrimination Scale. It doesn't capture all aspects of discrimination, but just little day-to-day indignities. Being treated with less courtesy and less respect, receiving poorer service than others. People acting as if they think you are not smart, or if they're afraid of you, or if they think you are dishonest, or they're better than you are. Little indignities on a day-to-day basis. I want to show you the power of this measure. There have now been more than 400 published studies globally looking at everyday discrimination. There are actually studies from Brazil that have used the Everyday Discrimination Scale. And these studies find that high levels of everyday discrimination is linked to a broad range of health outcomes. I just want to give you some examples. There are studies that show that new cases of metabolic syndrome, of cardiovascular disease, of breast cancer, of type 2 diabetes is linked to high levels of everyday discrimination. High levels of everyday discrimination also lead to higher levels of engagement in risk behaviors that adversely impact health. Higher levels of everyday discrimination is linked to multiple markers of subclinical heart disease, like coronary artery calcification, or visceral fat, or heart rate variation, or atrial fibrillation. Higher levels of everyday discrimination also predicts higher levels of blood pressure and asthma. Higher levels of discrimination predicts poorer sleep, quantity and quality. Higher levels of everyday discrimination predicts systemic biological dysregulation, higher levels of inflammation, higher levels of cortisol, shorter telomere length, higher levels of allostatic load, which is a measure of biological dysregulation across multiple systems. Higher levels of everyday discrimination predicts obesity and even weight gain over time in prospective studies. Higher levels of everyday discrimination instructively predicts less engagement with healthcare and less follow-through on a healthcare provider's recommendations. And finally, higher levels of discrimination predicts higher levels of mental disorders as well as measures of depressive symptoms, anxiety symptoms, and emotional distress, and so on. So just this slide is just illustrating the multiple ways in which research is documenting discrimination adversely impacts health. Today, we now have studies from Australia, New Zealand, South Africa, the United Kingdom, and the US that shows when you look at racial differences in health and you statistically adjust for income and education, but there still is a residual effect of race, that effect is further reduced when you add a measure of interpersonal discrimination to the statistical model. So we now are documenting that discrimination, the interpersonal discrimination, is making an incremental contribution. And this is not just studies of everyday discrimination. It's only one measure. There are multiple measures out there that are being used. I also want to point to that there are hidden ways in which stressors linked to race and racism adversely affect health. So here is a study I did with a young scholar many years ago. It was the first study that looked at discrimination online among middle and high school students in the United States. And we found that the experiences they had in an online context where they were treated badly because of their race was linked to increased depression and anxiety symptoms even after we statistically adjusted for discrimination offline and a global measure of adolescent stress. So we documented that the online discrimination was impacting their mental health over and above other stresses they face. That same colleague, Dr. Brandisha Tynes, recently published a paper looking at Black and Latinx adolescents, 11 to 19 years old, and found that if they've more frequently viewed images or videos of someone of their racial group being beaten by the police, being arrested or detained by the police, or being shot by the police, exposure to these online traumas predicted higher levels of post-traumatic stress disorder, PTSD, and depressive symptoms. So we are seeing among these young people just these online exposures of someone from their group harmed by the police is adversely impacting their mental health. Here is another study I did with one of my former students. We looked at national data for the United States. We used a database for 3 years that looked at every police shooting in America. And then we linked it to state-level data for multiple states from the CDC on the mental health of the population. And using a quasi-experimental design, we were able to show that every police shooting of an unarmed Black male led to declines in mental health, not just for the family and friends, but for the entire Black population in the state in which that shooting occurred for the next 3 months. So documenting a negative effect of police shootings on the mental health of populations. What's the consequence of this? Scholars are using the term that all this stress is leading to accelerated aging or premature aging or biological weathering and the earlier onset of chronic disease. What do they mean by the fancy terms? Let me use the biological weathering. Imagine a drop of water falling from the rooftop of the building you are sitting in to the concrete sidewalk below. If water dripped today, it's not a problem. But if day in, day out, week in, week out, month in, month out, there's a steady drip, drip, drip of water, the sidewalk below would become weathered. It would become eroded by the constant exposure to adversity. And what the research is suggesting that in the United States, Blacks and Latinos and Native Americans, as populations that are studied, they are literally aging biologically more rapidly than that of whites. And so the term that Arlene Geronimus uses is weathering, but it's talking about a cumulative negative impact of repeated exposure to psychological, social, physical, economic, chemical stressors. And that these stressors are taking a toll and are leading populations to age biologically. There are studies that use telomere length that shows racial differences, 7.5-year differences between Blacks and whites of the same chronological age. Because what this is saying is that your age is not only telling us how long you have lived. Your age is also telling us how long you've been exposed to bad environmental conditions and how physiologically compromised you have become as a result of those exposures. And so a consequence of that, and I'm illustrating it with data just on high blood pressure, is that you can see age 50 to 64, but at every age, but let's look at 50 to 64, 61% of all Blacks 50 to 64 have high blood pressure in the United States compared to 41% of whites. So you see the earlier onset of disease. And what's true for high blood pressure is true for kidney disease. It's true for a stroke, for diabetes. It's true for a broad range of conditions. Why does this matter? Let's come back to COVID-19. This is a study of 12 hospitals in New York City early in the pandemic. And what this study looked at, almost 6,000 patients, is the percentage of them that had a comorbid condition. So you could see of people hospitalized in these 12 hospitals in New York, almost 6,000 people, 57% had high blood pressure, 42% were obese, 34% diabetes, 18% with heart disease, and so on. In fact, only 6% of persons hospitalized for COVID-19 had no comorbidity, and only 6% had one. So 88%, almost everybody, had two or more. And what am I saying? I'm saying one of the reasons for the higher rates of death from COVID-19 of populations is the higher rates of comorbidities that reflect the accumulation of the living and working conditions that lead to higher levels of stress, and that literally have, with these comorbidities, puts these populations at higher risk. So I've talked about racism. I've talked about the structural institutional racism. I've talked about the stress of interpersonal discrimination. Quickly, I want to talk about cultural racism and just give one example quickly of how it operates, the negative stereotypes in our culture. It leads to inequalities in medical care. This was a report from the government back in 2003 on equal treatment from the government requested of the National Academy of Medicine that documented that Blacks and other minorities receive poorer quality care than whites. Just to give you one example of the studies that this report was based on, Dr. Todd was an emergency room physician at UCLA, emergency department, and he asked a simple question. When a patient comes to the emergency department with a broken bone in the arm or leg, does the patient's ethnicity determine whether the patient gets pain medication or not? So he looked at everybody for 1 year treated in the emergency department at UCLA, and he found that 55% of Hispanic patients with a broken bone in the arm or leg got no pain medication compared to 26% of whites. And when statistically he adjusted for every potential confounding factor, the single biggest predictor of whether a patient got pain medication or not was whether the patient was Hispanic or not. He replicated the same study in Atlanta with Black and white patients, finding Black patients with a broken bone in the arm or leg less likely to get pain medication. One other quick study, just to make the point. A study of 1.8 million hospital births in Florida between 1992 to 2015. When cared for by white doctors, Black babies are 3 times more likely than white newborns to die in the hospital. This disparity is cut in half when Black babies are cared for by a Black doctor. One of the things this highlights is the importance of diversifying the workforce to meet the needs of all patients. I want to show you the power of having racial concordance. This is a randomized controlled trial of 1,300 Black men in Northern California. They were recruited from barbershops and the community, sent to a Saturday clinic, randomized to be treated by a Black doctor, someone of the same race, or a doctor of a different race. The study found that men who saw a Black doctor were more likely to talk about other health problems, more likely to do screening for diabetes, more likely to accept the flu vaccine, more likely to do screening for cholesterol. So there was much better engagement and utilization of services when there was a match in racial concordance. In the United States, we face a huge problem. In 2014, there were 27 fewer African-American males in the first year of medical school than in 1978. In fact, in the mid-1960s, 2.9% of all practicing physicians in America were Black. In 2019, 5%. So there's an increase, but it's a small increase. 5% of practicing physicians are Black, only 6% are Hispanic, and only 0.3% are Indigenous or Native American. So we have a long ways to go. There is some good news. The good news is, here is a study of cultural competence among patients with HIV/AIDS, and they found large racial disparities. However, there were no racial disparities regardless of the race of the clinician if the clinician scored high on cultural competence. I want to give you some of the items on the cultural competence scale. A physician who scored high in cultural competence is a physician who said family and friends are as important to health as doctors. A physician who said social history contributes to how I care for my patients. Someone who said, I'm familiar with the lay beliefs my patients have. So I asked them about their lay beliefs. I asked my patients about alternative therapies they use. I find out what my patients think is the cause of their illness. I involve patients in decisions about their healthcare. So it suggests that a healthcare provider who respects their patients, engages with them, talks to them, gets their ideas and their understanding, and has a useful dialogue, that disparities can be reduced under those conditions. So I've talked about racism, multiple mechanisms by which it produces inequities in health, but in other social statuses. And I'm also saying that these inequities reinforce the stereotypes and the biases that exist and go back to strengthen the system of racism in the first place. I've talked about what needs to be done within medical care. Quickly, I want to talk about, as I come to a close, the big issue is how we dismantle the segregation and the inequalities that were created in the first place. I call for the need to create communities of opportunity to minimize, neutralize, and dismantle the systems of racism that create inequities in health. In other words, to improve health and racial differences in health, we need to enrich the quality of neighborhood environments. We need to provide for economic development in poor areas. We need to include housing quality and the safety of neighborhood environments. What would communities of opportunity look like? We need to invest in early childhood programs, reduce childhood poverty, enhance income and employment opportunities, improve neighborhood and housing conditions, enhance economic opportunities, raise awareness levels of these problems. There's high quality evidence, I don't have time to review them, that in providing additional income with no health intervention, we have randomized controlled trials, shows among poor populations, you get improved health, even with no health intervention. I want to talk about one example in the US of neighborhood intervention. It's called purpose-built communities. And I cite it not because it's perfect, but because it shows it can be done. Many policymakers I talk to think the problem is so complex, it's so complicated, there's nothing we can do about it. So come with me to East Lakes Meadows, Atlanta in 1995. It's a public housing project where there's a huge crime rate, 18 times the national crime rate. 90% of families are victims of crime every year. It's poor public housing, many units unlivable. Only 13% of adults are employed. The elementary school is one of the worst performing in the state of Georgia. And what happened in Purpose Built? They came together with the community, the public housing department, and a wealthy philanthropist, and they tore down the public housing project and built anew the villages of East Lake. 50% of the people living in the village of East Lake qualify for public housing. 50% are at market rate. There's been a 90% reduction in violent crime. The high quality mixed income housing. All able-bodied persons are employed. And the school, elementary school, is one of the best performing in the state of Georgia, even though 60% of the students qualify for reduced price lunch. That means 60% of them are coming from poor households, but yet the school is one of the highest performing, one of the top 5 in the state every year. It shows it can be done. We can address all of the challenges faced by poor communities simultaneously. we can develop place-based solutions, we can improve housing and provide the services to improve the quality of life and housing. What do we need to do to while we wait for all the great solutions? Let me talk about some evidence of individual and community resources that are resilience factors. So first of all, here is a study from Georgia. Teenagers, Black teenagers, aged 16, 17, and 18, they were studied. Those who were high on discrimination at 16, 17, and 18, by age 20, they had higher levels of stress hormones, cortisol, epinephrine, norepinephrine, higher levels of blood pressure, of inflammation, and of BMI at age 20. However, that relationship between discrimination and the biological dysregulation is broken if they were high on social support, high levels of support from their family, their friends, their teachers, documenting the protective role of high quality social resources. Here is another study, national data for the US among Black Americans. Those who were high on religious involvement, religious attendance, church-based social support, seeking religious guidance, it reduced the negative effects of the stress of discrimination on mental health. So again, social ties as a positive resource, religious engagement for religious individuals as a positive resource. And final example I want to give you is from Canada, First Nations or the indigenous population in Canada. This is a population that had very high rates of youth suicides. Researchers went to study this group. Here is communities with high rates of youth suicides, and they studied 196 of these communities. As a group, they have high rates of suicide, but the researchers found that more than half of them had had no suicides at all over a 5-year period. And so they wondered what distinguishes those communities with high rates of suicides from those that didn't have high rates of suicides. And they found 5 markers of communities that were challenging the federal government over titles to land, over the right to self-governance, over controlling their schools, their police and fire service, and their healthcare, and that had a place in the community where they celebrated their culture and taught young people their culture. What they found was that each of these indicators of advocacy, protest, empowerment, and cultural affirmation was associated with lower risk of youth suicide. And the more of these, a dose-response relationship between the number of markers of advocacy, protest, empowerment, and cultural affirmation with the prevalence of suicide. So actually engaging disadvantaged populations in advocacy, protest, empowerment, and celebrating their culture seem to have positive effects, at least on their mental health. What is holding us back? We need empathy. And I'm going to close on the point of empathy and just end here on what we need. We need not equality, but equity. Equality says, let's give everybody the same thing. You see? But everyone is not starting out at the same place. So giving everyone the same thing does not help to meet the needs of everyone. Equity is saying, let's give everyone what they need in order that they can thrive. And what we need is to move less from equality and looking at where populations are and think of equity. Martin Luther King said, true compassion is more than flinging a coin to a beggar, but it understands that an edifice or building which produces beggars needs restructuring. I'm saying to you today that the inequities by race in the UK, in the US, in other societies are driven by edifices that are producing those inequities, and we need to work together to, in fact, restructure them. Thank you so much for your time and attention today.
Thank you, David. This was just superb. The results are depressing because that's how life is, but your research is just superb. And, you know, as you were speaking, what can be done, and you showed what happened in those communities, I keep thinking, you know, what society are we where people are willing to pay $55 million to spend 8 days in a space? And I keep imagining how many communities we could improve if instead of spending 8 days in a space, people would look to the side and see how much good they can do for their neighbors. But, so let me just confirm one thing. Do you have 10 more minutes or you
yes,
have
time.
Okay, good. So I want to raise a question. I mean, I have a million questions, but I'll just raise one. And I wanna ask you how much this work you've done have been linked to epigenetics. And there is one faculty in our school that he has developed what he calls the biological clock. And I keep asking him, you gotta do some kind of study where you go to vulnerable communities and you do this biological clock and you see how much people are really losing in terms of years or the age you have right now because of the stresses, the vulnerabilities, the discrimination that people go through life. So are you aware or are you engaged in any studies that link this body of research you showed to us to epigenetics?
I haven't, but I do believe historically, when research was done in the 19th century, early 20th century on racial differences, the knee-jerk assumption was that any racial differences was as a result of underlying gene frequency differences. There were different racial groups had different sets of genes. In fact, some beliefs were even that a disease in one group might actually be different in another because of the genetic differences between populations. I think the data is clear, and I don't have time to review it, that no, the gene frequency differences are not an important driver of the racial differences we see. At the same time, there are likely to be large epigenetic differences. And when we talk about epigenetic differences, it's just going back to my point that our body keeps a record of what we've been exposed to. And if I'm saying that race, in fact, in part, reflects populations living under different environmental conditions, biology is not static. Biology is adaptive to the environmental conditions under which we live. And so we should find epigenetic differences. There is a more discussion of this in the literature on race and health. There are good, review papers that make a case for it. We do not right now have a lot of evidence. There are people talking about both epigenetic differences or microbiome differences that we might find in populations. I think it's an emerging area of work. The closest we have come to that, I think, is the studies that are looking at biological aging differences. Some have just looked at, measures of physiological dysregulation at age 55 to 65 and compare different groups. And one study done by Arlene Geronimus shows the average score that whites have at 65, blacks have that score 10 years earlier. And so there's a 10-year difference in biological dysregulation of persons in the same society. And there have been a few studies that have looked at telomere length, which is looking at a measure of aging at a cellular level. So I think there is more interest and work in that area. I haven't personally done any work in that area. I've done work looking at allostatic low differences, but not at epigenetics. But that is certainly a frontier of important work that we need to understand. There's also, I should mention, some interest in even the intergenerational transfer of exposure to some of these adversities, particularly for the indigenous population and some of the experiences that populations have had. And there's reason to think so. There's studies of survivors of the Holocaust in Germany that have documented epigenetic changes that puts individuals who went through that experience at higher risk of PTSD, and they find that they have given that epigenetic effect a change is also found in their offspring. So it's a reasonable hypothesis that there could be intergenerational transfer, but I would think not enough has been done along racial ethnic differences, although people have written about it.
Okay, you use an expression, the toxic stress, and that's the same we use for early childhood development. Absolutely. And I think that brings some hope, because there's all this discussion that despite the toxic stress, the brain has a lot of plasticity. So it's not that you can recover 100%, but you can recover some. So I think that brings a lot of hope that, you know, if we do the right thing, I think we can remove a lot of this difference.
Yes.
Lorena, do we have questions from the audience? Oh, Vera, go ahead.
Yes. Thank you, Professor Davis. It's an honor to hear you, and all the people who work with us in the peripheries of São Paulo with young people are just hearing you, and with immense pleasure and honor to have you with us today. And I wanted to just do some comments that I heard from them. Okay. One is that all of us who are doing this work around the peripheries of São Paulo and Sorocaba and Santos, 3 cities, among young people, see exactly what you're describing, right? In everything, every single thing you're describing, we are observing and trying to intervene over it, right? The main issue that we were discussing since the morning is facing COVID-19 is that the lack of community mobilization in the response to COVID-19, right? And many of us came from the AIDS field, HIV/AIDS field, to the COVID-19 field, as myself, right? And there was a tradition of community organization through identities, right? And a way of building identity groups and including Black people, Black women, gay people, right? All kinds of identity groups. And the spread of this disease is totally connected to the, as you called, the segregation of neighborhoods, right? If you know Brazil, you know that poor people and Black people are segregated far away from everything else. They are out of the access to opportunities, and I love this point you made you brought in your to our conversation, right? And some of the communities we've been working with, like the favela of Heliópolis, have done some of what you're talking about, and including mobilization, right? Yeah. So mobilization is good for your health, right? Yeah. And anti-discrimination education, and it's good for your health, and we have this improved. So my question for you is, do you agree that territorial organization, neighborhood organization, especially in COVID-19, it's very much important, and that's the way we should go to hear people and bring them to the response as a community organization, as you were talking about. So do you think COVID-19, in other words, made the point, right, that segregation and neighborhoods and access to opportunity investments should be the way to go to defeat inequality, inequity, and
I completely agree. I think we need policy change at a higher level to equip either local community individuals with resources. But yes, I mean, one of the things, even I think in the US, the COVID-19 and the vaccination hesitancy, there are many drivers of it for different population groups. Some of it is political. Some of it is more of a trust issue. And one of the things that happens when you have individuals from the local community, one of the issues is having people you trust. And I heard the example when I joined the panel early of the Native American community being so high, and it's because there were people who the community trusted saying this is good. And I think that's one of the things that needs to happen. It is happening in some places in the U.S. where there is an effort to get local pastors more involved, local people from the community that people would trust. Because trust is an issue for populations that have been treated badly by society. I mean, they don't trust what the politicians say, what the political leaders say, what they necessarily hear on television. So I think one of the things that is the empowerment and involvement at the local level can in fact play an important role. But at the same time, we have to find ways that we can give them resources that can really transform the living conditions at the local level.
Yes. Thank you.
Loriana, you have a question?
Oh. Yes, my microphone is, so it's an amazing honor for us to have you as part of this meeting. I think so much of what you've said today, you've given us a lot to reflect on and think about. We're really, it's very beautiful to hear your comments, because one of the things why we wanted to do this event is we've thought a lot about concretely, the point of all this suffering is to come out of this experience more with a stronger conviction of the type of society that we want to build moving forward, instead of reinforcing the society that we entered into this pandemic. I'm wondering a little bit in hearing you talk about and hearing you think the comments you made today. I think one of the things that we haven't talked as much about is in what you were talking about, some of these interventions. Perhaps if you could talk a little bit about what was the role of the public policies and was it really critical, for example, in the community that you talk about the turnaround? You mentioned the major donation, but I think part of it is also that there was a major change in terms of public policies changed also to try to come together with a donation to mobilize and to think about this intersectorality. I'm wondering if you're seeing that in the COVID response, we're seeing those types of collaborations come together. So are you seeing that there's progress in terms of our governments partnering in the US and in the UK, where you're speaking more specifically, but is there a lot of collaborations between community organizations and governments to be rethinking some of these strategies and be rethinking things? You mentioned vaccination and how this is a really critical area, but I think there's a broader issue that you're talking about. We need to restructure the society we want. And how do we start that conversation around COVID is very hard to do. So I'm wondering if you've seen any seeds of hope of who's doing that, who's having those conversations, and where can we look to as some kind of guidance of where are those light posts that we can look at of people that are leading the charge?
It's a really, really good question. I think it's also a really important question. I think there are few examples. I think, if we look at the COVID in the US context, and I think to a great degree the UK context, it's really heavily driven at a national level by what is being done, and maybe less in the US, in addition to the national level, the state level. There are some initiatives I have seen of really involving community groups and using familiar community sites like churches as the places where people will come to, or establishing a fear in the community, with a local organization, and people come to have fun, but they also have available the vaccines there. So I think there are some examples, but I think by and large, the system is still, the National Health Service they were so stunned by the racial data in the UK. By the way, someone had said only the US. The UK also collects racial data. Its census does, but it only started in 1991. Prior to 1991, the British census had never collected data on race. But since 1991, every 10 years, it collects data on race. But in the US, when I work with colleagues in the UK, in the US, we report data on race all the time. In the UK, they seldom report it. And that's why they were so shocked by these findings, because they do not routinely report data on race. So, but they're trying to reform that. They have created what they call a Race and Health Observatory. And I am the only non-British based person on the observatory, where they're trying to, what are the rules for data collection? What are the rules for data reporting? What are the solutions in the area of mental health and the area of maternal child health? So they're really trying. They've put 10 million pounds was given to this organization to try to map out the terrain of race and health in the UK and to point to where do we go from here. I would say, as of right now, it's at the national level, it's fairly British. We have are trying to think of solutions and how community can be involved, but I think the government focus is on really at a national level, what is the problem and where are the solutions? And primarily looking at the health policy solutions, what does the National Health Service have to do differently and so on, although it's clear that there are things that needs to be done with the delivery of care and quality of care and access to care. But if we don't change the underlying living and working conditions that give rise to the problems in the first place, it's putting a Band-Aid on. It's not getting at the underlying thing. So I would agree with you that I think the long-term solution lies in the empowering of communities to work collaboratively with others, but they need the resources. So that's why they need partnerships, either with government or civil society. I would say in the US, but I don't know what will come of this. In the US, there are a number of, I don't know what the term used in Brazil, but foundations that have said they are making racism a priority for funding. And not just the Robert Wood Johnson Foundation is saying racism in health is going to be a priority for funding, and the Kellogg Foundation and other Ford Foundations saying racism are priorities. They tend to work more with local community organizations, but exactly what will grow out of it, I think is still to be seen. But I would agree with you that long-term solutions lie with community involvement and community buy-in and community engagement. I think is important to the long-term success.
Yeah, and interesting enough, David, we saw some of this mobilization in Brazil in the communities, the slums, that people organized themselves and they created ways of replacing the lack of the community health agents, and it worked. I mean, that's the thing. We need to give visibility of those initiatives that happened in completely adverse conditions, and they saved many lives.
Right.
And especially at a time when literally, as you showed, it's the same storm, but people are not with the same kind of boats to be able to navigate. And especially, I mean, if you look at a country like Brazil that, it's highly unequal, if you have a government that doesn't have the word inequality in its agenda, and we are leaving a government that doesn't have the word inequality in its agenda, either it comes from the community. Hopefully those people stop going to space and put the money into help the community, or I don't know how it's going to happen. And, I think that's a big challenge we have as a society, how we make things happen literally from the bottom, create the momentum, and then it becomes abolished. But
the other point, and I probably need to leave in a couple of minutes, but the other point, that I think is so important that you just made, and I didn't elaborate on this, but one of the big challenges I think we face is how we build the political will. How do we get the general population to value the degree of inequities and actually to see that these inequities are costly. There have been studies done in the US, and we thought there would be, if you showed people the racial inequities in America is costing the United States government, costing the society something like $300 and something billion a year. That's what it costs. And most of that cost was not additional healthcare expenditure. Most of that cost was lost productivity. If you're looking at people losing their lives prematurely, early, in the most productive areas of your life, it's hurting the economic productivity of the nation, it's hurting the global competitiveness. So making an economic argument. But while, people listen to it, I don't think it's moving the needle. And the real big challenge is, how do we get people to care? Scientists are talking about it as an empathy gap. And that is, you are not moved to political action. You're not moved to say this is unacceptable in our country if you don't feel the pain that others are feeling. And what the research in America shows is that for most Americans, when they look at the plight of the disadvantaged, they blame them for it. So, for example, studies show that more than 50% of white Americans say all racial inequities in education and health and everything could be solved if blacks only worked harder. So it's their fault. They're not working hard enough. They don't have the right values, and that's why we have the problem. So if you see the problem, no, you don't have to do anything about it if people are bringing it upon themselves. So to me, one of the challenges we face is, how do we tell the story of the plight of the socially disadvantaged groups in our societies in ways that people emotionally connect with it? The research shows that if you feel empathy, if you emotionally connect with the problem, you'll say this is unacceptable, I have to do something. And so I've said that one of the things those of us in the health field need to do more of is to work with communication experts and work with political scientists so that we can better, and psychologists, of how we can better tell the story, because studies in producing empathy sometimes says you can take the same story, by changing 3 or 4 words, you produce an empathic response, whereas the basic facts don't produce it. So how do we get people to care? How do we get people to feel the pain? I think is one of the big challenges, because if people feel the pain, they will say, we have to do something.
Absolutely. And we cannot end on a better note. We started highlighting the need for trust, and we end the day with the need for empathy. And if we can achieve a little of those two things, we would be better. Thank you so much, David. This was terrific. Thanks for bringing light to those problems. And I hope to see all of you tomorrow for the second day of this event. Have a good night.
Bye-bye.
Good night.